talk.
Okay.
After he finishes, then he will say over to Janika.
To make it happen last year and this year also. And
No, this will be bigger than last year. You see.
and sir, the response from all the colleagues are extremely good, sir. Matlab they are,
Yeah.
we have one doctor who is very old from Kolkata, so he is also saying that I am a big fan of Dr. Janki Ram, sir. Thank you, sir. Thank you very much.
Welcome, welcome.
Okay, sir, we'll start within few minutes, sir.
Yeah.
10-15 minutes. We'll start, sir.
Hello. Hello. Good morning, Dr. Jankiram. Hello.
Hello. Hi,
Hello.
Janki sir. Can you hear us?
Yeah.
Yeah, sir, want to talk with you, sir. I hope so you can hear.
Good morning, Dr. Jankiram.
Good morning, sir.
Good morning. I have come from Calcutta. I'm 79.
Oh my God.
Can't you recognize me? Papa कहता है.
So nice, sir.
I have
So nice.
come here over from Calcutta to see your operations.
Sir, all your
I
blessings.
am very much fan of you.
Thank you so much, sir.
That's
Thank
the
you so
reason
much.
whenever I found you, you are walking, I do come. I went to Goa, I went to Hyderabad, again I came to Bombay.
Thank you, sir. Thank
That
you.
I know you, that is Papa कहता है at Calcutta.
पापा कहते हैं.
Hello. Hello, Chennai. Shankar.
हाँ सर बोलिए सर.
Yeah, Shankar, just we are starting.
Okay.
Camera na focus to sir.
ओके सर अभी कर रहा हूँ.
Thank you, sir.
हेलो.
Yeah, we can see that. Just focus to sir na. That's it.
सार फोकस பண்ணு.
Yeah.
ஆமா. हेलो.
Yes, Shankar.
सर 2 minutes sir.
Okay, fine.
Presentation is there sir. We are sharing the presentation.
இல்ல சார ஃபோக்கஸ் பண்ணுங்க சார்.
Just
சார ஃபோக்கஸ் பண்றாங்க சார்.
Shankar, just we are starting welcome address from here, and then after basically you can start the presentation. Yeah, just 1 second.
Good morning, sir. Dr. Archana from this side.
Very good morning.
Good morning, Janki sir. Good morning, Mohan sir.
Good morning. Good morning, Archana. How are you?
I'm good, sir. How are you? Both of you. Actually, I need to.
Good morning, Mohan sir.
Good morning, Janaki. Good morning. I think we'll survive.
We will not survive, we will rock.
I hope you're right.
So we have induced the patient.
Yeah, we have. We are ready. Whenever you are ready, we are ready.
So actually, we are waiting for Kitane sir. He's
No,
around.
no problem. No problem. No problem. No hurry. No. Try goes.
Team is conveying, sir. So we'll take around 10 minutes.
Take your time.
Will that be okay? Or
Yeah, we are fine. We are fine. No hurry at all.
Doctor,
Yes, sir.
if he's taking 10 minutes, then I think I will start and then let him come and talk. It's better because,
Sure,
patient
sir.
is
Even-
induced.
How
Young
much time
child.
we have, sir, in hand right now to start?
No. We have to start because patient has been induced and sir is ready. So,
Very true. Very true.
so I will just talk and then Professor Kirtane, when he comes, let him talk.
Sure, sir.
You
That
should
is
not
fine.
make a small baby under anesthesia wait. Not a great thing. Ask Sun Pharma to.
Just give our medical head will.
Yeah, you ask him to start, and then I'll give a.
Yes. And
few
then when
words of
sir will
introduction.
join, then we will officially
Yes,
immediately
yes.
take it.
Yes.
Yes. Thank you.
Hello, good morning and welcome all. Dr. Amey Mane from Sun Pharma. We welcome you all to the season 2 of India's elite ENT club. Today is a very auspicious day. I think it's a privilege for all of us to learn from the doyens in the field of ENT. We'll be witnessing, learning more about the surgeries from the stalwarts of the ENT. And without further ado, I would like to invite Professor Janaki Raman to take forward the proceedings.
A very good morning to all of you. It's a pleasure and honor to be a part of elite ENT club. So first of all, when I was discussing with Sun Pharma about a program to be conducted every year, I was discussing how to propagate academics through the well-known top-notch surgeons of India. And we were actually planning to decide what name we should, keep for this. And the name was decided as Elite ENT Club. Why elite? Why the word elite? Elite not only stands for the people who are demonstrating, but it stands for the people who have come in large numbers and have participated in this program. Without the participation of all these elite ENT club members, this group would not have formed. So we conducted the first season last year, and we had 5,000 doctors watching this, which is supposed to be one of the big numbers in this, specialty. Now, we are going to start this program for 2 days, and this will run every year. This time, Royal Pearl Group of Hospitals joined hands with AOI Mumbai West to bring this program to you. And we have the doyens of the field demonstrating. I want to highlight on the people who have accepted to demonstrate their cases from their respective centers. First is Professor Mohan Kameshwaran. Padma Shri Mohan Kameshwaran sir doesn't need any introduction. He is the father of implant surgery in India, and I have learned a lot from him, not only in the field of ENT, but how to stay humble after receiving the highest coveted awards. He is a very friendly gentleman, and in fact, I had the opportunity of inviting him to our center to Trichy to operate on a few implants, and the ease with which he does the implants, believe me, is unbelievable. He has got command over the middle inner ear and implantology. And so we couldn't think of any other person to demonstrate implants other than Professor Mohan Kameshwaran. Thank you, sir, Professor Mohan, sir, for always being there for us. And I have the greatest respect for you, not only as an ENT surgeon, but also as a great, affable human being. I have learned how to be humble from you, sir. Thank you so much.
Thank you so much.
We have the next doyen, Professor Vijendra, who is another big doyen in the field of middle ear surgery. He is the student of Professor Mahadevaya. Mahadevaya is the father of middle ear surgery in India, according to me. And Professor Vijendra is a person who is willing to teach. And he actually teaches from his heart. You know, some teachers teach from their lips, some teachers teach from their heart, and Professor Vijendra teaches from his heart. And when he does the surgery, he tells all the nuances of the surgery, step by step, so that everybody in India can, all over the globe can follow his steps so easily. Thank you, Professor Vijendra. He's going to demonstrate a very interesting case of facial nerve decompression. And we're just waiting to watch you, and also your share, young lion, Dr. Vinay Vijendra is also going to demonstrate today. We are actually eagerly waiting for that. The next doyen in the field of ENT who is going to demonstrate is Professor Milind V. Kirtane, Padma Shri Professor Milind V. Kirtane. I have had the opportunity of being his student. And again, there are two people I look upon to when I see India and being brand ambassadors of India, throughout the globe. One is Professor Mohan Kameshwaran. When we go and tell in the US or in the UK or wherever, I'm the student, I just don't have to introduce my name. I just have to say I'm from India. And then the next question is, do you know Professor Mohan? Do you know Professor Kirtane? This is what usually people ask. And after that, I just have to say I am their student. And then I get all the credit. After that, I get all the credit. It's like that. So there are two people who have actually made India very proud by their presence in our country. And Professor Milan V. Kirtane, I was a student in KEM Hospital. I started my journey when he gave me a case of fascia lata harvesting, and I took it like a cribriform plate. So I could see his face through the fascia, and he said, Janakiram, I don't think you will be a good skull base surgeon. And, that's how I started my journey. But then I determined myself to, improve on my skills. And this is just to say that if you have determination, you can definitely reach. And we should have teachers like Professor Kirtane. And in the morning, I used to see a clival tumor. In the afternoon, I used to see, a CSF rhinorrhea. And in the evening, I used to see a pituitary in Kambala Hospital. I used to just run behind Professor Kirtane sir. And Kirtane sir is another great personality in the field of ENT. And we are proud to have him here as one of the faculties. Now, the next faculty would be Professor Deepak Haldipur, a very nice, affable gentleman from Bangalore. And I always call, is the K. Balachandar of ENT. The reason is he directs very well how to conduct programs and, also a very good surgeon. He's going to demonstrate a case of endoscopic sinus surgery. We have Professor Nupur Kapoor Nerulkar. What a sweet, I can call her a nightingale of India. She is such a beautiful, fantastic, fine surgeon. If you look at her surgery, we will actually be in awe how a person can handle tissues so gently. And I always, love to see her surgery. And last time when she operated, I got a lot of feedback from all over India and the globe. Please ask Dr. Nupur to demonstrate again. It's a fantastic surgery she did. Of course, the last, just the youngest and the most inexperienced out of the lot is myself. I will be trying to, live up to the expectations of my teachers. All of them are my teachers. And we'll be demonstrating on Sunday. So this program is on Saturday and Sunday. And I think the cases have been put forward to you. I have to tell a few words about Sun Pharma. Sun Pharma is committed to academics. And I don't associate with a company which is just, whiling away their time. This is purely an academic program. And last year also we had 5,000. This year we are expecting 8,000 ENT surgeons in 120 centers. And I'm sure that this program is going to be a very, very, very big success. And but with the stalwarts like Professor Kirtane, Professor Mohan Kameshwaran, and many others, I don't see any doubt why it should not be a very big hit. Without much ado, because the patient has been already induced, I am going to give the mic to Professor Milan V. Kirtane, who is my teacher, and he will be introducing the program to you. And over to you, Professor Milan V. Kirtane, sir. Good morning. I can see you all fresh and right from the badminton court. And I am jealous of you, Over to you, sir.
Hello, Janki.
Yes, sir.
Can you hear me?
Of course, yes. Thank you.
Yeah, I can see Mohan already, and people have now come into the auditorium to see his surgery. Before we start, since you've already talked about the program and Sun Pharma, I don't have to do that. But I just need to introduce one personality at this program, and that is one gentleman called Dr. Narayan Jankiram. Managing Director, Royal Pearl ENT and Skull Base Institute, Trichy and Hyderabad. Janki is a versatile, dynamic, and if I may use the word passionate, world-class renowned surgeon. He's a ranker all throughout. Feels proud and fortunate with the fact that he could learn as he says, from a guru like me, but actually it's me who's learning from him when I watch his surgeries now. It's really fascinating to see this young man who's invited as operating faculty in various national and international conferences. I don't know how many different countries he has demonstrated surgery in. Besides that, he conducts free camps, online YouTube channel, which is like a ENT encyclopedia. It's free online platform. Education, I feel, should be free, and knowledge becomes your power only if you share it. Knowledge is not knowledge unless you share it, and that is what he has been doing passionately. He's an international pioneer in the field of endoscopic management of extensive sinonasal and skull-based tumors. It's fascinating how easily he goes around removing these complicated tumors. He's had numerous honors, awards, just to mention the recent one, Best Teachers in Rhinology Award in the 17th Otolaryngology Conference in Dubai, March 22. And in spite of all his accolades and achievements, he still remains an extremely humble, down-to-the-earth ENT surgeon, a friend to all of us. Janki, thank you for putting this program together. And without further delay, let Dr. Kameshwaran now go ahead with his demonstration of cochlear implant surgery. Mohan, over to you.
Good morning. Thank you. Thank you very much, Milind. Lovely to see you. You're looking as fresh and dashing as ever. I hope you're all able to hear me.
Absolutely, clearly. Go ahead.
Okay, great. Excellent. We have actually, they told me I have time from now till 12:30. So what we've done is we've got 1.5 cases ready, which means that we'll be showing one cochlear implant completely from first step to the last step, and the second one with some modifications, just the important modifications alone, so that we'll have time correctly to show these two cases. My second case is being simultaneously prepared and worked by my colleague, Dr. Raghunandan Sampath, who is himself a very versatile skull-based and neurotologist. And he is going to be preparing the next theater ready so that we don't waste any time. So thank you very much to Sun Pharma, to Janki, and to Milind. It is always a pleasure to be a part of this academic program. And Janki, you're very, very kind, in your introduction. But as Milind said, I think one of the greatest, pleasures for us is to see a student who's, excelling in everything. And that's the greatest honor for a teacher, and take great pleasure in watching your growth and the way, you have brought accolades to the country. So very proud of you, Janki. Keep up the good work.
Thank you, sir.
So I'll just start before I start, I think Raghunandan is going to be sharing the details of this case. So over to Raghu.
Thank you, sir. Very good morning to all of you. Greetings from Merv, Chennai. This is Dr. Raghu here. So we start with an interesting case this morning. So I'll just briefly share the background of this child. So this is a 2-year-old child who was brought with complaints of bilateral congenital profound hearing loss with speech and language delay. And the usual workup was done for this child. The basic history showed that there was no history of consanguinity. The child had normal birth weight. The only problem that happened during labor was that the child possibly had meconium aspiration. There was a premature rupture of membranes, due to which the child had to undergo an emergency cesarean section. Perinatal history was quite normal, and the child did not go into NICU or intubation and slowly recovered except for mild chronic stress with some jaundice which settled over a period of time. So, of course, these are little warning signs which could possibly make us think of a background with regards to why the child had bilateral profound hearing loss. Otherwise, child was systemically normal. We did a thorough ENT audiological evaluation as always. And of course, the rest of the ENT examinations was normal. There was no associated syndromes that we could identify. As usual, the audiological test battery was done. We can see that there is bilateral profound hearing loss on behavioral audiometry, normal mid-ear, absent DPOAs, and Vera was absent to 90 decibels of stimulation. So, and we also did a thorough speech and language evaluation. Incidentally, the child had developed some motor milestone delay, and along with that, the child had some hypotonia, generalized hypotonia. And looking at the scans, we could find that there is a slight incidence of increased intraventricular pressure. In fact, if you look at the IAMs on both sides, it's looking much more bulbous than a normal IAM. The inner ear anatomy was absolutely normal. The middle ear looked normal as well. And we had a complete.
Sorry to interrupt you, sir. Sorry to interrupt you. The slides are on the first slide itself currently.
Okay. I'll just recap. Are you able to see the scans?
Hello. We can see the.
Yes. Wonderful. So until then, it was just the history. Now I've just come to the first image. So the only thing which we picked up on a CT axial section of the child showed that there was a little bulbous nature of the IAM on both sides. And there was also some effacement of the ventricles, possibly suggesting there is some increased intracranial pressure. So what would this warn us? Possibly there is a risk of CSF leak. So we are completely prepared if we suppose encounter that. And we have prepared for the backup electrodes as well. But since the cochlea is absolutely normal, we are proceeding with a normal array. And with the backup, if there is a CSF leak, and Professor Mohan will actually show you the steps that we take for managing CSF leakage. So this is the most important cut, as you can actually see the round window niche here. I hope that is seen very well on the hand there. That's where the round window niche is. And in practice, we always ask our implant fellows to calculate the cochlear duct length and also look for the cordofacial angle. So that's important, good practice for us to judge the posterior tympanotomy in anticipation to overcome any obstacles on the way. So this is the report. There was no significant abnormality in the middle ear or in the inner ear, but possibly there was some dilatation of the IAM. You can see more CSF around the nerves in the IAM. All right. So I'll move on to the live surgery. We can change the image to Professor Mohan Kamishnan, who will start with the surgery. Thank you.
Thank you, Raghu. 15 minutes.
So can we interrupt for a moment, please?
Yeah, please.
I want to invite and introduce the panelist here.
Hi, morning everyone. This is Dr. Vijay Kadam. I'm the medical advisor from Sun Pharma. So I take honor and pleasure to invite our today's panelists for this session. Dr. MVSS Bapara, who is a senior ENT surgeon from Visakhapatnam, practicing for over 1.5 decades. His interest is in the area of anterior skull-base surgeries, laser-assisted ENT surgeries, cochlear-associated OSA surgeries, and who has won the several awards and presented in various ENT conferences and the workshop. He is presently the honorary secretary of North Coastal Andhra ENT Surgeon Association. So welcome, Dr. Baparao. And the second panelist, Dr. Panilappan sir, who is the MS DLO, done MBBS and DLO from Madurai, Chennai, who is currently has his area of interest is basically in the these ENT surgeries, and has done over 100 cochlear implant surgeries and 150 mucor debridement surgeries, and got 2 MS ENT seats every year for teaching Government Medical College. Acted as MCI inspectors in Calcutta. We welcome Dr. Paliyappan sir as a panelist for this session. Welcome, sir. Over to you, sir.
Please take over.
Hello.
Yes, sir. Please take it over.
Hello, Mohan sir.
Morning, Paliyappan.
Sir. Okay, sir. Now the.
Good to see you and Baparao both together.
Yeah. Good morning, sir. Morning.
Morning, Baparao. How are you?
Fine, sir. Thank you, sir.
Good to see you.
Your session, sir.
Always a pleasure to see you both.
So the incision, sir?
I've just made I'm doing a classical, step-by-step implant.
Yes, sir.
Raghu will probably be showing you a minimal access procedure later on. But my idea is to show a very traditional, classic procedure. So I've done a post auricular first incision is through the hairline here, a lazy S, an extension superiorly, and this gives a nice access to create a good bed because it's what I want to do.
Yes, sir.
I'm a little old-fashioned, traditional guy, so stick to old. So now that we have listening, now I'm going to lift up a musculoperiosteal flap, which is anterior base flap. This is the Palva flap. It's named after Joseph Palva, who was one of the very eminent otologists of over 100 years ago from Finland, and he is considered the father of otology in Scandinavia. And he developed this flap, interestingly, for mastered obliteration. But today it's a really important workhorse which we use for all kinds of implants, not only cochlear implants, but even for brainstem implant, for middle ear implant like vibrant sound bridge and so on, for envoy team. So it's a very, very versatile flap today, which is because of the fact that it is a very vascular flap.
It's anteriorly based.
Anteriorly based. But then you can have, various other models. You can have inferiorly based flaps. You have superiorly based flaps, all sorts of flaps. So each one has got a name also.
Yes.
Somebody calls it Singapore flap, Hong Kong flap, but these flaps were there before Singapore or Hong Kong came actually. So many, many years old. So the important thing is to make it as broad-based as possible, Karapu.
So, there are thousands of students also attending this virtually. For their benefit, I will like to ask one question.
Yeah, please ask.
While selecting the patient, do you have any criteria or you have any guiding pearls for the students?
Can you say that question again? Question? Do I have?
While selecting the patient for the implant.
How do we select? Okay, that's a huge topic, in fact. First criteria is that the patient audiologically is found out to have profound hearing loss or severe hearing loss, where the benefit from hearing aid is not sufficient. When you say not sufficient, it's not enough to give normal speech development. So that is the first criteria. And the second, of course, is that radiologically, you work up the anatomy and make sure that the anatomy is normal. That the child should have workup regarding any syndromic association. So in short, there are 5 questions that you have to ask yourself. First question is, has the child got a hearing loss? If so, how much is the hearing loss? Is it benefiting from hearing aid or not? The second question is, if possible, where is the hearing loss? What is the location of the problem? Is it in the middle ear, inner ear? Is it in the cochlea? Is it in the retrocochlear region? Nerve? Central connections? So where is it? The third question is, what is the cause of the problem? So is there a genetic cause? Is there an acquired cause? Not always possible, but try and elicit it. The next question, of course, is is there any benefit at all coming from hearing aids in this patient? And finally, is this a standalone problem or is it part of the syndrome? So you need to not only work up the child's hearing, but the child as a whole. So you need to look up all the systems. It could be part of Jervell-Lang-Nielsen syndrome. So you have to look at the heart, conduction of the heart. It could be part of an Usher syndrome. So look at the eye. It could be part of the Pendridge. So look at the thyroid profile. So you need to work up the child completely, not just the ear alone. So once you have all these questions answered, then you have worked up a child for a an implant, and be ready for it. So this is in short, I think, a summary of
Thank you so much.
how I would appreciate. Yeah.
Thank you so much.
Mohan sir,
Yeah.
regarding emissary vein, please.
Yeah. See, actually, we had a little bleed here from the emissary vein, but a very small emissary vein. It wasn't a big problem, but sometimes it can be a big problem in a child. This kid is 10 kilos, not so bad. So 10,
Left hand is in the way, obstruction.
yeah, 10 kilos
Yes,
means
okay, sir. Great, sir.
the blood volume is roughly about 750 ml. So if you lose about 75 ml, it indicates you got a 10% blood loss. Elevator. You have to be careful about your blood loss in a small child.
What to do when there is a bleeding?
Well, there's many things you can do. First thing is to put your thumb on it and make sure that the blood loss is controlled.
Okay, sir.
And then after you've done that, then you may have to either use a diamond burr
Yes, sir.
or monopole. It's a venous bleed anyway, so you don't have to worry too much about it. The low pressure bleed.
Either diamond burr or?
Diamond burr, monopolar cautery.
Yes, sir.
All this like I'm doing now. It's also small emissary veins here.
Okay, sir.
Okay. Stitch. So I've got a nice flap.
Anterior limit of the flap, sir.
Yeah, it's just near the external canal here. I can just see the external canal. But it'd be nice if you expose a bit of the external canal because you can then see the curvature of the external canal. That will help you to.
Okay, sir.
Mohan sir?
Ah.
Audience sake, I am asking this question. What is the lowest age limit you have operated?
Oh, now you know that we want to go as young as now. In fact, FDA has lowered the age limit to 9 months officially.
Yes, sir.
So the lowest we have done is about, I think, 7.5 months or so.
Yeah, this is great.
Yeah.
Mohan sir has done the case of 7.5 months.
So more than the chronological age, what you are worried about is the weight of the child. So if the child is about 8 kilos, very good.
Yes, sir.
But even if it's not 8 kilos, you have to be sometimes doing it. For example, in the case of meningitis, you can't wait.
Yes, sir. So to avoid this, your
ossification, you may have to go earlier also.
11 that is ossification.
Okay, so we are ready now.
Yes,
I'll
sir.
get a little bit of soft tissue and keep it here. Later on, we may need it.
This soft tissue you are taking for tissue seal.
Sealing. And Raghu, as you said,
Yes, sir.
was telling us that there might be a leak also.
Yes,
sir. I don't hope not, but we'll prepare for it if it comes to that section. So I'm switching over to microscopic image now. Section check. Motor.
Sir, what microscope you are using, sir?
Using a Zeiss S8.
S8. Okay, sir.
Sir, any contraindications to take up a cochlear implant case, sir?
The only true contraindication, absolute contraindication, is the absence of cochlea or the cochlear nerve.
No.
All the others are relative contraindication. Of course, relative contraindication is infection.
Yes, sir.
You are collecting the bone dust.
Yeah, collecting the bone dust. I'll tell you why. With short time we'll be seeing it.
Reason, sir.
We'll be seeing it in a minute, sir.
Yes.
So when the key to the procedure is the posterior tympanotomy.
Yes, sir. Posterior.
And to do the posterior tympanotomy, the most important thing is to keep the posterior canal wall thin. So this is the most important thing that all the beginners have to learn.
Okay. So simple mastectomy, posterior tympanotomy, round. So you have told that the posterior wall should be thin. How far thin?
You'll be seeing it now in a minute. It must be opalescent.
It must be opalescent.
It must be very thin, paper thin, opalescent.
Yes.
But at the same time, there should be no hole in the posterior canal wall.
Okay, sir.
Are you seeing the microscopic image?
Yes, sir. And Mohan sir used to tell something. It should be opalescent and it should be very strong enough to.
Yeah, it's intact. It's very, very strong.
Small history belong.
I used to compare with bone china.
Yeah, bone china. Okay, sir. Holding the Mercedes Benz.
Yeah. Middle ear section. Keep two sections.
Sir, when you are dissecting towards the tip, you used to see some nodal swelling, sir, in some cases.
Yeah, sometimes you'll find diploic mode.
Yes, sir.
That will cause bleeding. So that is one problem in very small children.
Children, yes, sir.
Presence of diplo.
Yeah.
Because they're still forming marrow. The thing to do is to use diamond bar that will usually seal the bleeding.
So you prefer cutting one rather than the diamond?
Yeah. Cutting burr will open up the
channels.
Cells, yeah. So you'll see the landmarks better.
Yes. But the diamond burr will increase.
It will obliterate the landmarks. Yeah, it will stop the bleeding, but it will obliterate the landmarks.
Heat also get transferred.
Yeah, that's true.
So now you are going towards Adidas and Antrim you to see the incus, sir?
That's right. I'm going to see the incus shortly.
Okay, sir. Okay, sir. In the posterior aspect, we are able to see the bluish hue.
Yeah, there's the sinus coming up here.
Yes, sir. Now you are thinning down the posterior canal.
That's right.
Yes, sir.
All about.
So will you increase magnification power?
I'm going to do that in a minute.
Great, sir. Now we are able to see the lateral semicircular canal now.
Yeah, you think that it is?
Yes, sir.
And the lateral canal.
Yes.
See, the advantage of exposing a bit of the posterior canal is you can see the curvature of the posterior canal. So you know exactly how the curvature is, so you can take appropriate amount of bone, keeping the posterior canal wall thin.
Thin, okay. Bigger size cutting burr is preferable, sir.
Always. Whenever possible, use the biggest burr because the bigger the burr, the better the control.
Control, yes.
But at the same time, you must, remember that it can cause collateral damage if it's too big.
Okay, sir. We are able to see the incus, the body of the incus.
You can see the body of the incus now. Now give me a smaller burr. On trying.
Sir, many juniors are watching. So
Yeah.
use the second.
I'll just tell them what.
Thank you, sir.
Right. So now you can see give me a pointer, please. You can see the lateral canal here.
Yes, sir.
Right. You can see the short process
Body and short process.
of the incus there. And just above the incus, you can see the superior incudal fold. Okay?
Yes.
Now that's the fossa incudis. And the incus is like a pointing finger. It points to the facial nerve. So I would expect the facial nerve to be somewhere here, but I've still got a lot of bone here to remove. So I'm going to take out all that. கொஞ்சம் பெரிய பார்.
For getting the good access, you are working near the tip. Am I right, sir?
Yeah, always.
Always.
Always. You have extra space more than what you need.
The surgeon can be comfortable.
Yes, right. Okay. So now this is the area that I'm expecting the facial.
Facial.
So what I'm going to do now is I'm going to work parallel to it, thinning out the deep part of the postcanal wall.
Okay.
Little bit of fine focusing required.
Okay. Is that better?
Better, sir.
You still need more?
Little bit.
I think that's about it, really.
Okay.
Is it okay?
Okay, sir.
Okay, we can see the lot of hair cells there.
Yes, sir. Yes. So you are working along the facial now, sir?
That's right. I'm working parallel to the
facial now.
That's right. Exactly.
Why not transversely, sir?
You cannot work transversely.
Yeah. Yes, sir.
You want injury to it. And I'm using a cutting board, as you can see.
Yes.
The advantage of a cutting board is, first of all, it opens out the
channels,
landmarks.
Okay,
Secondly, as you said, it also cools better because between the teeth, the saline can go and wash.
We can irrigate, we can do the suction.
That's right.
Yes, sir. And the heat is not getting transmitted towards the structures.
And also remember that we are opening the facial recess, the boundaries of which are the facial nerve here, the annulus somewhere there, and the incus, fossa incudis. It's a triangular space. And the apex of the triangle is the facial angle.
We are able to see the facial nerve areas.
Just starting to see the face here. The incus buttress here is the base of the triangle. It's the broadest part of the area. So that's the safest area to open up the post triangle. Now give me a smaller cutting board, please. Now, if I suck here, give me a pointer, please.
You're able to see the suction effect.
Yeah, you're able to see the suction effect here.
Yes, sir.
Isn't it? That means there is a cell which is going there. That's the perifacial cell.
Perifacial cells. Okay. So beautifully we are able to see the kada.
Okay, give me a pick, please. Smaller pick. Yeah, so this is the cell, perifacial cell that we were talking about here.
Yes.
Just getting opened out. Give me a moment. Small cutting board.
So here you are using the size of 3.
Yeah, this is a 3 millimeter bar.
Yes, now we are able to see the
We are starting to see.
Yes, sir. Through the facial trees, we are able to appreciate the long process of the incus and IS joint. The stapedial tendon is also in the view.
Starting to just connect.
So please focus, sir.
Yeah, I'll follow.
Beautiful, sir. Superb. We are able to get the view of the long process of the incus, IP joint, and stapedial tendon.
So now the
Focus,
focus.
sir. Little bit.
Yeah, 1 minute. Is it better?
Better, sir.
Better, sir. Very clear.
Smaller section, please.
So with the sharp pointer, can you show the structures inside?
I'll show you.
Yes.
Expand it a little bit more, then we can have a better.
Okay, sir. Okay, sir.
Reduce irrigation by 1, please.
In that area, the bone will be thick, sir.
Yeah, usually, yeah. If this is, give me a pic here. This is the facial here.
Yes, sir.
Facial canal is here, somewhere here. Okay, can I have a give a diamond ready now?
Now we are able to see the promontory also, sir.
You're able to see the promontory.
Yes.
Family. Now I'm going to take away a little bit of this curvature here.
Okay,
so that you get more light into the
More
tape.
light will enter into it.
Little larger cutting board.
Yes.
You see that little fold there that is hiding it. So I have to take out a little bit, tighten it.
The posterior metal wall, there is a bony overhang. So you want to remove to allow the light to go in.
That's right.
Yes, sir. See, these are all very important. These are the tricks.
These are some very important practical tips.
Yes, sir. Yes.
To make your life easy. Yeah, but now we can see the difference.
Yes, sir. Yes.
Diamond.
See, now we are able to see the good light is going in, sir. So we are able to see the inner structures.
Smaller. Smaller. So now I'm thinning out the bone.
Yes.
Anterior and lateral to the facial cluster.
Yeah. So it should permit the butt of the bus should go in.
That's right. Exactly.
Yes. Okay, sir.
And the more bone you thin out,
Okay.
the more you expose to the round window area.
Even the round window is coming in the view, sir.
Yeah, it's just coming into view.
One, sir.
Yeah.
For the audience sake, I'm asking this question, sir. This mic's angle.
Yeah, kind of it. That's good. So I'm widening it a little bit more so that you get more space.
Yes.
One, so that you can have your instruments comfortably going in, and also because you can get more light inside. So extending the window inferiorly a little bit more. So we are starting to see the round window niche. Almost
Different types of round windows, sir.
That's right.
Sir?
So almost onto the facial there.
Yeah.
Still a little bit of bone. Right. Now we can see the
Round window.
round window niche.
Period is anterior, inferior, we are able to see.
Give me a smaller section, please.
Sir, if you are showing with the pointer, it will be helpful, sir.
I'm going to show it in a minute. Okay, give me a small needle of probe. Okay, let's see the landmarks now.
Yes, sir.
Okay, so now you can see the long process of the incus,
Yes, sir.
lenticular process,
Hmm.
head of stapes,
Yes, sir.
and this undersurface of the malleus here.
Yes, sir. Stapedial tendons.
Right. And then that's the tendon of stapedius here
Okay, sir.
and the pyramid here.
Pyramid.
Okay.
Yeah.
Right. And then of course you can see the horizontal part of the facial nerve also there.
Little bit about the Mike's angles.
Right. This is a facial nerve. Right. Now this corner here between the incus buttress
Yes, sir.
and the lateral boundary of the window of facial this is.
Okay.
This is the position of the annulus. So this angle here is known as the Mike's corner.
Okay.
So this Mike's corner, the more you take out, the more of the long process you will expose.
We can see. Okay.
This is important when you're doing middle ear implants, like vibrant sound bridge, for example, because you have to clip the vibrant sound bridge onto the long process.
Okay, sir.
So this is why it's not important in this surgery, but it is important in middle ear implants.
One, sir.
Yeah. Right, give me a
Types of round windows, sir.
Theta. Oh, round window, there's a big classification.
Yes, sir.
2 or 3 classifications, in fact. One was put forth by in our own country by Dr. Naresh Panda.
Okay, sir.
But basically, the round window comes in various shapes
Yes, sir.
and sizes also. And it can be a little bigger diameter. And it can be usually covered by the superior lip.
Yes, sir.
This is known as the operculum.
Yes, sir.
Operculum covers the superior lip. And when it covers, it can hide various parts of the round window.
With the sharp pointer, can you show the operculum areas?
Okay, give me a pointer. So this is the upper border, right?
Yes, sir. That is very, very important. Operculum. Okay. Sir.
So let's take out that.
Yes. Sir is removing the superior mesh area. Sir, which is important, sir? The skater?
Now, yeah, skater is good for this, but because it's very precise.
Yes.
Right. Now, give me a small pic, please.
So now you have reduced the rotations too?
Yeah. So now I can see the membrane better.
Yes.
There. Okay.
Yes,
and
sir.
there is a bit of, there is a false fibrous layer over it, which is what I'm feeling.
Yes.
Okay. Can you all see now?
Yes, sir. We are able to see the membrane also.
That's the membrane now. Okay, good. Excellent. So now we give a pause, give a gel foam, please.
Sir, before that, can you show that membrane area? Can you centralize the picture and can you show that area, sir?
Can you see that?
Yes, sir. Yes.
Give me a pointer.
Pointers.
That's the point. That's the round window.
Yes, sir. We are able to see better. Great, sir. So, gel foam soaked in? Gel foam soaked in?
Adrenal.
Adrenal. Okay. Sir.
Yeah. So I'm going to now go and make a bed for the receiver stimulator. Right. Give me a clear, please. Top lights, camera first, hand camera.
Now you are going to proceed the receiver bed creation,
Yeah,
sir.
that's right.
It's
So I'm being assisted by Dr. Shanmugapriya template, who's an implant fellow.
okay, sir. Great, sir.
So we have 2 implant fellows every year, Shanmugapriya and Dr. Sethu. They are both assisting in today's procedure.
Okay, sir. Great, sir. Now you are keeping the template.
Yeah.
Sir, we are not able to see the picture, sir.
Hand camera. இது வந்து நேரம் தானே வருது இந்த தானே அந்த டெம்ப்ளேட் இருக்கு அதுல.
What is the distance between the?
Yeah, you need at least 2 centimeters from the mastoid cavity to the bed and corresponding to the sinodural angle.
Angulation 45 degree.
45 degrees is sinodural angle. Right?
Sinodural angle, yes. What is the brand of the implant you are going to use?
We are using a Sonata 2
Medal Sonata 2. Okay, sir.
And yeah, this is a template.
Yes, sir.
With a flex soft electrode.
Flex soft. Okay, sir.
So with your permission, can I take certain questions?
Please. You don't need my permission at all.
Even I'm requesting Kirtane sir and panel because all of you can answer the questions because
Small.
Dr. Nitika is conveying good morning to you and
Good morning, Nitika.
The question is, can we know the speed of burr during
speed of
cochleostomy? Speed of burr, sir.
For the cochlea, I was using a heater drill to expose around in the membrane. I think the revolutions is this is 16,000 per minute. Yes, 16,000 RPM.
16,000 RPM.
Yeah.
Thank you, sir. And when the facial recess is narrow, what could be the option?
In the?
When the facial recess is narrow, what could be?
Okay, facial recess is narrow. Yeah, well, there's so many things you can do, See, one, you can maximize your exposure. And this is by thinning out the bone almost to the level of the facial nerve. So this is number one. The more common problem, though, is that people are scared of the facial nerve and they start going without realizing they go and open the annulus. And that is a bigger problem, actually. So you have to be careful that you don't breach the annulus. Right? So that is a more common problem. But you can also, do in a very, very bad situation, there are certain things you can do. You can remove the incus with the incus buttress. That gives you a little extra space. And then you can also do an anterior tympanotomy if it's very, very bad. I don't think I've done it many, many years now. But that is something you can always do if it's very bad. The worst scenario, you can always do a subtotal temporal bone, resection. But that is in a very, very, should be an extremely rare situation where a very abnormal, unfriendly anatomy, like in syndromic ears and all that. These are all the options you have. But they're all very rare, I must say that, because in general, you can always expose it smaller.
Yeah, Mohan, can you hear me?
Yes, Milind.
One more option which has been described, we've done in a couple of cases, is when the recess was very narrow, we thinned out the posterior canal wall.
Yes, yes.
Because as you've shown, it is attached to the skin of the external auditory canal. Make two small cuts, push the wall forward.
Forward and then put it back.
And put it back, yes. Had to do it a couple of times, but as you rightly said, most of the time you can widen the recess. Once, a couple of times I've decompressed the chorda tympana and pushed it a little out of the way. Some people have even said, in a worst case scenario, you can even sacrifice the chorda, but I don't think that's a good idea since a lot of people are going for bilateral implants.
That's right. That's right.
Wouldn't want to sacrifice the chorda.
Today is the era of bilateral simultaneous implants. And in that era, two things are important. One is the vestibular preservation.
That's right.
Other is the chorda preservation. On a cutting board.
I'll be taking the next question from Dr. Gautam Naik from Guwahati.
Yeah.
He's asking how to look for facial nerve when we do posterior tympanotomy.
Oh, you don't have to look for the facial nerve. The facial nerve will look for you. You know, it's the other way around. The moment you start working in that area, Gautam, automatically you'll be going near the facial. The important thing is to work parallel to it, so that gradually, even if you expose the nerve, it's not a problem, you know, as long as you don't injure it. So work parallel to it, layer by layer, and you will slowly be seeing the image of the facial, or the shadow of the facial through the bone. Like I'm in this case, I'm just starting to see that. So, you know, you can always do that. So you don't have to worry about the facial. I think it's a bit exaggerated, the fear of facial.
I think if you learn to identify it, the chances of damage become
very small, very small.
Don't try to just make a small tunnel in that area. You saw what he did. He broadened the area like a funnel so that enough light went in, and he had access which was broad based, not a small tunnel going inside.
So here the tunnel is in the center, so it is a latest type of plug stuff, sir. Hello, Mohan sir.
This is a Sonata 2. Sonata 2 is the latest version. It's got a central access point. Like
So this question is for all the experts, including Kirtanesh panel and yourself. Can we do CI in cochlear nerve hypoplasia?
a very good question. It's a big topic. It's an essay topic. Okay, now let me put it very simply for you. You can do if you have a nerve which is functioning. Okay, that's it. So how do you know the nerve is functioning? So today we have a test which you can do. And one of the most reliable tests that you can do is known as a transtympanic EABR. And this transtympanic EABR is a test where you simulate the facial turn of the cochlea near the round window on the promontory with a single electrode, and then record the brainstem responses. If you're able to record and you get good responses, it means that nerve is conducting. And then you can go ahead confidently with an implant. So just because the nerve is thin doesn't mean you can't do it. You can always test and find whether the thin nerve is functioning or not. You have methods of doing it. You can also do cortical potentials. You know, there are various other options we have, but a transtympanic EABR is a gold standard for it.
Yeah, if you have a hypoplastic nerve, that means you're able to see the nerve. If you're able to see the nerve, there are good chances that...
Yeah, that's right. Exactly. So you can always test this.
At times you might be in a situation where the radiologist says he cannot see the nerve.
Yeah.
And it could be possible that the vestibular and cochlear fibers are going together, especially if you have a abnormal cochlea. So he will report, the radiologist would usually report as a deficient nerve. He will not say absent nerve. And there have been cases where, in spite of the fact that a cochlear nerve could not be seen separately,
Okay.
you did a transtympanic BERA, you got responses. Or if the audiologist told you that in the hearing aid trial, the child was definitely responding, you could go ahead. And I think we've got two cases where the nerve was not clearly identified, but on the basis of audiological tests, we went ahead and got responses.
Thank you, sir. So there is one naive question from my side. may be important, but I'm not the expert. Most of the time, the oozing is the problem. So, in which patients you have observed the oozing is more, and when the doctor or the surgeon should think of that patient will ooze more, and do you take any precautions for such?
Mohan, anything to add to that? I mean, we normally do in all patients PT, PTT before
Yeah,
surgery.
that's right. That's right. The only warning you might get is if there's a lot of diploic bone. As I said, that is something that is common in kids, and
Yeah,
you
but
use
then you use
diamond.
a diamond burr and take care of it.
That's right. That's all.
Unless the child has some kind of a
Bleeding.
gut dysplasia, which you would pick up in the preoperative phase.
Sure, sir. Thank you. And so, one very important question: how to make the surgery easy?
By repeatedly doing cadaver dissection,
By getting a good.
watching expert surgeons like Dr. Kameshwaran.
I was going to say pass it to Dr. Geethan.
And yet repeatedly doing cadaver dissections. There is no substitute
True, sir.
for that.
Very true.
Here, this is very, very important question in front of two doyens. Hey, Mohan sir is here and Ethne sir is. We have to watch and we have to do the cadaver dissections.
I have a very, usual dialogue with patients. Commonly, patients come and ask you, sir, is it a major operation or minor operation? So my response usually is there are only major surgeons and minor surgeons. You don't have major operations. So that's how it is. So you don't have to worry about it. It's a very straightforward surgery, with good temporal bone practice. It's a very reliable, rewarding surgery. So I don't think you have to worry too much about
Yeah,
it.
but Mohan, there is a reason why they come with that question, because somebody else before you whom they have consulted might have tried to put them off from doing a cochlear. I mean, we've had all sorts of, is it a brain surgery? I'm told it will work only for a few years. So there is a reason why these patients ask that question.
Yeah, I suppose so. I suppose.
When you are creating the receiver bed,
Yeah.
what is the
I have made a receiver bed now.
depth, sir?
And you can saw me making it, and I have, kept a tie there. All right. So these are all. I'm going to give a nice wash.
Yes, sir.
I'm almost ready to put the implant in.
So there is one question about the infiltration. The infiltration was with 2% lignocaine or with adrenaline or something else. Like which concentration you have used?
I use xylacine with adrenaline, pre-prepared solution, unless there's a contraindication for it. There may be sometimes. For example, child can have a cardiac problem. The anesthetist will tell us, don't use. So in that case, we may not. But generally speaking, this is what we use. Diamond.
The infiltration is only for the incision line. You don't
Only for the incision, not afterwards.
And actually, the patient is under general anesthesia, so.
No, it's only that your
Even
incision
then we
bleeds
have
a little less if you infiltrate. Even if you don't infiltrate, you can go ahead with this.
Yeah, exactly.
It's a cardiac issue or something, and we are now doing more and more implants in adults who have cardiac issues. So if you don't use it, it doesn't matter. I mean, the initial incision will bleed a little bit till you cauterize the empty.
Right. Okay. Change gloves, please.
Post-operatively, the infiltration. Post-operatively makes any difference?
The infiltration?
Yeah.
No,
It will
not there, because the effect of the infiltration will wear off in hours. So I don't think it helps.
Sure.
Probably the more relevant question is, do you use steroids? So there are some surgeons who actually, intraoperatively use steroids. That we do when there is a hearing preservation surgery. So sometimes you do in somebody with residual hearing, so you want to preserve the hearing, in which case you use minimal access to the cochlea and atraumatic insertion. And there you may use steroids intraoperatively, or also use a steroid, fill up the cavity with steroid lake and insert through that. These are all some of the things that you might do.
Sir, over the round window, you have kept the gel foam soaked in.
Yeah.
Can we use the steroid?
Yeah, you can use that.
Sir, can you show the implant, sir?
Yeah, I'll show it to you.
Sonata 2.
So that's the implant. Okay, you can see the implant there.
latest.
Viveki.
So what is the suture material you are using, sir?
This is the Ethibond,
Ethibond. So
so that it's
commission of Ketane, sir. We used to call Mohan sir as bond, 007 bond. Ethibond here.
you're talking to keeping Keithan there and talking about bond. You know,
Okay.
you're forgetting you're in Bombay.
No, sir, no problem.
You know, he is the Shivaji there.
Yeah, he's a great teacher.
Good to me. You're talking in Shivaji's land about Shivaji. Keeping Shivaji there with you.
See, what's very important is where he has tied the knot. It does
Yes,
not
sir.
come on top.
Yes, sir.
It goes so that it will never project against the
Yes,
skin.
yes. Sir, another important thing, you are putting the tie down in the implant material. There is a notch, sir. Can you show that?
Yeah. Point. It's actually in this one there is, this is the knot there.
Yes, sir.
There's a notch here, but that's not very good in this particular model. Okay, very good. Let's now go back here. Section.
Mohan, sir.
So
Yeah.
Can you just lift up the flap and can you show the magnet in the?
Yeah, I'll show you. Not good.
The marking of pelvis flap and the advantage Dr. Rajesh wanted to know.
You can see the magnet there. Okay.
So this is very important for transcutaneous transmission of the signals.
The palva flap advantage I already said in the beginning, but basically it's an anteriorly based flap. It's a very, very vascular flap, a very versatile flap. That's the advantage. So you can use it for a whole variety of implants.
Yes.
Not only cochlear implants. Fine section.
Major Vaibhav wanted to understand, sir,
Yeah.
how to decide cochlear candidacy and its favorability in a child with multiple or additional disorder.
Favorability in multiple handicap.
Yeah.
Yeah, well, it depends on what kind of handicap you're talking about. Generally speaking, the only one handicap which can be a problem is the handicap which affects the IQ of the child or the mind, the mental status. If there's a mental retardation, that can be a real challenge. That apart, it's not a problem. Okay, so we just made a small opening there. Jewelers.
How many electrodes are here, sir? The Sonata?
12 pairs.
12 pairs. Okay.
Right.
Mohan, are you on the external camera by any chance?
Yeah, we have an external camera here.
No, but right now.
Microscopic. Is he using the external camera? No. Microscopic.
No, because we are not able to see the round.
Not able to see the
round window area at all.
Hey, what are you showing?
That's much better. Thank you very much. Thank you.
Yes, sir. Great.
Ask him to show the right thing, but hope he's interested in seeing my back.
Great. So the speed of insertion, sir?
Yeah, very slowly. So you want to go one electrode at a time. Okay? Always without kinking the electrode. Pressure along the long axis of the electrode.
The trajectory, sir?
Yeah, always along the long axis. You see it's going in slowly. Don't be in a hurry to push it.
Yes. What is the forceps that you're using?
Jeweler's forceps.
So what is the forceps, sir?
Jeweler's forceps.
Beautiful.
So your aim is complete cochlear coverage. May I, sir?
My aim is to
So-
put the electrode
Oh,
inside.
yeah, full electrode. So the final end, can you show, sir?
Yeah, I'm just trying.
Yes.
Just going in now, slowly.
Oh, sir is using a jaw.
Suction. This is the instrument is called a claw, which will slowly negotiate the last bit.
Yes.
Metal electrodes are a little longer because they believe in complete cochlear saying. I'm not sure if all this makes a difference, but anyway, each company has its own philosophy.
Yes, sir.
We are not supposed to that. But important thing is that you have to be adramatic in your instruction, never force it. Okay, so we've got the full electrode in now.
So Dr. Farooq want to know, you have approached in low lying dura, and what if it's get exposed, then how to handle it?
If you expose the dura,
Yes.
no problem. No problem. As long as you don't injure the dura, no problem. Dura is tough, Dura is the best protection, not the bone. So exposing a dura is not a problem. As long as the dura is intact, no harm done. Okay. So now let me just go into higher magnification. You can see a small ridge there, kind of a thickening. Okay.
Yes.
That's the mark. Once it reaches around window, you know that the electrode is completely inside. Okay. So now can I have a picture of the soft tissue?
Sir, what are the different techniques you will use when you are inserting the last electrode, when it is not going in?
But whatever you use, don't force it. That's the important
Force
thing.
it, yeah.
Yeah. Insert it till the point of rest. Soft tissue.
Even if, let's say, an electrode remains out,
Oh, it doesn't matter.
it's
Yeah.
preferable to trying to force it and damaging the.
Dr. Abdul Kalam used to say very, very correctly that you just need about 8 electrodes. Right? He used to always say this point, make this point. And, more than that, all that is it's just, what can you say?
So the metal company is telling that 8 electrodes is sufficient to be.
Actually, that is what Abdul Kalam used to say, not metal company. Dr. Abdul Kalam used to say that very often. He said 8 electrodes is all that you need.
Mohan, I have had the occasion to use implants with 8 electrodes. That was the middle.
Beginning. Yes.
They had introduced it specially for India. And believe me, I have some star patients with that.
Yeah, exactly. So Abdul Kalam used to say the point again and again. Every time, every meeting, he'll say that. Okay, give me bone dust now.
So you are using the bone dust to cover the channel.
Yeah, that's right.
Expecting for the neosteogenesis.
The left.
So Dr. Balaji wanted to know etiology and update, any recent updates on JNA currently. Dr. Balaji wanted to know the etiology and update on JNA, any recent updates, JNA.
Gerbil nails, no?
JNA, that's juvenile nasopharyngeal angiofibroma. That will
Right.
come later.
Sure.
We're doing cochlear implants now, so let's have the questions related to cochlear implants. We can discuss JNA later.
Sir, what is the use of the keeping that area, no?
Tell us.
Bony overhangs in that area.
Yeah. It has to go in so that it doesn't jump out. This is the reason why you're keeping a small little ridge here.
Stabilize the extra length. And there is an extra length, no?
Yeah, this is supposed to be uncoiling as the skull grows.
Yes, sir.
Emotional release.
Beautiful, sir. Superb.
Thank you so much. Thank you. I think they're starting the, but before that, we'll just show you the ECAP and also the flap going back.
The metal company was talking about the breakage of the electrode near the receiver, sir.
No, not only metal company. Every company, the most common site of trauma is this area.
Show the site, sir.
This is the area where I'm covering now. This is why a little bit of more cement there.
To avoid that only you are creating a channel and the bonders. Yes, sir.
Mohan, beautiful demonstration. Beautiful.
Thank you, sir. Thank you so much.
It's
okay.
So the post-operatively nausea and other problems are significant.
Post-operative nausea is not a problem. Usually, we only have vestibular stimulation when we are doing bilateral simultaneous implant. Otherwise, it's not a problem. So, generally speaking, if you're doing a bilateral implant in a child, the child may be a little unsteady, have a little nausea, vomiting, and all that sort of
Parents
stuff.
may notice that the child is walking a little peculiar.
Wobbly, yes. But usually, in a couple of days, it will stabilize. It will compensate very well. Camera, hand camera, please.
It is really surprising that in spite of your, invading the cavity, the vestibular symptoms usually are not very strong.
Very strong, yeah.
Even the balance issues and
Bilateral, yes, to some extent, but they settle down very fast.
Very fast.
Kirtan said there is one more question from my side for the benefit of the people who are online. Rehabilitation is very important part in this. So, will you like to guide?
It is the most important part. Yes.
So, if someone is not having that backup team because speech therapy and other things will be required,
Then don't do the surgery. It's a part of the surgery. It's not something different. It's a part of the surgery. You have to ensure that your patient is going to get mapping and therapy. Otherwise, there is no point.
Thank you, sir.
It's like planting a seed in a pot and then not watering it, not caring for it. It's just going to be useless.
And this will require the lifetime follow-ups also frequently, how it is going, the audiometries and.
Absolutely. And you need to check the mapping from time to time, at least in the first 1 year. You would have to do it quite often. In the second year, a little less. But even after that, once even the child has developed good language and speech, from time to time, as a child grows, you'll have to keep on checking the maps. May not require therapy after, say, 3 years, but checking the map would be necessary.
Sure, sir. Thank you.
Well, when you say lifetime, Milind knows this. I keep saying this. He always laughs when I say this, but it's the lifetime of the child, not of the patient, not the surgeon. The surgeon is much older, so he's going to have a much shorter lifetime than the patient. So there must be a mechanism to follow up this child even after the surgeon is gone.
This has to be impressed on the patients beforehand. I
Thank
think
you,
one more thing which we are impressing on our patients is that start saving money because you might require an upgrade of the processor after some time.
Absolutely. There's the cost of maintaining hearing each year.
Yes.
Maybe in parts, replacements of parts, upgrading the processors. So the parents have to be smart and start saving every month, a small amount for the small kitty for the baby.
I think it is necessary to make them aware of this, right?
Yes, very true.
The coil is.
Sir, we have many experts here, and I will like to take this opportunity because audience experts also have certain questions. So I request Dr. Khanna, he want to ask certain questions.
Please.
Good morning, sir. Vikram from Mumbai.
Morning, Vikram. How are you?
Excellent demonstration as always. Sir, can you just highlight the role of artificial intelligence and robotic surgery with respect?
I knew this was coming. Vikram, yes. Vikram, the role of artificial intelligence is when natural intelligence declines. So I think people like me need artificial intelligence. You have a long way to go. But basically now, jokes apart, it's becoming a very, very important part of the process of auditory implants. Because we are getting into an era where the stimulation of the auditory neural system itself is now, getting to be governed by AI rules. So it's very important. Yeah, I think a lot of things are happening, but we'll wait and see. I think in my generation, probably, I'll go through where I am. But certainly in your generation, Vikram, you're going to be seeing a lot of AI coming into.
If I may just add to that, Mohan.
Yes.
I think the artificial intelligence will come much more in mapping and those issues
Yes.
where the mapping will be done remotely using AI. As regards robotic, I don't think there is a role for the mastoid part, but I think the only place where a robotic insertion insertion tool for making the insertion as atraumatic is possible. They say that you have to do the insertion very slowly. Dr. Mohan said that go one electrode at a time. What the experts are saying is that it should not be a start-stop insertion as we have been doing so far. It should be a slow, continuous insertion over 5 minutes. No human hand can do that, to hold that steady and over 5 minutes. But if you had a robot and the robot that could feel also the feedback of the resistance being offered to the tip of the implant, I think that's what people are working on now.
They are telling that the planning is taking nearly 5 days. The insertion few minutes.
Interestingly, only yesterday I had a paper published in Lancet, Laryngoscope, on an insertion tool which was developed by a team from IIT Guwahati in collaboration with Merck. So it just came out yesterday, an insertion tool called insertion of cognitive implant. So hopefully, if they develop this, IIT's Guwahati is trying to get to commercialize it. If it does, it will be a very, very great help for us.
Yeah. Already AB is having, sir.
Sorry?
AB.
Advanced Bionics has got that insertion tool.
Yeah. That's
that
not
is
the
still
same.
you're using it by hand.
Yes.
That's not them. This is a mechanical, this is completely motorized.
Yeah. So you just guide the robot there, and the rest of the insertion very slowly is done by the robot. Yeah.
And it's also got a haptic feedback. So if there's any pressure resistance, it will stop.
Yeah, because otherwise the robot will just keep on pushing and the implant will kink.
So this is where, as Professor Kitner is saying, there's a role for artificial intelligence. Yeah, definitely, because it has to be sensitive for haptic feedback.
The flap should cover the entire receivers. Huh?
Absolutely.
Yes.
More soft tissue you cover, the better the protection against infection, biofilms and so on. That's the one great fear that all of us have.
Yes.
So, any specific packing material you are using?
Packing, no.
There's no packing here. The wound is closed in layers, and you give a little tight bandage for the first 48 hours.
48 hours, yes.
So, Monsar, it is not MRI compatible. So now the company has come out with the MRI compatible.
Yeah, but when you say MRI compatible, you have to understand what it means. What it means is, if you're doing an MRI somewhere, you don't have to take out the magnet.
Yes, sir.
But it doesn't mean that you can do an MRI in the region near the implant. You'll still have a shadow.
But they are telling that there is a rotatable magnet.
Yeah.
Magnet is rotatable so that it doesn't get extracted. In the olden times, initially, we had to actually open the wound, take out the magnet, do the MRI and put the magnet back.
Yeah.
Then they said you can protect the magnet with a very tight bandage and do it with a low Tesla machine.
3.5 Tesla.
No, this is 1.5 Tesla machine. You don't use a powerful machine.
Yeah.
Now what they've got is a magnet that can rotate in situ.
In situ.
So that the MRI doesn't pull on the magnet because the magnet changes polarity.
Yeah.
But as Dr. Mohan said, around the area of the implant, you're going to get an artifact. So that particular area you cannot really image. You will get a fairly large artifact because of the metal there.
So when you say MRI compatible, you have to qualify that. You have to say, yeah, it means you don't have to take out the magnet, but it still means you can't be imaging next to it. You won't get a shadow. You'll get a very black shadow.
The use of CM, sir.
CM, I don't use it. There are some people who like to use it, make sure that it's going into the cochlea. But I think most surgeons, are quite happy with just insertion in the right anatomy.
Yes.
As long as you're going to the round window, you can't go anywhere else, really. And
I prefer to do SIA because I do a lot of mentoring. I travel and I don't want to leave the place.
Yeah, that's right. Without an X-ray.
Without an X-ray. And there are some places who don't have a C-arm, then they do a portable X-ray. But ultimately, if you're going to...
Sir is
yeah.
CM human.
Yeah, I think it's your choice, really.
I mean, you're more secure in the knowledge that everything
That's right. So here in, as you know, Palniappan, in Tamil Nadu scheme, we insist on a post-operative X-ray.
X-ray, yes, sir. Post-operative.
That is for the same thing. You document that it is in the cochlea, and also for future comparison.
Yeah.
All the experts in the hall, if you have any queries, please raise your hands so we can pass on the mic to you. Thank you. Kirtani sir, there is one question from my side. Post-operatively, any particular restriction for CT scan or MRIs or
CT scan, no restriction. MRI is what we talked about. Basically, nowadays you get MRI, so-called MRI compatible implants, which are implants which you don't have to take out the magnet from. You can do an MRI. For example, you're doing an MRI of the, let's say, knee joint. You don't have to take out the electrode. But if you're going to be doing an MRI in an area near the implant, you won't get any image. So CT, yes, so you can do it, no problem.
Even in CT, you will get some artifacts.
You will get, but you can get definitely better quality image compared to an MRI.
Thank you.
Are they starting there?
Sir, one question.
Yeah.
Usually in the state schemes, the implant model is more or less decided and you hardly have a choice.
Oh, we have a lot of choices. In fact, next child I'm going to do, they're doing there is a scheme patient. And it's exactly the same electrode, same implant.
My question was, how do you decide which company and which model for?
In Tamil Nadu, each scheme is different. Tamil Nadu, the department or the center has a choice. We can negotiate with the company and get an implant as long as it's FDA approved. It's not a problem.
And in a private paying patient, you decide which implant would be best for that.
No, what we do is very simple. We give them, like in our center, we do all three major FDA approved implants: advanced bionics, Medel, and cochlear. So we give the choice to the patient. We tell them, our audiologist will counsel them, give them a chance to, ask.
Don't give them the choice of the new bio. Sorry.
Yeah, well, I'm waiting for Dr. Keithre to do it before I do it.
I'm waiting for Dr. Mohan Kameshwar.
There are multiple questions again.
Please go ahead.
So what are the precautions to take in case of IPL malformations? Dr. Nageshwar Rao wanted
IPL?
Malformation.
Oh, well, it depends on what kind of IP.
Talking about incomplete partition 1, the question.
Yeah. If it's IP1, then there is a very good chance that they may have a CSF leak. And there is also a chance of migration of the electrode into the SCP angle. It's happened to me actually for one of the patients. It's not a problem. If it does migrate, you have to switch off those electrodes which are migrated and use the other electrodes. The CSF leak, of course, is a problem. It has to be addressed. If you have it, you have to seal it and get a watertight sealing.
IP1, IP3 and common cavity is where you will get a CSF gusher.
Big gushers, yes.
IP2, where you have enlarged vestibular aqueduct or an isolated enlarged vestibular aqueduct, you will get a CSF oozer.
Yeah, that's easy.
Much easier to seal off. While I did a bilateral IP3 yesterday. a child bilateral.
That can be a real problem.
Mohan, this is one of the rarest of the rare cases. You know why?
Yeah.
It's an IP3 in a girl.
Ah.
So now we are doing chromosomal studies. Yeah.
Yes, it must, because it's not
IP3
common at all.
usually occurs only in male children.
Yes, they
All
almost
the IP3s we have done are male. This one,
This must be some other.
yeah, some so we are doing the chromosomal studies. But in IP1, IP3, you have to be prepared for a massive CSF gusher, and you have to be prepared with connective tissue to seal it off. So don't panic. But if you anticipate it, then you're not worried. If it comes suddenly, then it's a different thing.
So what is the connective tissue you prefer?
You can use fascia, periosteum, fat, whatever.
Yeah,
is it.
periosteum.
Important thing is to ensure that you have a watertight seal before you.
On the table. And one more thing here is that you have to be prepared to look at the oval window area also. I've had cases where I've gone and sealed off the round window, the leak continued. You looked at the oval window and you found that there was a
leak from another area.
Stapes foot plate.
Stapes foot plate.
Very important point.
Yes.
Because usually you'll be looking at that area, but.
So when will you use compressed?
Compressed electrode in a situation where you have an ossified cochlea, for example,
Labyrinthitis ossificans.
or where you have a short cochlea anatomically. Those are all rare situations. But ossified cochlea can happen, and you may need to have this.
Before that, will you use the test device?
Yeah. You can if you're not sure about how much the depth you're going in, so you have the.
You use the test device before you open the, because once you open the implant, you'll have to pay for it. So.
Sir, any role of CBCT in pre-op evaluation?
See, cone beam CT is very good. It's much better than even a HRCT. Gives you more detail, less radiation. Biggest advantage is in a child, it's almost 1/6 the radiation.
And we can keep the CBCT in the consulting room itself.
That is the hospital. You can keep it in the hospital.
Yeah.
And you get a lot of information out of it.
Yes.
So I'm asking my colleague, Ranma Priya, she's going to be closing the last skin. And we're going to get the decaps now.
So when we want to see the NRT, sir.
Yeah, it's going to show it to you. It's going to show you the.
What I do is before I really completely close the wound, I've just taken the periosteum.
Yes.
I put a small wet gauze, cover it with plastic.
And then do it, yes.
And do the measurement of the neural responses.
Yeah.
Right.
NRT, NRI, caps, whatever you call it.
Before you close up.
Before you close. Because sometimes you find that, maybe it slipped out or whatever, then
it may
don't have to open the whole wound.
Again, you need not open.
So here, actually, what we're doing is she's just closing put the flap. She's just closing subcutaneous tissue, then she will do the test, and then after that put the skin. That's what she's trying to
Sir,
do.
it is not complete closure, sir. One or two stitches.
It is just the upper end, so that
the periosteal flap.
Yeah.
You just take 1 or 2 stitches.
Yes. Sir.
Then do it and then close the
Yes.
rest. Yeah.
NRT can be done.
So Dr. Anurag Sangupta sir has conveyed regards to Kirtane sir and yourself.
Thank you.
About Siam, he had question which Kirtane sir has already explained. He wanted to know when do you use endoscope? Like, do you use endoscope when round window is not properly visualized?
I don't. You can use, but I really don't.
I have not used it so far, but it has been described that you can use, and you can use the 2.7 millimeter endoscope to sort of localize exactly where the round window is. Suppose you cannot access it and you have to do a cochleostomy, at least you will know where to position the site of your cochleostomy if you can visualize the window. So this has been described in literature using 2.7 millimeter endoscope in case the facial is overhanging.
So just for academic interest,
Thank you.
the Cyrodin endoscopy, the model thing, and we put inside and
inside the cochlea.
Yeah.
Why would you want to do that?
No, no.
I mean, I have seen a slide from Mohan. I've also done it once just for the heck of it.
Yes.
Yeah, right, exactly. There's no real indication for that.
Real indication.
No real in, yes.
It's
Yeah. Hi. So there is one more question from Dr. Stalin from Pondicherry. Can we have telemetry report and its importance?
Telemetry for the uh, electrophysiology, yes. You know, you can have telemetry. You can even, as Professor Keithney was saying, you can nowadays you can do remote telemetry. You know, I can stay in Chennai and do ECAPs on a patient being operated in Trichy, for example. So it's quite possible nowadays. That is very, very possible. So yes, the answer is yes. You know, you can.
So from Indore, Dr. Vishal has asked, so you don't feel the need to pack the mastoid with AB gel? If we do, are there any problems?
Need to pack the mastoid?
Yeah.
Why would you want to pack the mastoid? It's a pneumatized mastoid. Why would you want to pack it? Your gestation tube function is okay. It's an aerated mastoid. So what would be the need to pack it? I don't see. The only time we pack it is when we do a total petrosectomy. That is the time we pack it with fat.
Right, sir. Right,
sir. Now the NRT is going.
Yeah, the impedances are all okay.
Yeah, impedances are okay. Good. So he is now starting the ECAP.
So Satya is doing, sir.
Yeah, electrode number 6.
Yeah, now.
And there, I think you've got a response there.
2.
Yes. Okay.
You can see the depolarization, everything now. 11 also okay. ECAP score of 9. Yes, okay. Now it is 7. Now examining the 12. So beautiful, sir. Superb, sir.
Yeah, so we're getting all
intact. Just for the audience, please clap because hello, Mohan sir, able to hear?
Yeah, thank you so much. Thank you. You're all very kind and charitable. Thank you so much.
The surgeon will be happy when he's getting the claps.
Yeah,
I think be even happier when the child hears the claps. Yeah?
Very true. Well said. Well said. We're just shifting to the other theater because I think they're ready now. Just to show you the little changes that they are doing. Take the camera to.
Fantastic job, Mohan. Thank you very much.
Thank you so much. Thank you so much. Very kind of you. Thank you.
So I don't want to jinx it, but there is a question from Hyderabad. Dr. Syed is asking, have you faced implant device failure post-operatively?
Oh, yes, yes.
So how do you manage such a case?
If it is real heart failure, you remove the device and put a new device. It can happen, because child can fall, hit the head, device can be damaged. All that can happen. You take out the device and put a new one. If it's within the warranty period, it's not a problem.
Explantation and reimplantation.
Yeah.
So when you're doing this, it's a good idea to not remove the implant straight away.
Yes, sir.
If you're going to re-implant at the same sitting, then keep the array inside the cochlea for as long as you can.
Yes.
If you're going to do it second stage, then we actually cut the array near the round window, remove the rest of the implant, so that the cochlear patency is maintained for you to implant.
It's a great idea. That is, we have to keep a small bit near inside the cochlea.
No, whatever was inserted in the cochlea, let it remain.
Let it be there. So it will be useful when we are going for reimplantation. Yes.
Yeah.
So there is one question, maybe a naive question. Acute infections, you must be avoiding the surgery during that time. But when there are chronic infection, then how you manage the implants? Because
it's a big problem. If you get infection, you have to treat it very aggressively. Intravenous antibiotics, etc. But once the implant gets infected, then the chances are that you get forms of biofilm, and people have done all sorts of things, that revision and washing it and manuka honey and all that. But very often it doesn't work, in which case you'll be forced to explant.
Explantation.
Now, you're not going to re-implant at the same sitting because there is infection. So that's the time you cut the area at the round window, keep that area covered, remove the implant, maybe debride the granulation tissue.
When will you re-implant, sir?
You would wait till the skin heals, wait till there is no more inflammation there. And maybe after, say, 2-3 months, when you're sure that there is no infection, you can do your parameters like CRP, WBC count, or things like that, and local examination to know there is no infection. And then you can re-implant. But never make the mistake
We should take
of
care of
re-implanting the opposite
thickness.
side. You know, it has happened in the past where somebody said, oh, I'll take out this implant and I'll implant on the other side. Don't do that, because if you've got infection in the body, you can't take that chance.
Yes. The flap thickness.
Well, if in a very obese patient, if the flap is more than about 6 millimeters or 7 millimeters thick, then the magnet may not stick.
Palyapan, I'm giving the mic to Raghunandan, who is now, you can see now, I don't know, they're getting the images of his.
We are getting the images.
Yeah,
sir.
so it's a minimal access surgery,
Yes,
which
sir.
he's demonstrating. So you can see the difference in the incision. You know, my incision was a huge incision. This is a very short incision. And he's also made a pocket, a tight periosteal pocket for the implant there. You can see that pocket there.
Markings and the, sir, markings and the.
Yeah, Raghu will show you. Okay.
Taking those implant questions forward, sir. So there are two questions from Hyderabad and Nellore. They're asking, what is the lifespan for these implants, and what are the post-operative care that needs to be taken for these implants as well?
I'll ask the second question first. Once the wound is healed and there is no infection, I don't think there is any special care to be taken for the implant, except that you want to avoid direct trauma onto it. So I would definitely suggest avoid contact sports. Okay, boxing, wrestling, best avoid it. The life of the implant, nobody knows in the sense. The first patient I operated was about 28 years ago.
Hello.
Still using the same implant. So unless something goes wrong, the implant could last you even lifelong.
Hello, very good morning to all of you.
Good morning.
It was a pleasure watching Professor Mohan Kamishran demonstrating cochlear implant with such ease and so quickly. I've learned all my implantation from sir. So a little bit of improvisation here. So nowadays, I think the trend is to change to minimal access surgery. So nowadays, we are doing more and more of this minimal access. So a few things about minimal access per se. Minimal access does not mean only the incision is smaller, but each and every step of surgery is actually a bit difficult because of minimal access, because you have to respect the tissues. The concept of minimal access surgery came because of respect to the tissues. So the more that you actually meddle with the tissues, the more the problems. So if you actually respect the tissue planes, hopefully wound heals better. And in fact, we are trying to reduce the size of the incision, and our outcomes are pretty good nowadays with minimal access with less amount of infections. So this is a child, a 2-year-old with congenital bilateral profound cochlear hearing loss with speech language delay. In fact, this child was referred to us through the Tamil Nadu Comprehensive Chief Minister's Health Insurance Scheme. So the implant is actually funded through the government. And so this is actually a Medal Sonata TI 100 with a standard electrode. So going on to the incision per se, I'll just show you, this is a right ear. So I have Dr. Setu, implant fellow with me, assisting me. So you can actually see that the incision is almost like a mastoid incision, maybe even smaller. So with regards to the site, the surface marking, as Dr. Paniappan sir had asked me. So you can actually see that the incision starts, this is the mastoid tip, to just about the root of the zygoma. You can actually see the root of the zygoma, probably a centimeter above it. So it's almost just 3 fingers there. Okay?
Yes, sir. Yes, sir.
Yeah, just 3 fingers. So what I do is in the surface, I mark it slightly extended post-auricular. I don't go into the groove. I make the incision slightly behind, about 5 centimeters behind the post-oral groove. And it is about 3 finger breadth, a curvilinear incision, or even a straight incision should suffice. And then I place the surface marking for the template. This template is placed, this is the root of the zygoma, at an angle of 45 degrees with at least 2 finger breadth post-auricularly. that is important because you're going to actually wear the microphone here, and this microphone should not hitch against the border of the RS coil. Many times in our early learning curve, we are more used to putting the coil further down the ear. But it's important to find the most flat part of the temporal bone, wherein the coil can actually sit. You can actually feel, I put the template inside here. You can actually see the template is sitting nicely.
Already you have inserted the template. No?
Yeah. So, yes, sir.
Again,
So,
please take it out. Can you please introduce?
Sure. See, the thing is, the idea about minimal access is to find a nice snug template pocket, so it doesn't move at all. In fact, this is actually sitting nicely. In fact, I'll be removing this when I'm putting the actual implant in, but I will just show you the other steps of minimal access soft tissue work. Can I have the rake, please? So you can actually see I've just made an incision. So infiltration here, you should not give infiltration in the subperiosteal plane. So basically, the infiltration in the subcutaneous tissue will raise the subcutaneous tissue from the periosteum. Okay, so once we have done the infiltration, I just make an incision.
Bring it to the center.
Yes.
Raghu, please bring it to the center.
So you can actually hopefully see the whole wound. So these are the two subperiosteal margins. So you can actually see that the periosteum is incised now. I've got into the mastoid cavity. But what I have done here in anteriorly is to make elevation up to the posterior wall of the ear canal. This is the ear canal. And this is the periosteum. So I have just made a vertical incision along the posterior margin of the ear canal and extended it up here like a hockey stick.
Ideal idea behind this minimal access is to minimize the dissection.
So we are trying to minimize the amount of dissection. At the same time, we are making sure that
avoid infection also.
That the entire soft tissue pocket here is undisturbed. It is not meddled around. So we generally don't use monopolar cautery. We don't use much of tissue dissection here because we want to create a nice periosteal pocket for the entire coil to stay away from the surgical field. So
your incision in the skin and the periosteum is not overlapping, right? They're separate.
No, sir. That's exactly what I was about to say. In fact, that's great, sir, for you to mention that. The very fact that the skin incision is slightly behind than the periosteal incision is that the wound healing will be in different planes and different sizes. So even if you have a skin infection, the periosteum will nicely heal forward. And the other advantage is if you do this hockey stick like that, the two margins will come close together and you can actually have a complete periosteal cover. So the entire RS coil bed is separated from the mastoid cavity. And the subperiosteal pocket is separated from the periosteal cover over the mastoid. So literally, you don't actually take out any tissue. So the margin should actually approximate primarily end to end. That's the idea. So once I've done that, this hockey stick incision is basically from, so this is actually a metal sonata. So we are going to have the electrode coming out from this corner of the template. So
Raghu,
yeah.
It is better to remove that and
Yeah. Okay, I'll show
you.
you.
Undermine the after taking the skin incision before you take the periosteum.
No, sir. No, sir. In medieval, no, sir. We don't touch or disturb any of the tissues which is not necessary to be undermined. So I have just elevated the soft tissue. I've gone straight down to the periosteum, made a vertical incision with a hockey stick extension for the coil. I've elevated the subperiosteal pocket of the freers. Since Dr. Palniappan requested, I will remove and reinsert it. Possibly. So you can actually see that that's the marking of the RS coil, and I've inserted the template right underneath.
Raghu has learned this technique in England.
Yeah, because there my bosses used to say the smaller incision that you make, you get more chance. So we actually call this as a 10-pound technique. So there's a 10-pound coin with a queen space on that. We actually put the template coin and we mark the two ends of the 10p coin and then we insert. So that's the template there. So there in UK where I trained, cochlear implant used to be daycare surgery. In fact, the problem was getting beds for these patients. They used to stay in the hospital for 8 hours. So we got to be very meticulous about it.
Raghu.
Yes, sir.
Please remove entirely and remove the packet. It will be useful for.
Yeah, so I think it's just a little bit. See, minimal access. Yeah, retractors. So minimal access is all about being very slow, gentle, careful dissection. It takes more time, but I think the end result is worth the effort. Can I put another lanyard back here? So you can actually see here that the two periosteal margins are reflected. I have not cut any periosteal tissue. I have not elevated this part of the periosteum. That's very important because Otherwise, there is a risk that the lower border of the template, because of the weight, can gravitate downwards. So this will actually form a nice channel for the coil to go into the mastoid. The electrode
The
array
meaning of
goes
minimal access is elevation of the periosteum is minimal.
very minimal, only enough for us to actually expose the mastoid and also to get enough space for us to create the subperiosteal pocket here. And you can just snugly fit it. So what I do is I put the template inside the beginning of the surgery. The template will slightly expand the periosteum in such a way that it creates enough space for the actual implant to go in by the time we actually are ready to insert it. Lift, please. Yeah. So that angle of 45 degrees, and there you go.
Yes.
So the whole thing is hidden. So you don't have any of the coil exposed to the real wound. So then we come down to the mastoid, and then we put 3 stitches, stay stitches, sutures, please. So this point where the hockey stick is created, that sharp margin is important for us to keep preserved. So that helps to approximate at the end of the procedure. I'm just going to take a couple of stitches here.
Already you have marked the site of mastectomy.
Yes, sir. So mastectomy is as a routine cortical mastoid that we would do anyway.
Already you have marked everywhere.
Yes. So I'm just trying to reflect here again, make sure that we don't tear the periosteum. Hold it. Scissors. So the most important thing is to make sure that your posterior canal wall, the soft tissue there, the skin is not tethered, because we are very close the anterior part as we elevate the periosteum there. So we don't have a Palvar's flap. This is actually a flapless minimal access procedure. It's basically a subperiosteal dissection. We don't raise a flap. As Monsa said, Palvar's flap is a fantastic flap based on the posterior auricularis. Very old flap, most useful for more than 100 years now. Can you have a gauze, please? So I'm just going to anchor the stitch anteriorly to lift the soft tissues away from the posterior canal wall.
We can reduce the incidence of infection.
I think we are finding some good results now with the minimal access, because we are causing less harm to the surrounding tissues. So wound heals, nature will heal.
Surgical dictomy skin is the best dressing in the world. So you are not violating that.
Yeah, because in my training in the UK, people used to always say, respect the tissues. If you don't, then they will come back at you.
Yes.
One more gauze, please, here. So these things will take a little bit more time, but I think it's worth the effort. This child also had a post-auricular lymph node here, which I excised. Some of these children, they have this recurrent ear infections, and because of the low socioeconomic status, multiple URIs, we do find glue, we do find lymph nodes in patients whom we post, especially under the scheme. We take that extra care to make sure infection doesn't harm the implant. I think that's the biggest challenge and the biggest difference between the Western countries and us. Any questions now, please? I'm happy to take. As I work along the soft tissue, tethering the flaps.
Request audience if you have any queries, concerns.
I'm sure there'll be a few surgeons who are doing minimal access anyway. So I think it'll be good to have their expert comments as well. Please, right? I'm just going to take a piece of fascia and muscle, scissor. So that pretty much exposes a decent mastoid, isn't it? So that's enough for us to work on the mastoidectomy and get into the posterior tympanotomy.
Immediately you will go up to the root of zygoma.
Yes, sir. So you can actually see the root of zygoma, yeah? I'll just show you. There's a little bit of blood clot.
Now you are removing a small bit of tissue.
Yeah, for packing the cochleostomy.
Yeah.
Again, we don't want to take periosteum, so I'm taking only muscle here because we want to keep the periosteum intact. Okay, so suction, please. Master drill. So that's pretty much the exposure. And then we go in for a next step, which is actually again cortical mastectomy, but with minimal access, which means that we don't do a authorization. That is pretty much the same case in all cochlear implants. So you can actually see the spine of Henle.
Yeah.
You can see the root of the zygoma.
Yes, yes.
This is the posterior canal wall. Okay.
Okay.
I hope the images are clear.
Yes, yes.
Thank you. So I'll just start off with the mastectomy as a routine. Again, because of the minimal access, you will have some soft tissue coming in the way. But I think over a period of time, it's just a learning curve. We will try to negotiate. Part of the surgery in minimal access is also by feel. You don't really see as much as you should. But that's okay. I think we will learn over a period of time.
It's also cellular mastoid.
Yeah, very similar. I think there is no change from now on for cochlear implantation. I think minimal access stops at soft tissue level.
Oh.
The rest of the principles of cortical mastectomy, posterior tympanotomy, cochleostomy, electrode insertion, everything is exactly the same. It's only a subperiosteal pocket and anchoring the RS coil in the bed differs.
Okay.
I won't use any web suturing. I won't anchor the tie-down holes.
Yeah.
I'll just use one stitch on the periosteum over the RS coil because in any case, it's not going to slip out from there. It's very tightly placed, snugly fitting. And nowadays, the newer implants are getting more sleeker and smaller.
Yeah.
So I think the future is possibly something like this. We don't know.
All the
More
three
people
companies are coming out with the thinner receivers.
Yeah.
Raghu, this is Baparao from Visakhapatnam.
Raghu?
Hello?
Yeah, yes, sir.
He's asking.
Yeah.
Visakhapatnam.
This is Baparao speaking from Visakhapatnam.
Hello, sir. How are you?
I'm fine. I'm fine.
Please tell me.
Very happy
This is my smaller bar.
watching you operating.
Yes. Pleasure to hear from you, sir. Smaller bar. So I'll just ask my colleague to show you the scan of this patient.
Yeah.
It's normal actually, but just that we've had a presentation, just want to show you the anatomy as I'm doing the mastectomy or diamond bar. Diamond cyst. Okay. Diamond cyst. Just tilt the head a little bit. Right, so you're able to see the dome of the lateral semicircular canal now coming up.
You're able to see the dome of the lateral semicircular.
Yeah. I have a smaller section diamond. So I'll just ask my colleague, Dr. Rupak, to talk about the patient. A couple of minutes before I actually get into start the posterior tympanotomy. Yes, yes, yeah. Cutting bar, please. Smaller cutting. Smaller section. So the idea is to have vertical margins all around. Do not saucerize the rest of the mastoid. You just need adequate space for you to start the posterior tympanotomy.
This is very, very important point. We should not saucerize.
Action block. So in classical cochlear implantation, we spend extra time in having the tie down holes. We also make a bed.
Yes.
And then we collect bone dust to actually put on the electrode channel as it goes into the mastoid. These steps are now generally avoided in minimal access.
Yes.
It does save time, but I think the outcome is pretty much the same whether you do it. There are some people who actually continue to still create a RS bed and also a tie down hole and put some bone dust on the channel with minimal access also, which is absolutely acceptable. Whatever has actually worked for us over so many years has got really some weightage, isn't it?
Old is gold. So still
Always gold. When I have some difficult anatomy, I don't actually prefer this. I always go conventional.
So, good morning. So, we'll have a short presentation on the case. So, we are going on with the second cochlear implant by Professor Dr. Raghurandan.
Some questions are coming. Okay, right. Rupak, you can go ahead just to present this case.
Sure, sir. So, we are presenting a case of a 2-year-old child who was brought with a profound hearing loss. So, the child was under a no consanguinity of marriage and a normal birth history. Perinatal history was also found to be normal. Had a cesarean section and no postnatal events of birth. So on general examination, the patient was normal with no events. And on your examination, clinically, the patient was normal. And oral cavity oropharynx examination was also normal. The child was under the Chief Minister's Comprehensive Health Insurance Scheme in Tamil Nadu and approved for the same. And so the baby had initial complete audiological evaluation done, which showed a profound hearing loss with bilateral A-type curve. And the TPOA showed a no response, and the PERA also was found to be negative, implying a profound hearing loss. So on hearing aid trial, which was not benefited by the patient comes under the scheme of a cochlear implant. So coming to the CT initially done preoperatively, the CT had a coronal section, which showed a normal anatomy with a normal cochlea and a normal IAC, which shown in the figure seen here. And the cochlear facial distance is usually measured to know for the ease for going through a posterior tympanotomy approach.
Yeah.
This is a CT scan report of the same.
Yeah, smaller section, smaller bar.
T2 weighted MRI was also done to look for the CSF space around the IAC and to look for the nerve anatomy. The 7th and 8th nerve was found to be normal in this patient, which promotes our ease to do the procedure.
Drill again.
The MRI report. That's it. I'm handing over the screen to Dr. Raghurandan.
Okay, we are able to see the incus.
Yes, so we've just got into the additors there. You can actually see the incus. Here again, we should be exposing the short process incus. Actually, as Mohan sir has already mentioned, the tip of the short process will be pointing towards the facial nerve. That's a very important landmark because we want to be absolutely sure. Most of the fear that we have for posterior tympanotomy is with regards to the facial nerve. But in fact, if you're closer to the facial nerve, you'll have more confidence and you'll get more space to expose the round window. And the fear of the facial nerve takes you away from it.
So dissection very close to the facial nerve is better.
Yeah. So basically, most often there is a sentinel cell which opens up.
Yeah.
And I'm sure senior otologists would always look for the sentinel cell.
Sentinel cell, yeah.
Once you find it, it's easier to get in there. So you can see that cell coming up there.
Yes, yes. We are
And in
able
fact, if I put suction, it's coming down. So you can actually see that's a way of confirming that you're in the middle ear. So the other principle here is to keep the incus bridge as thin as possible.
We're talking about incus buttress.
Yeah, incus buttress, because sometimes it hides the view, especially to look for the incudocipitال joint. And always remember the facial nerve is inferior and medial to the lateral canal zone. Smaller suction, please. Smaller cutting bar. Thick. You can actually see that the sentinel cell is opened up here.
Yeah.
Okay, can I have a smaller suction and smaller cutting bar? Counterangle. Okay. Any questions, please?
So,
Raghu.
Yes, sir.
The Doin Kitne sir is watching.
Oh, we honor for having Kitne sir watching.
Yeah, great.
Definitely.
Beautifully. Very good dissection.
My early years as a PG, I was watching you, sir. So that's a
So he's
circle of life.
doing it, sir. Yeah.
Pleasure to have you here, sir. Thank you.
Yes.
Thank you so much.
It's a pleasure watching you operate.
The important thing, Kitne sir is always interested when his students are.
Absolutely. I've learned so much from him, sir. We had the pleasure of hosting him here in our conference long back. We really look forward to another opportunity.
Many times he is telling. He's
Malaba?
interested in his students doing the surgeries.
So with the
Have a smaller bar, please.
I would ask few questions that are there. How to manage
Counterangle, smaller cutting bar. So kind of
questions, Raghu.
Yeah, please. Any questions you can ask. You're kind of seeing the stapedius tendon now, so I know where I am. So I'm going to go down. Generally, the round window is about 2 millimeters below the oval window, 2-3 millimeters. So the most important thing here is the pyramid. If you actually can see the stapedius attaching to a pyramid, you know the facial nerve is just behind that.
Retropyramidal.
Yeah. Sometimes you can have a high riding chorda in front.
One or two questions are coming, please.
Yeah, please, we can go on.
So from Calcutta, Dr. Rahul is asking, please explain the landmark of posterior tympanotomy.
Yes, sir. Okay.
Yeah.
The landmark for, of course, the beginners. So it's a triangular space, basically bridged on the top by the incus buttress. Posteriorly, it's the facial. Yeah. Yes, sir.
Pointer and show that.
Yes. So okay. I have a little bit more work to do. I'll just finish that and get back to you. You have a bigger bar. So the most important thing, as I said, is to see where the pyramid is. At this point, I would like to tilt the patient towards myself. Okay, once you do that, you can actually see the round window niche coming up.
Beautiful. We are able to see the pyramid and the stapedius.
That's again something that we always tell our implant fellows, you know, because the small little angles of the microscope and the patient make a lot of difference. I have a slightly bigger burr. And people tend to go for very small burrs here, but I think better to actually have a slightly bigger burr, which is adequately taking away the bone, chipping away at it. Yeah. The other trick is to actually put the suction in the adductus here as you drill on this side, so that you're not hiding a view. And you may not have enough space for two instruments, and sometimes if there is a tight posterior tympanotomy. So there you can see the round window coming up.
Yeah.
There is different arguments about whether using a diamond burr or a cutting burr. I think it's surgeon's preference, isn't it? The cutting burr is less harming than a diamond burr because diamond burr causes more heat and it compresses the bone. Your view may actually get compromised sometimes. A cutting burr is more precise, better controlled, but I think the surgeon is safe or unsafe, as Mohan sir would always say. It's not the equipment, it's the surgeon. So you can actually see the round window. I usually go slightly below that so that we actually get to the lower lip to see a bit of the hypotympanum, because that helps in the angle of insertion.
Yeah.
Because many people stop this when they see the round window. It's good practice for us to slightly go below and expose more of the entire round window membrane, because we all know that the round window membrane is about 90 degrees to the posterior.
To get the nice trajectory.
Yeah, so you get more angle of insertion. Okay, you can see the nice round window membrane there. I'll zoom in. Oh, that's clear. Can I have a cochleostomy suction? Yes, sir.
Question from Chengalpet.
Yes, sir. I have a pic, please. The some soft tissue which I'll remove here. Cochleostomy suction, please.
Grade 2. There was a question from Vishakhapatnam. The grade 2 round window visibility.
Yeah, I think that's an interesting paper which is going to be discussed in CGCon as well, coming up in 2 weeks. There are different classification systems, but practically for us, it's the visibility, isn't it? So if you do a posterior tympanotomy and see the entire round window, it's probably grade 1. So where you actually are right on the round window. This is maybe a little hidden, partially hidden. So maybe grade 2. Grade 3 is when you can negotiate up to the facial nerve and then see it. Grade 4 is where, in spite of even exposing the facial nerve, we can't see it. That's a simple, I think, surgeon's classification.
You see where he is removing the tissues now.
Yeah, because all that
to the facial.
Yeah,
you might encounter the stapedius muscle itself.
This is stapedius muscle, yes, sir.
So no, the pyramid has the what you're showing is the tendon.
Yes.
Sometimes that pyramid is large and overhangs the.
Correct, sir. Very true.
Move that area. Time you might expose the stapedius muscle. So you're suddenly worried that you've got something soft over there. But if you know where your facial nerve is, then you're not worried. And the second thing is, if you were to expose the facial nerve like that, it would bleed. The muscle doesn't bleed that much. So
absolutely,
you're forced to actually take out a part of the pyramid to expose the round window. The pyramid is large.
So when we are searching the round window towards stapedial tendon is better.
Right. So sir has asked me to do a cochleostomy, and even though I can see the round window very well, I think it's just for a learning a different change in the approach to implanting electrodes through a cochleostomy. I think
planning for cochleostomy, yes.
Yes.
Here you have to remove some more bone.
Yes. So you're actually seeing the round window membrane here very well. Okay. And cochleostomy site, I'm using a skeeter now. Is generally antero-inferior to the round window.
The marker, please show the right.
Can I have a pointer, please?
The site of cochleostomy, antero-inferior.
Yes. So you have the round window niche here. Okay. Yes. So this is the anterior part of the round window, and your antero-inferior bit is here. Can I have the skeeter, please? Where exactly my suction is?
Actually, the round window right now for you is so ideal for a round window.
So it's up to you, sir. Can I go through the round window then?
I think if
just for
you have to obey the boss.
Yes, sir. No choice.
Just for demonstration purpose.
Yes,
show the height of cochleostomy.
As a learning, yes. So Skeeter is a high torque, low speed drill system. The advantage of this is it gives you good control when you're actually drilling. because it doesn't slip through and it doesn't damage, especially when it comes to cochleostomy. You don't want to push the bone into the lumen of the cochlea. So just gently.
0.6 or 0.8?
This is 0.8, I think, sir.
0.8.
So there's a question from Pune, Dr.
Yeah.
Singh. Can you please explain the extended posterior tympanotomy?
Yeah, so sometimes it's very difficult to visualize the round window. Maybe there is some hypertrophic mucosa over the promontory, and there's probably a grade 3 or 4 round window. We would want to see more of the round window to actually see where we are. So as part of an extension of the facial recess or the posterior tympanotomy approach, we have to sacrifice the chorda. Okay, so that's the cochleostomy coming up.
Yes.
The biggest advantage with the cochleostomy is you have an end-on view into the lumen. Sometimes with the round window, we never know because the angle of the round window is also of different types. And the hook region, again, we all have talk about the hook region.
Okay, we can see the lumen.
Yeah.
When the bone does goes in, what will
That's
it
what
do?
I'm doing, sir. So basically, soft insertion. We can actually see the undersurface of the basilar membrane now.
Yes, sir, yes.
We should not apply any suction into the lumen of the cochlea. At the same time, if there is any residual hearing, we should minimize the trauma through cochleostomy. Because cochleostomy by mechanical trauma, thermal trauma can also cause.
Yusuf, can show us the basilar membrane if you that you.
I will widen this a bit, sir. Diamond bar, can I have a diamond? I have a smaller sucker, cochleostomy sucker. We are right underneath the basilar membrane there, in the scala tympani. And just smoothing the margins, just to make sure that the electrode goes in smoothly.
Yeah. Will probably reduce the bleeding as well.
Very true. So that mucosal ooze is a little nuisance. We'll put a adrenal soaked gel foam there when we actually are anchoring the RS coil.
So prior
That's
to
good.
do that, can we elevate the mucosal flap
For
before making the opening, you mean?
Opening.
Take the mucosa away.
Yeah.
Sometimes, yes, sir. If we find real thick mucosa on top, we actually do all that work.
Yes.
Only then we'll do the cochleostomy.
Okay.
Can I have a diamond, please? Diamond bar. The small ooze, which I'll stop from here. But I think that's adequate space for us to.
Yes, sir.
Yeah. So I'm just zooming in to see hopefully the undersurface of the.
Bring it to the center. Okay, sir.
Yeah.
Yeah.
You can
That's zoom in. Very nice cochleostomy, Raghu.
Thank you. Thank you. Little small ooze from here.
Yeah.
Irrigation stop. So I'll have an adrenal soaked gel foam. In fact, you can see the undersurface of the basilar membrane scala tympani nicely. Stop irrigation, please.
Repeated bleeding is there. No?
Just a little bit. No, in this corner. Gone. So adrenal soaked gel foam. So next we move on to how we anchor the RS coil in the subperiostal pocket.
I was waiting for you to point out the basilar membrane. Could you show us?
Oh, okay, sir. I'll go back to it. Can I have a smaller cochleostomy suction, please?
What's the size of the suction tube? It will be here.
0.6. Ideally, they say the cochleostomy should be as big as the suction tip. So it should be able to snugly fit there. That means the electrode will go in. Right. Can I have a needle pointer? There you can see the undersurface of the basilar membrane. There.
Okay.
We are not able.
Not really able to appreciate because
focus.
of the blood.
Not able to appreciate. Fine focus.
Sorry, 1 minute. Yeah.
Yeah.
Beautiful.
Yes.
There you go.
Excellent. Superb, sir.
Superb.
There you go. I don't want to put suction into that. Okay. All right.
Excellent.
So the adrenal soaked gel foam. So that helps to actually get some hemostasis when we are actually going to get the RS coil bed ready. Can I have some adult soap gel form? Yes. Yeah. Thank you. Leave.
Yeah. So there's a question from Calcutta. Why are you doing cochleostomy when the round window is already visible and electron can be
No, I
inserted
think
through
he
it?
has answered that
just
because
for-
he just wanted to demonstrate. Ideally, he could have easily gone in through the round window. It's only demonstration purposes. He made
Okay. Yeah. Just to see a different perspective. Yes, my boss. Now, can I have a retractor to Langenmax, please? Have they checked the implant?
The surgeons want to learn different techniques.
Yes, I think you should learn everything and then follow your own choice. I have suction. So before we open the implant package, we always check the implant, make sure all the electrodes show high impedance. I think our audiologist can show you that, just to make sure that the device is okay. So
we have to cut off the electricity.
Tell me one thing, has it ever happened when you do this check that the implant was not okay? Has it happened even once?
Yes, sir. I think
has happened.
I'll give a mic to Mohan, sir. He can explain it. I think.
Yeah, but it's happened to me.
Yeah.
The thing. And then I got to gauge it and then after. Later on, they told me it is fine, there's the software, is there, but anyway.
Sorry, Mon, your voice is not clear. Yeah.
We'll get the
It's
mic.
happened to me once. They tested and it was not very good. So I said, no, change it. Later on, they said it's the software glitch and all that, but whatever it is, it's happened once and I changed it and then it became okay. So it may happen. I don't think it happens very often, but it may happen.
Yeah, because even with advanced bionics, we do it for every case. But so far, I have not.
One more retractor here. One more retractor here. So we've checked the implant and we are opening the package. This is standard array. Inserting this should be very gentle. So can I have a hover? So we actually ask our assistant to lift the subperiosteal package in such a way that we actually put the dummy once to make sure that it's fitting up nicely. There you go. It's gone in nicely there. Can you remove that? Okay, so it's nice and snug, and this is the flattest part of the temporal bone here, and the whole template RS coil bed should sit flat on the bone. That's important. It should not be lifted off. And retractor. The other thing is about the lower margin here. You can actually see that I have not elevated any of the soft tissues, so that the soft tissues will fall back and prevent the implant coil from getting displaced this way or the other way, here as well, in the corners.
You have a suture line on either side, so it will prevent the implant from
migrating, sir.
Periosteum is tethered down over there.
Correct, sir.
So it will not allow the implant to move.
The package should be a narrow package.
Possible.
The periosteum should be tethered to the bones.
Yes. Suction. Can we have the implant, please?
From now.
We'll change gloves and we'll cut off the monopolar.
Yeah. How often do you get the facial exposed while doing posterior tympanotomy, and how neurologically exposed facial behaves post-operatively?
If you expose the facial nerve and the sheath is intact, there is absolutely nothing to worry because the sheath is very, very strong.
It is
Now,
having
the problem comes in if you open the sheath and the fibers are exposed, in which case I would suggest do a little bit of decompression on either side. So there is not a knuckle of the facial nerve coming out. You decompress a bit on the other side and make sure that your electrode doesn't press on that part of the nerve. Yeah. But using the sheath is no problem.
I think we can go up to epineurum.
If the sheath is exposed, the sheath is so strong. No issue.
Right. Thank you, sir. And there's one more question from Indore. What are the reasons to not use unipolar cautery?
So you can unipolar cautery. If you're doing the second, if the patient already has another implant inside, then you don't want that strong current going to that implant. So you use a bipolar. If you're using a unipolar on this side, there is no issue at all. And Only thing is, the less tissue trauma you treat, the better your healing is.
Okay.
Raghu?
Right, so I've actually placed the implant in the coil in the subperiosteal pocket, but this being a scheme patient, government has got to actually have evidence that the implant is inside, so we're going to take a photo.
This is the electrode the government is supplying to them.
Remove it.
Normally.
Yeah.
Government is not supplying this electrode.
Can you say that you take a photo just to prove that you put the implant in?
Yeah, we have to take a picture of the electrode inside the patient.
Along with the serial number.
Along with the serial number, and then load it up.
They will check the serial numbers, sir.
Yes.
Yeah, unique serial number for each patient.
The patient also has a serial number.
Yeah.
So we're just taking a photo.
So having that packet, so it is also having the same serial number.
Yeah.
The government will check.
So we write the serial number here. Okay, and along with that, the implant is taken.
So you take a picture with the patient's name also written.
Correct, sir. Yes, sir.
That's a good idea, yes.
And post-operatively, we also take a picture of the patient's face once the wound is closed, and the post-operative X-ray sternus view.
The surgery is going on, they will keep a mirror, sir, in front. They will take a photograph of everything, and we have to submit it to the governments.
Sorry, mirror in front?
We have to keep a mirror, and we have to show the eyes of the patient, the number, everything. When the surgery is going on.
So we have a mirror with the patient's name written, so we can actually take a photo of the post-oral area with the face seen on the mirror.
There will be audit, sir.
Yes. Gauze, please. We can actually see the entire coil is gone in. There is no exposure of the wound. It's sitting nicely here, and only the electrode channel is coming out either way. And we don't need to actually do any
silver bed and
holes or web suturing, all that. And because the less the trauma over the RS coil, better wound healing. That's the idea with regards to the minimal access. So I'm just going to suck out.
Interested in this mirror thing. The mirror is put first, taken a picture, and then you remove the mirror.
Yeah. Right. Mirror as a picture, mirror with the name of the patient.
And is it there all through the surgery, or you just put it?
No, just
put it once and take it off.
I
don't know whether anybody actually looked at all the pictures.
I mean, it tells you how much the government trusts the doctors, but
Religiously load all this stuff.
Suction, please.
There will be hundreds and thousands of these photographs with the government.
Suction.
I don't know who's looking into it.
Suction block, please. So I'll just remove the adrenaline soak gel foam. Just check for hemostasis, and then we can go ahead implanting the electrode.
Yeah.
Suction first. Suction, please. Currently suction.
Raghu, you don't create a tunnel here, right?
No need.
No tunnel, no drilling, sir, no bed, nothing, no bone work.
Ugly fitting packet, sir.
Yes, it's all only the soft tissue work with absolute flat cortical bone.
Okay.
Raghu, one modification that you could do is where the array is crossing the cavity edge.
Yes, sir, you can. Yes, sir, that area.
That if you drill a depression and sort of just.
It'll help, yes, sir. I'll do that for you. I'll do that right away. A small drilling, cutting work. It'll help to ease the electrode into the mastoid better,
that's right.
rather than having a sharp head. In fact, sometimes we've had the shearing effect of the channel as it comes into the mastoid, causing some trouble. A few implants have had some slightly bigger bump. In adults, we generally don't.
Dr. Sunidhi from Chitradurga is asking,
yes,
intraoperative facial nerve monitoring is required.
Yeah,
absolutely yes.
Ideally, absolutely yes, but it's an additional expense because our hospital charges extra for the use of the implant. So for the patients, especially those who are from the government scheme where you want to keep the cost down. But if you say ideally, yes. As a matter of fact, ideally it should be used even in routine mastoid and parotid surgery.
Yeah.
But that is what an ideal situation would be.
But I think without that, they won't give the permission for center approval, sir.
Block, section block.
Permission for?
Approving the center by the government.
So you just show the
suction
that you've got a nerve monitor, but don't use it.
Hold the electrode.
So Ravi, the question to you is, are you using nerve monitor just now?
Yeah, are you using nerve monitor?
I think you answered it well. Actually, correctly speaking, we should. In Europe, for example, or in US, you can't do a blood flow.
Even for a meringoplasty, they ask for one.
They ask,
It's a litigation, medical legal.
Here it's a lot of people don't use it because
No, Mohan, I've operated on a submandibular gland where the patient was taken on the table in the UK, anesthetized, and then removed because their nerve monitor was not working.
Cochlear suction.
Came to India and got it operated. He says, "What about nerve monitoring?" So I said, "I'm sorry, we don't have one." And happily, his submandibular gland came out without giving him a marginal mandible.
Actually, I think what we do here, if there's any abnormal anatomy, especially our cochlear and all that, we use the patient monitor. Otherwise, generally straightforward implant, we don't talk to them.
Yeah, but I mean, technically speaking, yes, ideally you should.
You should, yes.
Watch the direction. This is so important. Look at the direction in which is put.
Yeah, the trajectory.
Slowly. So the angle is antero-superior medial. Follow the curvature of
the curvature of the scala tympani.
Exactly. Just below the basilar membrane.
Yeah.
And do it slowly. No rush.
This is
hold it at the marker ring.
Nursery rhyme to be sung every time for one elect.
Over a period of 2 minutes, they say.
Over the period of 2 minutes, yeah.
Suction, please.
Some say 2 minutes, some say 5 minutes, some say 9 minutes.
Raghu?
Yes, sir.
You are asking for the suction tube. What is the size of the?
This is actually 1 mm, I think 0.6 to 1. Just sucking around I won't put any suction around the round window.
Yeah.
Just to get my view clear.
Okay.
That's it. So
there's slow.
So there's a couple of questions.
Yes.
Can we use dexamethasone soaked gel foam over cochleostomy?
Sure.
Yeah, I think when I answered this. A lot of surgeons use dexamethasone, even flooding the area and creating a lake and putting the electrode through it. So all that is meaningful if you are trying to do a hearing preservation surgery.
When you're opening the round window, what they do is they pour dexamethasone and through that pool of dexamethasone, open the window and put the electrode.
That's right. So it's what they call a steroid lake. So it's basically all that is important in hearing preservation.
Suction, please.
Sir, when there is a fluid gush, what will you do?
So there is a related to that. Dr. Vaibhav from Nagpur is asking, after opening the cochlea, if you put adrenaline soaked gel foam, won't it affect cochlea?
No, it's all right.
After opening the cochlea, you would not use it.
Not inside the cochlea, no.
We will not
just in the middle ear.
And adrenaline is not toxic to the or the cochlea.
Even then, yes, once you have opened the cochlea, you would not want to.
I want to put anything in. Yeah.
Smaller suction.
Sir, when there is a fluid gush in that area, what will you do?
CSF, you mean?
CSF gush, yeah.
Yeah, you'll have to take connective tissue and seal it tight. Make sure that the gusher stops. And like we said, you also make sure that the other part, oval window, is not affected. I've had cases where we closed the round window gusher and the fluid still kept on coming in. I was wondering, if I've done such a tight closure, why is it still gushing? And then you looked at the oval window and there was a gusher from there. So we had to go and close that.
So taking a fascia and making a small hole, introducing the electrode through that, and can you introduce like that?
For the oval window, you mean?
No, when the
yeah, so I take a strip of fascia.
Yeah.
Because the fat, when you try to use fat, it keeps on bouncing out.
Yes, sir.
So
Fascia is
If
better.
fascia or a periosteum
Periosteum is better.
is better to you.
Yeah. Soft tissue. So the markering has gone in.
Yeah.
Yes.
So full insertion went in smoothly and did it over a slow 2-minute time.
You can still see a part of the cochleostomy in front.
Yes. In front, sir. Yes, sir.
So it's quite a biggish
Ah.
cochleostomy that you made it for us to look at the basic.
To look at the extra bit of the basal membrane. You don't require that much.
Oh, no, that was for our benefit.
But the markering went in that way. That's why.
Yeah.
So I'll just put some soft tissue. Plug that small area in front. The other advantage with this minimal access is you can actually immediately start testing because that area where the RS coil is fully undisturbed from surgical field.
But by intact skin.
In fact, many people do a switch on the very next day.
Yes. We are having a paper on that in CG.
Classical example is Abdurrahman Hajar, Saudi Arabia. He insists on doing the implant and the next day switch on and then send the patient. So his argument is, they've come here all the way to here. Why do you want to send them without here? So that's his argument. And because for that, this kind of minimal access approach is ideally for me.
One more soft tissue. So it's nicely sealed. So we support it inferiorly also because there is a tendency to slip downwards. So we actually have soft tissue anchoring on 3 sides. Posteriorly, you have the canal of the posterior tympanotomy supporting it. Soft tissue. Actually, we can start testing. So we can actually show you the ART and impedances from an audiologist perspective. Right. Okay. So this attic loop we have to create. AOS. 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 The jewelers, okay? As Kirtane sir had said, this saucerization helps because there is no sharp margin there as the electrode descends down into the mastoid.
A small channel, that area.
Yes. Option, please. Cochless neuron. Right. So we have adrenal soap gel pump. So that's pretty much it. So now I'll start closing the periosteal flap. So you can actually see that the periosteum falls back nicely on both sides, covering up the mastoid. Yeah. It's just to support the posterior end of the posterior tympanotomy. Right. Okay. Then we can cut the tied threads, stay sutures. Gauze piece. Knife. Yeah, you can cut. Thank you. Remove those things. Sutures, please.
Raghu?
Yes, sir.
Question to Mohan, sir.
Yeah.
Yeah, I'm listening.
Statistics, sir. The number of cochlear implants in Murph Institute.
How many have we done? I don't understand the question.
How many, sir? How many have we done? Statistics.
How many have we done in, I think over nearly 5,000 now. Over 4,000 from.
And number of ABAs?
ABAs about 90, 89 or something. It is all from the very beginning, if you are right from, we start. But, statistics doesn't mean anything. After 1,000 implants, you can get into a problem.
After the second implant, you get into a problem. So problems can always happen. You will always be prepared. Every case you have to take as a fresh case. Never feel overconfident just because you've done. In fact, the statistics are that the more you do, the more likely you'll see problems.
So you can actually
Two
see.
doins, both the people are very humble.
No, I don't think
Sir
so.
and
I
Ketan.
think both of us have seen enough with practical. Realistic.
The one we have to learn from these.
So we've already started testing the implant. You can actually see the transmitter coil is sitting on the RS coil. You can see how far it is from the actual wound.
Yeah.
So this heals very nicely. Basically, the wound is restricted to the mastoid. You can even do a smaller incision, but today we went a little bit beyond. Maybe you can reduce some more. So this is totally away from the wound. This heals separately, and our audiologist will show you the responses now.
Yeah. It avoids post-operative infection, biofilm formations.
So impedances are fine, all electrodes. That shows
Can you
it.
see the NRT?
Yeah. Yes, sir. We'll change the camera.
So you are saying the fellow is, with the permission of Mohan sir, I'm telling, is Setu, he is my son.
That's
supposed to be a secret which you're not supposed to say to the lab.
Sorry, sir.
Yeah, Setu.
I could have directed the questions to Setu, sir.
So 11th electrode they are testing. Okay. Yeah, it's working.
Excellent.
Super,
Raghu.
excellent. Ninth electrode. Yeah. ECAP. Seventh electrode.
Hold that. Hold tight.
Sometimes it happens that you don't get the ECAP on one or two electrodes.
Yeah. I think, as long as you're,
Ninth electrode ECAP. Yeah, we are getting.
you're confident that you've got the electrodes in place and everything is fine, because there's a bit of blood, the cochlea, or an air bubble can interfere with it.
So subsequently, when you test, they all come.
Yeah, as long as you got more than 75% electrodes function, you can leave it and then do it again and then
Raghu, excellent, Raghu.
Thank you, sir. So,
Claps from the audience, please.
Absolutely. Superb job.
Thank you so much, sir. So we are using monochrome.
Able to hear?
Yes, sir. Thank you very much. Pleasure to have you, and Kirtani sir appreciating this, sir. Thank you so much.
Nice, very nice.
So the most important, this is the
You are
most
doing the surgery in front of two doins, no?
Yes, absolutely.
And
So many more watching as well. Thank you so much.
As
Very good.
Dr. Jankiram, he told, nearly 8,000 doctors are watching now.
That's great, sir. Very nice.
Great show.
Pleasure and honor to be here. Thank you so much.
Yeah, great show.
So you can actually see it's falling back nicely.
Yes,
I have not sacrificed any periosteum. It comes vertically.
We are seeing you. We are not seeing the wound at all. Yeah, that's better. Thank you.
Oh, okay. Okay, we shifted to the microscope, please.
Thanks for showing the surgeon and the assistant. Thanks, sir.
Excellent. Excellent.
Can we have to the microscopic picture, please?
Yeah, great.
It's switched over. It's not in microscope. Okay.
Yes.
What you're seeing is
testing, all electrodes are fine. So we are closing up now. Just wanted to show all ECAP responses are good, the audiologist says. So,
the post-oral, the bandage that you put, how many days do you keep it on?
we take it out the next day and put a prep for first 24 hours. We put a elastic wrap bandage. Next day, and we remove it, check it. If there's no collection of hematoma, then we just put a elastic wrap bandage. After 48 hours, patient is discharged.
After 48 hours?
Discharge.
Oh, discharge after 48 hours.
Okay.
So is there any difference, sir? The minimal access and the
sir,
discharge.
Here we follow the same.
Same routine we follow for everybody.
For this patient, okay.
Yeah.
So for adults in the UK, as a daycare surgery, 24 hours they, yes.
Even the US also, even
Yes.
in
the children's hospital of Philadelphia, CHOP and all that. They do it as a day case. They do it in the morning and evening. They do.
Yes, sir.
Patient goes home with the bandage and they take the bandage down themselves. They come to see the surgical nurse in a couple of days for wound checking. That's all.
So when will you ask the patient to come for
Switch on. When they come for switch on, we see them.
Yeah, usually here we do it on 20 days, 3 weeks.
Sir, 3 weeks. Sir, not audible, sir. 3 weeks.
3
Sir,
weeks. 20 days. 20th days is when we 10th day switch removal and after 10 days, 20 days.
Sir, in abroad, sir?
Most places is 3 weeks. Some sectors do it earlier. Rajit actually initially did a cohort, a study where he did a lot of children in the first 24 hours. And he said there's no change in the map or anything. But I'm more comfortable allowing them to heal first and then.
I think in the tropical environment with the sweating and hygiene, we are
very worried about sweating, hygiene, all that. So giving it full time to heal completely, sutures removed, and then after that, then we go.
So I've closed the entire mastoid cavity. Coming up to this part where the hockey stick incision was made. So this is again away from the RS coil bed. So you can actually see how much distance is there from the actual incision mark and the coil.
So it's very important that you get a periosteal cover over the cavity.
Yeah. Correct, sir.
Otherwise, the scar will tend to sink inside the cavity.
Absolutely.
Incidentally, talking about the children of ENT surgeons, you talked about Setu here. Similarly, he's a very successful surgeon's son now. Gaurav, Tikiri, Vinay, Vijayendra, and Satyanarayana, Janagram son, are very smart, very promising, and they're really doing extremely well. So, nice to see them coming up.
Do you think they have a genetic advantage? Huh?
Yeah, I think they have. I might have had, but I never used it.
they are fortunate to get trained by the Doyens.
Very good.
Please. So the entire periosteum is fallen back now. So then we'll proceed to the skin. So just routine cinch suturing. Then we put a primer pour and then a compression dressing as a routine. Any other questions we can take?
Post up protocol of MAF.
Usually we put them on a spectrum for 48 hours. After 48 hours,
not audible, sir.
48 hours in the hospital, they get IV antibiotics, broad spectrum cephalosporin. And usually after 48 hours, they go home with oral, oral cephalosporin. 10th day suture removal, 20th day activation.
After then, sir, follow up, sir.
Follow up, we don't generally follow up. It is followed up in the institute, audiology, where they have the mapping and so on. And if they have any concerns, they'll send the child to us. We see them. Otherwise, we see them usually after 3 months.
Yes. And just a couple of subcutaneous.
Sir, what are the, when will you, how will you select children for ABA, sir?
when they are not fit for cochlear implant. So basically, either they have visual deformity, or if they have cochlear nerve complete deficiency where trans-tympanic ABR is not showing responses. So things like that. But usually the most of the ABAs who have had in children are all people who have had visual deformity. There is no cochlea at all. So
And this is very important. Padma Professor Mohan Commission has started a ABA in Chandigarh also.
So you can see the advantage of minimal access. Described by Jerry Donahue, who happens to be a very close friend of all of us. The advantage is that you have very little, handling of tissues or roughening up of tissues, as you can say. So it's very minimal, injury to tissues, so that healing is very, very good, very fast, very good. And child is up and about in a very short time.
Respecting the tissues.
Yeah.
So in the UK, they used to use dermabond.
Yeah.
And we also have tried subcuticular also, so which has worked in fact. Instead of having the child to go through another anesthesia for suture removal, there's an option of having absorbable sutures or dermabond on top.
Yeah, absorbable sutures.
So now we have started doing minimal access mastoids also.
Tapless? No.
Publications, yes, we are working on it.
Oh.
Monocryl is a good monofilament absorbable suture.
Yeah. Okay.
A less amount of irritation to the skin. Wound healing is better. Less amount of granulations and infection.
Hello, Mohan.
Yeah,
We are now switching off. We'll be switching over to Vijay.
Yes. Thank you so much. Thank you for the opportunity. And thanks to Sun Pharma and you and Janaki.
Big hand of
Great opportunity for us. Thank you so much.
Mohan sir?
Yes.
Able to hear the applause.
Thank you. Thank you,
Yes, great, sir. Great show.
Thank you.
Thank you very much, sir. A pleasure to have you all.
A big thank you to Dr. Bapparao and Dr. Palaniappan for the moderation and giving us their inputs. Thank you very much.
Off, please.
We are now shifting over to Dr. Vijendra's setup. He's just getting things ready. So in the meantime, if there are any other points, questions you would want to discuss, any of you have any questions or comments to make, please go ahead. Yeah.
Skin, please.
Still expecting you, if possible, for the evening. Thank you so much, sir. Thank you, Murph team.
Thank you. Thank you.
Here.
Thank you for the opportunity. Thank you.
Thank you, sir. Thank you, sir. Thank you. Thank you, ma'am. Thank you. Skin portrait, yeah, come sit down.
Okay, while we are waiting, India is the only country where we have in all centers 95% children, 5% adults. In all the developed countries, it is almost 50-50 or sometimes 60% adults and 40% children. So what we have not really gone after is a large population of adult patients who all of you get. All of you get patients who come with hearing aids who are not very happy with their hearing aid performance. All of you get patients with single-sided sudden onset deafness, which doesn't recover with steroids and whatever treatment you give. These are all candidates for cochlear implants. So which means we have not explored that whole patient pool at all because we've not been very proactive in advising cochlear implants to these people. There are so many people. The oldest I have operated is 85 recently. He's doing very well with his cochlear implant. So as long as your old patient, elderly patient who comes and is not happy with a hearing aid, you can look at his physical and mental status, and if he's okay in both, I think you should advise them cochlear implants because not having access to sound makes them withdraw. Even changes that occur in patients mentally are far more rapid if they do not have access to sound. Therefore, the interaction with people stops. You have this patient population, which all of you see, but have not been advising cochlear implants. Look at it. Best thing to do is to ask them to go and do a speech discrimination score individually for each year and see if the score is poorer than 60% with the optimally fitted hearing aid. You can consider a cochlear implant. You have patients with ski slope curves where low frequencies are good, but the high frequencies are really sloping down. And these patients wear a hearing aid, they can hear louder sounds, but they are ones who say, I'm not able to follow conversation at times. These are again patients who can be helped with a cochlear implant. Do speech discrimination scores as a routine in your patients. And I'm sure many of you will pick up patients who can be helped with cochlear implants. So I think in my practice, the number of adults I'm doing now is slowly going up. It's becoming more than 10%, where at one time it was down to about 7%. But I think we have to keep on increasing that because today it's not unusual for a 75 or a 80-year-old man to walk into your clinic, ramrod straight, mentally all there, physically totally fit, just not happy with his hearing aid. We are waiting for Dr. Vijayendra to come on. I don't know what cases he's going to show. Who are the chairman for the session? No. Okay, so I think I would request Dr. Panigrahi. Debrata, you're going to be on the chair there with Dr. Ratnesh Kumar. Is Dr. Ratnesh Kumar here? Yeah. And the one and only, is he here? The big boss, Dr. KP Morwani. Maybe he'll join us. He's not there. Oh, he's not coming. He's not here. Maybe he'll come on. Okay.
So 3 of the CVs will take and Vijendra sir CV will replace you too.
Okay. So, has he come? He said he would be coming. Okay. Okay. So, you're going to introduce the chairpersons? The chairpersons.
Just a minute.
So in the chair now for this session, we have Dr. Panigrahi, who is a former professor and head of department of ENT in Bhubaneswar, is presently working as a senior consultant at the medical director and chief ENT surgeon Dev ENT and Eye Hospital in Bhubaneswar and has done a fellowship in cochlear implant surgery from Institute of Cochlear Implant Training, Florida, USA. Has several publications in different national and international journals. Dr. Morwani, of course, will wait till he comes to introduce him. And Dr. Ratnesh Kumar did his MBBS from Pune and MS ENT from Patna. Is worked at the Municipal ENT Hospital, Fort Mumbai, which is like a factory of ENT cases over there. One of the busiest ENT hospitals in the city, and is working at present as an assistant professor at Patna. His special interest is in middle ear surgery and otology, and that is what Dr. Vijayendra is going to be showing us now. If Dr. Morwani comes in, just get me Morwani's biodata. Or we'll wait till he comes. He's on the way, so we'll wait till he comes in. And get me Vijayendra. We are now going to have the good fortune of watching one of the finest middle ear surgeons that I have ever seen, and that's Dr. H. Vijayendra. He's an MS DLO, he's the director of the Vijaya ENT Care Center in Bangalore. He's a past president of the Indian Society of Otology, and he's an advisor to the Indian Society of Otology. He's an honorary visiting professor at the JN Medical College, KLE University, Belgaum, and also University of Bijapur, honor professor at the University of Illinois Hospital and Health Sciences, Chicago. His following techniques have been named after and published in reputed journals as Dr. Vijayendra's technique. Technique of transcanal facial nerve decompression, technique of facial nerve grafting without suture, attic retraction pocket classification system, and technique of management of pseudocyst of pinna and preauricular sinus go by his name. So he's done us proud. He's put us on the international map. He's an author of 2 books, Color Atlas of Temporal Bone Dissection and Otology Demystified, which came out recently. A diagnostic atlas of autoendoscopy with some absolutely fabulous colored pictures. He's conducted 5 international live surgical conferences successfully in 2017, 18, 19, 22, and 23, and about 800 to 1,000 delegates attending each time from all over the world. So we are just waiting for a signal from the clinic of Dr. Vijayendra to set the ball rolling.
Hello, good afternoon. Respected my beloved teacher, mentor, Miss Dr. Kirtane sir, and Dr. Morwani sir. In pillar behind this workshop, none other than the dynamic Janaki Ram from Trichy. And I sincerely thank Janaki Ram for giving me this opportunity. This is in collaboration with the Mumbai AOI West branch, where Professor Kirtane is in charge. So these 2 doyens have arranged this wonderful workshop. So it's a great pleasure and honor to be a part of this workshop. I sincerely thank the Sun Pharma people for doing this wonderful workshop. Arrangements has been made where Janaki Ram has told nearly 8,000 delegates have been watching this live stream. It's really a great honor, and hats off to Janaki Ram. So the case which I have selected, I had many cases in the last moment. Yesterday I got an interesting case of unrecovered Bell's palsy. So this is the case which I am going to demonstrate how I do facial nerve decompression. This I have been doing from past 22 years. So beyond doubt, I have proved that the vertical segment has to be decompressed. Not only the result, this thing, there's so many controversies, always it will be there, but personal experience and most important thing is results. almost all the cases which I operated for unrecorded Bell's completely they have recovered if I operated on time, that is before 3 months to 6 months. So this is my result. So far we have done in our institute from last 22 years, 147 cases we have operated. I can say almost 99% of all the cases which are they must have recovered from grade 6 to grade 2. So this is the results. The result speaks. That is the most important thing, not the controversy. So now I will hand over the mic to Nilesh Mahajan, and we have started the case. This I am doing at a local anesthesia. The local anesthesia preparation, what we do is we give pethidine 75 milligrams and Finargan 37 milligrams intramuscularly about 40 for 30 minutes before the surgery. And we have taken 10 cc xylocaine and 10 cc saline. To that, we added 8 drops of adrenaline and infiltrated post-auricularly. Now I am doing this decompression through post-auricular approach. Already I had done a cortical mastectomy and handed over to Vinay. He will be doing the rest of the thing. And I hand over the mic to Nilesh to narrate the history of this patient. So, sir, thank you very much, sir, Kirtane sir, and Moroni sir, to be there as a moderator. Thank you so much, sir. It's a really honor and pleasure. I once again thank Janaki for this opportunity. Thank you very much.
Thank you so much, sir. It's our honor also to share the stage with Kirtane sir for some time. And Morwani sir is on the way. He will be joining the panel soon, sir. Thank you so much.
Over to you, Dr. Mahajan.
So good morning all. Welcome to India's Elite ENT Club Season 2 conducted by Royal Pearl Group of Hospital in association with AY Mumbai West Branch. So the case we have selected here is a case of unrecorded Bell's palsy. So this male presented to us yesterday only, 46-year-old male presented with a right-sided facial weakness since 84 days. So you can see the tympanic membrane, it is absolutely normal. The external auditory canal, the tympanic membrane, the middle ear through the tympanic membrane, even you are able to see the shadow of the IH joint also, the handle of malleus, pars tensa, the promontory, the hypotympanum, the round window area, the posterior superior part, everything is normal. So you can see there is a complete paralysis on the right side of the face. When patient starts to close its eyes with the force, he is not able to close the eyelid completely. There is a gap between the eyelid. And in video, we can make out there is even Bell's phenomenon present. That is uprolling of the eyeball in the outer part. So you can see there is a severe palsy on the right side. When he tried to show his teeth, you can see the angle is totally deviated to the normal side. That is the left side. There is no any movement at the right angle of the mouth. Coming to the frontalis, wrinkling is totally absent. You can see in the closer view also, there is no wrinkling over the forehead. Then when patient try to puff his cheeks, you can see there is a weakness of the buccinator. This part is not able to hold the hair properly. So there is a hair leak and he is not able to whistle properly. So we did Shermer's test. So as here you can see the Shermer's test on the right eye, it's a 20 millimeter. This was recorded at the end of 3 minutes itself. It was not even 5 minutes over. So at the end of 5 minutes, you can see both the sides. It is wet, means it is 35 mm at the end of 5 minutes. So this is normal lacrimation, means Shermer test is negative. So if Shermer test is negative, that itself indicates that lesion has to be distal to the geniculate ganglion, because the GSPN, the greater superficial petrosal nerve, which is responsible for lacrimation, it comes from the geniculate ganglion and traverse anteriorly along the first genu to enter inside the middle cranial fossa. So first, this is the topodiagnostic text which has told us that lesion is distal to geniculate ganglion. Next, coming to, we see the video of this patient. So you can see here in the video, when he tries to close his eyeball, you can see uprolling in the outer side and face is totally paralyzed on the right side. So it is completely deviated on the left side. Again, the angle, there is no movement in the right side. It's completely deviating to the normal side. There is no movement in the frontalis. It's absolutely mask-like face, you can say. And when he's trying to blow, you can see there is a weakness in the buccinator muscle. He is not able to hold air there. And even whistling he cannot do because of the weakness at the angle of the mouth. So pure tone audiometry is showing normal hearing both the sides, 13 decibel hearing level in the right ear and 15 decibel hearing level in the left ear. Coming to the reflexes, you can see the tympanogram is a A type of tympanogram and all the reflexes are present. So again, reflexes are present means nerve to stapedius is also intact. Means this is the second topodiagnostic test which is telling us that the reflexes are present, means nerve to stapedius is also working. So first test, topodiagnostic, that is the Shermer test, told us the lesion is distal to geniculate ganglion. Second topodiagnostic test is acoustic reflexes. It told us that lesion is distal to the second genu because the branch to stapedius comes from the second genu. Then coming to the nerve conduction test, this is the left side and this is the right side. You can see the left side, the amplitude is 1.57 millivolt. If you compare to the affected side, that is the right side, it is 0.15 millivolt only. And here it is 1.54 and here it is 0.06 millivolt. So percentage wise, if you calculate, it will come definitely more than 85 to 90%. So to summarize that in plot, I have written here, this is left side amplitude. You can see it is 1.6 millivolt and 1.5 millivolt in the orbicularis oculi and the nasalis. And here you can see it is a 0.2 millivolt and 1 millivolt in the nerve conduction test. So definitely there is a severe decrease in the amplitude around the 90%, means only 10% conduction is happening, means there is a severe neuronal axonopathy in there in this case. So coming to the CT scan, so we got the CT scan done for this patient. So this is the CT scan of this patient. We are going to operate on the right side. So we'll go through the right side of the scan. So you can see the stylomastoid foramen. Here it looks widened. So this is the vertical segment. As we are coming up, entire vertical segment is intact. Then coming to the second genu, you can see this is the second genu area. You can see medial to that is pyramid. So second genu area. Then coming to the horizontal segment. So this is the horizontal segment. Then the first genu, geniculate ganglion and the labyrinthine segment, and finally the internal auditory matters. So here we want to see the status of the sinus because we are planning transmastoid decompression. We have to see how the sinus is placed. So here you can make out in the upper part it is quite flat, but when we are going down, you can see it is slightly anteriorly projecting sinus. So slight anterior projection is there in the sinus, but mastoid cortex is quite good here. Lot of air cells are there. Then we'll see the tegmen also because we are already doing the mastoidectomy. So tegmen also looks fine here. There are some congenital microdehiscences are there, but we need not worry because we are not going to that part. So these are the CT scan findings. So this is the CT scan 3D reconstruction I done with my software, Radiant DICOM viewer. So here visually also you can make out this is the left facial nerve and this is the right facial nerve. Visually you can make out there is a difference in diameter in the vertical segment of the facial nerve. So this is the consistent findings which we have got in all cases what professor has told now. We do the 3D reconstruction and we do the actual measurements, and though the measurements some 0.1, 0.2, 0.3, sometimes we have got 0.7 mm difference also in the diameters. Those are all statistically significant. So this is done in the workstation. Entire 3D reconstruction, you can see that is widening at the second genu and the stylomastoid foramen. There is a 0.3 mm difference in the second genu and 0.5 millimeter difference in the stylomastoid foramen. So visually also, if you see this nerve looks visually slightly wider than this side of the nerve. So coming to the MRI contrast, now we have started doing even MRI contrast also. So in MRI contrast, all the facial nerve, they will show the minimal type of contrast enhancement, particularly in the tympanic segment and the vertical segment. That will be the minimum contrast enhancement. Then there will be intense contrast enhancement in cases of facial nerve schwannomas. So it will be somewhat like this. It is the jugular bulb here. So jugular bulb and internal jugular vein, how the contrast it is taken, like this will be seen in the cases of facial nerve schwannoma. But this type of moderate enhancement we always get in the vertical segment in cases of all Bell's palsy. So routinely we do now MRI with contrast even in Bell's palsy cases to compare both the sides facial nerve. Now this side there is hardly any enhancement in the normal facial nerve. That's why it is not seen here. But you can see this is a moderate type of enhancement. You cannot tell it is a intense. To call it as intense, it should at least match this venous blood. So it is not as intense at this jugular bulb, but it is not normal also. So this we call the moderate type of enhancement. This we see generally because of fibrosis of the sheath. So our diagnosis is, it is a right unrecorded Bell's palsy grade 6 with negative Shermer test. Our plan is transmastoid facial nerve decompression. So you must be wondering, why are we talking about the vertical segment in cases of Bell's palsy? Everybody talks about the labyrinthine segment. So this is the myth which we have resolved beyond the doubt. If you see the evolution of the Bell's palsy management, in the era of 1931 to 1970, the first surgical decompression was carried out in 1931 by Arthur Duell, and he decompressed actually vertical segment. Then post 1970, that is called Yugo Fishira, he popularizes the labyrinthine segment decompression for the facial nerve. But in our experience, what is professor's experience in the case of 147 cases, we are returned to the past, that vertical segment decompression is the norm. So you can find out these articles, numerous articles are there before 1970 mentioning the pathology being in the vertical segment of the facial nerve. So, and these are published in good international journals. So this is one article, this is another. Like this, you will get numerous articles over the Bell's palsy surgical management before 1970. So if you try finding, this is another good article. You can see transmastoid facial nerve decompression in cases of Bell's palsy. Then this is the historical review where Professor Adar, he has clearly told that how the era changed from the stylomastoid foramen to the vertical segment, then it reaches to the second genu, then the people started decompressing the tympanic segment, and later in the Yugo Fishira, they reached to the labyrinthine segment. So these articles are available online. So this surgery is a transmastoid facial nerve decompression for unrecovered Bell's palsy. Dr. Vinay has already started this case. So the case will be transmitted live from Vijay ENT Care Center, Bangalore. So I will hand over mic to Dr. Vinay Kumar Vijendra to take us through the case in forward.
Thank you so much for the wonderful demonstration. It was a treat to watch. Yeah. Thank you so much.
Hello. Hello. Am I audible?
Yes, sir, you are audible.
Yeah. Good afternoon, sir.
Can you please describe whatever you have done till now?
Yes, sir. Yes, sir. So at the outset, I would like to thank the organizers for giving me this wonderful opportunity. So thank you, Kirtane sir, Janki Ram sir, for organizing this wonderful workshop, which I'm sure will be of great benefit to all the otologists. And also thank you to AOI Mumbai West and Sun Pharma for organizing this workshop. So Dr. Nilesh has already explained in detail about this case and why we decompress the vertical segment of the facial nerve. We've already started this case. Professor Vijendra has done the mastoidectomy just to save some time. And let me just show you what we've done so far. So there's a wide cortical mastoidectomy. It is always better to open the mastoid wide, especially when you're decompressing the facial nerve. To get access to the complete nerve, it is always better if you do a wide cortical mastoidectomy. So this is the right ear, and this is the antrum which has been opened. This is the lateral semicircular canal. This will be the level of the superior semicircular canal, and here you'll get the posterior semicircular canal. You can see the shadow of the curvature of the sigmoid sinus here, and you can see the digastric ridge over here. And also I've drilled out the retrofacial cells here. These are the retrofacial cells. And next thing I did was I thinned out the posterior bony meatal wall as much as possible. I still have to thin it out a little bit more so that it gets easier for me to open the facial recess cell. And also I've done an epitympanotomy here and just exposed the incus here. So this is the incus which I've exposed. This is the I have to still extend the epitympanotomy. Here you can see the short rows of the incus attaching to the posterior bony meatal wall, and this is called the fossa incudis or the incus buttress. So that is a very useful landmark when you're opening the facial recess cell. So to delineate the facial nerve through the transmeasured approach, you can go one of two ways. The first way is to open the facial recess cell here. So the facial recess approach is a very popular approach where you can open the facial recess and you can also you can visualize the round window. It is a very useful exercise to do a cochlear implantation, but also to find the facial nerve here, it is a very useful exercise. Another way is to follow the nerve from distal to proximal. That is by following the digastric ridge. So this is the digastric ridge here. And if you keep following the digastric ridge, it will blend into the facial nerve. In this case, I'll be going through the facial recess approach because we have to decide, delineate a little bit of the normal nerve as well. So as Nilesh sir clearly explained in the CT, the vertical segment is involved in this case. However, to get good results, one has to always decompress a little bit of the nerve, normal nerve, both distal and proximal to the site of lesion. So I'll be going a little bit towards the second genu and also the beginning of the horizontal segment. So that is the plan. Let me further thin out the posterior bony meatal wall. So here we do most of the cases under local anesthesia, and even this patient is very comfortable, and we're doing this surgery under local anesthesia. So already I can see the thinning out of the facial recess cell here. So the boundaries of facial recess are medially you get the facial nerve, laterally you'll get the chorda tympani, and superiorly you'll get the incus buttress. So this is a facial recess cell. I'll switch over to a smaller burr tip and further open it. Before I do that, I'll further extend the epitympanotomy because I want to see the incus more clearly and also get a wider exposure to the horizontal segment of the facial nerve. So here you can see the short rows of the incus attaching to the fossa incudis. So this attic wall here, I'll just thin out with a diamond burr tip. And this is what we call as epitympanotomy. So this epitympanotomy is also a very useful exercise and it has many indications. Usually when we see a lot of granulations fixing the incus and the malleus to the tegmen, we can do this epitympanotomy to release the adhesions while retaining the normal ossicular chain. Another indication of epitympanotomy in case of tympanosclerosis, where again we see a lot of tympanosclerosis between the malleus and the tegmen, between the head of malleus and the tegmen. Also in cases of limited retraction pockets, we can do an epitympanotomy and push the sac completely from the epitympanum into the middle ear. So in that way, you can remove the entire sac in toto. And finally, in case of bony ankylosis. So in bony ankylosis, there'll be a bony fixation between the tegmen and the head of the malleus. So even in such cases, you can do a wide epitympanotomy like this and try to create good space in the epitympanum so that the ossicular mobility is, you can make the ossicles freely mobile.
Intermittently, can I take the questions from the audience or
Sure.
online participants? I will try to avoid the important times of the surgery. So that's the reason I thought I can ask right now. What are the indications? Dr. Nageshwar Rao from Vizag, he want to understand what are the indications of facial nerve decompression in Bell's palsy? What is the role of EMG, ENG in the Bell's palsy and facial nerve decompression? And third part is what is the rule of 21?
Yeah, so the surgery we do for Bell's palsy is not for all cases of Bell's palsy. The surgery is for cases of unrecovered Bell's palsy. So in all the cases of Bell's palsy, as soon as they present to us, we investigate, we start with the oral steroids. We give deflazaccortisone about 30 mg per day and we taper it. And also we insist on physiotherapy. So we keep reviewing this patient every week. And at the end of 3 weeks of steroids and physiotherapy, we check for eyeball closure. So this is the most important sign that we look for. If there is eyelid closure at the end of 3 weeks, then the patient will recover. Even if they have a little bit of residual palsy, they will definitely recover over a period of time if they continue physiotherapy. But even after a course of steroids and physiotherapy, if the patient has Bell's phenomenon or if there is no eyelid closure, these patients will not recover without surgery. So these are the patients that we subject for surgery. And in our experience, we see that about 85 to 90% of the patients recover with medical line of management. It is only the remaining 10% of the patients who do not recover even with steroids and physiotherapy that we subject them for surgery. So these patients, if you don't do surgery, they will remain with permanent facial nerve palsy for a lifetime. So that is very important to know. And the rule of 21, as he asked, we wait for 21 days of we wait for 21 days, and at the end of 21 days, we check for eyelid closure, and we give a lot of importance to eyelid closure. If there is eyelid closure at the end of 3 weeks, then these patients will recover and they don't need surgery. If it is not there at the end of 3 weeks, then these patients require surgery. The same criteria has been followed by Brackman also in his book. So even he says 21 days should be the cutoff to decide whether you go for surgery or not. So EMG and ENOG also we do, but we give more importance to our clinical findings rather than the electrodiagnostic tests. So now this is the facial recess cell here. I'm slowly widening it. And here I should be careful. Always keep an eye out on any change in color, because medially here I'll get the facial nerve, and laterally I should also keep an eye out on the chorda tympani nerve. I can already see the stapedial tendon there and the stapes. I'll slightly widen it a little bit more so that it is more clearly visible. One of the pitfalls of doing this procedure is we have to disarticulate the normal incudostapedial joint and remove the incus, because in order to get a good visualization of the horizontal segment and the second genu, I have to remove the incus. But of course, we do a ossiculoplasty, so the patient will not have much of hearing loss after we do the ossiculoplasty.
Thank you. Dr. Neeraj has one question. The definition for the surgery, Bell's palsy definition, maybe he want to understand how you will choose these patients. And just a minute. And can we promise the patient for improvement after surgery, and how many percent chances of improvement or the success?
We get almost 100% results if we do the surgery early. That is, before 3 months, if we do it, then we can guarantee that the patient will definitely recover. So we wait.
Dr. Morwani has just arrived here, so I'm handing him the mic now, because he's got tremendous amount of experience with facial nerve surgery, and he was just held up in traffic. He's right here now.
Hello, sir. Good afternoon, Morwani, sir. Very nice to have you as the moderator.
And then you go on, and I'll just come. So let me get oriented to what you're doing. Can I bother you? What is history?
Sir,
How
he's
long
a
patient?
46-year-old male, sir.
Since how long the patient has Bell's palsy?
Sir, 84 days, sir.
84 days. Yeah.
It is persistently grade 6, sir, currently.
See, there's a lot of controversy about when to do a surgery for Bell's palsy. And some people believe there's no role of Bell's palsy surgery at all. Okay. So there are two thoughts at all. So I'm a person who believes in the role of surgery. But Vijendra does surgery much faster than what I do. In the sense, he does even after 15 days, and you're going to result, as he said, result going to be 100%. If you do after 15 days, but anyway, 95% plus would have improved anyway. Either way, 95 or 97 would have improved. So, but still, I don't criticize what he's doing. You know why? If you are doing a surgery, let's say a lot of us do a surgery for post injury or anything when there's a grade 6 palsy. But if you're grade 5 palsy for 2 months or 1 month, if I'm an excellent surgeon, I do not mind doing a surgery. In fact, I did it on one doctor's wife about 4 months back. 2 months, she had a grade 5 palsy, post-mastectomy. And when I saw the CT scan, there was some reason which I did the surgery for. But important thing is when you're doing so-called people who do not believe surgery, you're going to do a recovery much faster, number one, and chances of mismatching fibers are going to be reduced. So it's a way of looking at how you do it. People who are fond of doing certain surgery, they'll find more indication. People who are not fond of doing certain surgery. Now, Kirtane knows so many indications of cochlear implant, which so much of us do not know, who do not do cochlear implant, and they're not wrong indication. You know what I mean? Today we are doing a cochlear implant for severe conductive loss, advanced atherosclerosis patient also, for example, so things are changing. So, and this boy is an excellent surgeon, and I worked with him. We done a workshop together. This boy is a very good surgeon. Well done, son. Get on with it.
Sir, thank you very much, sir. Just one small thing. We wait for 3 weeks, sir, not 15 days. So we wait for 3 weeks and then decide whether to take the patient up for surgery or not.
Yeah, Jack Manion also believes in that. Okay, it's not that only him, and there are a lot of American authors, they do believe in it. So it's a question of which school of thought you belong to.
Yes, sir. So now I open the facial recess cell and you can see the landmarks very clearly. Kautik. So here you can see the round window, and this is the pyramidalis process here, the stapedial tendon, and you can see it attaching to the stapes. So you should get a good view of the middle ear through the facial recess cell. And also here, I think this is the shadow of the chorda tympani, which is coming here. I still have to trace that a little bit more.
Just one question.
Yes, sir.
Dr. Vijendra told us about his technique, and all of us know that it's named after him, of facial nerve decompression transcanal. Am I right?
Yes, sir. Yes, sir.
So when do you decide to do transcanal? When do you decide to do mastectomy?
So transcanal facial nerve decompression we only do in cases of longitudinal fractures of the temporal bone, causing secondary facial nerve palsy secondary to longitudinal fractures of the temporal bone. So in such cases, it is the perigeniculate ganglion area which is involved. That is the labyrinthine segment, the first genu.
You don't do that for Bell's palsy. I'm sorry. Okay.
No, sir. That's because in this case, it is mainly the vertical segment which is involved. So we'll be doing a decompression of the vertical segment. And for that, this is a much better,
fine.
This gives a much better exposure to the vertical segment.
So according to you, every case of Bell's palsy, you'll do a vertical segment only?
Yes, sir.
Okay, again, there's a difference of opinion. Hugo Fish, who popularized the thing, he always said decompress the labyrinthine portion. And this is what I emphasize on decompressing the labyrinthine portion. Now, if he's getting good result with the vertical portion decompression, I'm getting good result with the labyrinthine portion. Does the patient need surgery? Question comes like that. Does this patient need a surgery? If he's getting vertical, and a lot of us people want to do labyrinthine portion, and we get a good result. We are doing decompression of two different areas.
No, sir, it's common test and stapedial reflex is present.
Sorry?
Yeah. So they are thinking that the vertical segment is involved. So after doing all those tests.
In the introduction, they showed that the stapedial reflex was present and the genicular ganglion lacrimation was equal on two sides.
He gives a lot of emphasis on the lacrimation.
So therefore,
very good testing for lacrimation.
Therefore, he concluded that the lesion is in the vertical part.
Fair enough. I was talking
also radiologically also we have shown that the vertical segment the diameter was increased. This we see in all the cases. And also, if you take the Schumer's test, is a very important test. Whereas, if you take in a longitudinal fractures, which we see even day before yesterday, we did a case. In all cases of longitudinal fractures, when you do a Schumer's test, all cases, the lacrimation will be absent. That is, the Schumann test will be positive. Why it is positive? Because the greater superficial petrosoma will be involved in cases of all longitudinal fractures where the lesion will be around the perigeniculate ganglion. And as Vinay was telling, we do through transcanal approach. The reason is you can easily follow the fracture line very clearly. It will lead you to the site of the lesion. So that's why we do transcanal approaches very easily. We can recompress the labyrinthine segment, perigeniculate ganglion and the geniculate ganglion, which is the need for longitudinal fracture. And the Schumann test you do in all cases, it will be positive. That means lacrimation will be absent. Whereas in all cases of Bell's palsy, you do it, lacrimation will be present. So that's why I give a lot of importance for this. It has genuine reason for that. So that to prove that the lesion will be distal to the geniculate ganglion where the greater superficial petrosoma will be functioning in Bell's palsy. Whereas in contrast, in cases of longitudinal fracture, it will be absent where it is not functioning.
Very good. I advise somebody, this is a patient, about 20 years old boy, who got a facial nerve palsy with bilateral total deafness. I told him get a cochlear implant and decompression in one sitting. Of course, he was Sonal Modi's patient, could not afford it. And there are a lot of people willing to do cochlear implant for pediatric age group free of cost. 20-year-old patient, nobody was willing to do free of cost. But this is one of the indications, for example. Yeah. I didn't know. Patient is with Sonal. It is just about 4 or 5 weeks back. Yeah. Okay. So, even the cochlear implant with facial surgery at the same sitting, why not? If you're clean cases, so you have to advance keep on thinking of future and how we can help the patient. So having 2 episodes.
This patient's life is ruined unless he can get his hearing back, bilateral deafness. So in such a case, we would definitely consider we can try and raise funds for him and get it.
Yeah. So I told you this is Sonal Modi's patient. Patient is very poor. He rang me up. So somebody was willing to do cochlear implant free, but he said child, if it's another small child, we cannot give a free implant to him,
You can see the shadow of the facial nerve appearing now.
Head injury.
And you can see the shadow of the facial nerve appearing now. And also, you have to note the direction of the bird tip and how I'm drilling. I'm using a diamond bird tip and I'm not drilling continuously because I'm already getting the shadow of the nerve and I know that I'm close to the nerve. So
and you can see the blood vessel also.
Yes, sir. So just make gentle strokes. Lift up the bird tip after every stroke. Don't drill continuously because you don't want to end up damaging the normal nerve fibers. And also always work parallel to the direction of the facial nerve and just slowly polish it like this once you're close to the nerve.
Can you just show the relationship to the digastric ridge?
Yes, sir. So you can see the digastric ridge here. And if you keep following the digastric ridge, that will lead you to the vertical segment of the facial nerve. I'll just drill a little bit more close to the digastric ridge so that you can see exactly where the nerve is ending here.
See, sometime in the sclerosis bone, digastric ridge may not be prominent. You may not be able to diagnose the digastric. But in that area, if you drill and if you open the periosteum of digastric ridge, you know this is digastric ridge. Then you come forward and you know where the facial nerve will be.
Yes, even if we don't find the digastric ridge, you can always go to the digastric muscle. Follow the muscle, it will lead you to the tendon. And if you follow the tendon, that will sort of blend into the nerve.
Yeah, before the muscle, you see a periosteum. So you don't really go up to the muscle. It's a periosteum.
Yes.
Then comes the muscle.
Now you can see the relationship of the digastric to the nerve here.
Very nice.
Always try to decompress the nerve as widely as possible, at least 180 degrees all around. So that will give very good results.
How about incising sheet? Do you incise the sheet? Son, do you incise the sheet of the nerve?
Sorry, sir? Yes, sir. After delineating the entire nerve, I would like to incise it. Now I've still retained a thin eggshell layer of bone over the nerve. In the end, I'll remove that bone with a Plester's knife and later incise the sheath. So it is always safer to retain a thin layer of bone rather than drilling through and through. And at the end of the procedure, you can use blunt instruments to remove the bony pieces. And this part, it looks like there's a bit of ecchymosis here. So once we remove the bone, we'll be able to see exactly what is below it.
About incising the sheet, when you're doing a facial nerve surgery in case of infected mastoid bone, a lot of us do not believe in incising the sheet. Okay, decompression should be suffice. You incise the sheet in Bell's palsy, you incise the sheet in head injury where there's no infection around. And some people are willing to incise in every case, but we do not like to incise the sheet when there's infection around.
Sir, I do it regularly. Nothing will happen, sir.
Yeah, so as I said, everybody's thought process is different. And if the patient on a right antibiotic, why should it infect,
Yeah, that's individual variation. But in deserving cases, so many cases we do, cholesteatoma cases, keratosis obturans and all. So there will be a constriction. I do inside the sheet, nothing will happen. Except in cases of tuberculosis, I don't do it. The rest of the cases, if it is indicated, I do it.
Okay, Vijayendra, but in cholesteatoma cases, whenever we've decompressed and not opened the sheath, also it has recovered.
Yes, I agree with that, because in most of the cholesteatoma cases, there will be a paresis or grade 2 to grade 3. Very rarely we see these cholesteatoma cases with grade 6. So, because of the compression, that is more than enough, as you said, sir. Correct.
There's more of paresis rather than paralysis. Whereas you're mentioning about the COX, there'll be more chance of paralysis than paralysis rather than paresis. And there's loss of tissue in case of COX cases, One thing, as we're talking about cholesteatoma, is out of the turn I'm talking here, Kirtane, I learned one thing from Madhuri. Her mastoid cavity used to heal faster than my mastoid cavity when I was training her to do surgery. She would do every patient culture and sensitivity and start the antibiotic pre-op, which I have tried to tell myself I'll do it for everybody. I still don't do it. Certain things you don't learn, in spite, because you've been getting away without doing culture. But if you do a culture and sensitivity and give a right antibiotic, your mastoid cavity is going to heal much, much faster.
Yeah, very often you would have sensitivity only to intravenous antibiotics.
That's true. And Kirtan, we wrote a book, and we wanted to write a chapter on antibiotic. What literature talks about antibiotic, our culture was totally different. And we didn't put them in a book. Only the confusion we created, we did a culture of central perforation also and cholesteatoma cases also. So we say if you are going to write against the world, and when we mixed up the two cases, so she gives every time an intravenous antibiotic, she doesn't keep the patient in hospital at all. You put a vent flow and tell them to go and take them to villages where they come from.
Autophatic you pick. The next thing I'm going to do is I will disarticulate the incudostapedial joint. And like I was saying, this is one of the pitfalls of doing this procedure. But why am I doing this? It is always important to delineate a bit of the normal nerve and decompress that as well. So the normal nerve is in the horizontal segment. You can see the horizontal segment here through the epitympanum. So to reach that segment, I have to remove the incus and also the fossa incudis. And before doing that, I would like to disarticulate the incudostapedial joint, because while drilling, your vibrations of your bird tip should not be transmitted through an intact tympanic, through an intact ossicular chain down to the stapes foot plate. So I'll disarticulate the IS joint now and remove the incus, and then proceed to decompress the second genu as well as the horizontal segment of the facial nerve. Chikkutkodi.
And how would you replace it? Tell them how you're going to replace it.
Yes, we do a ossiculoplasty. So initially we used to do a primary ossiculoplasty, but somehow the results were not very good, because it is very difficult to calculate the length of the prosthesis, the cartilage which is required. Because in this case, again, I would like to tell that we haven't elevated the tympanomeatal flaps. We haven't entered the middle ear at all. Directly, we have come post-auricular. So if we try to do a ossiculoplasty through this facial recess approach, it becomes a little difficult. So nowadays, we counsel the patient for second stage ossiculoplasty, which we do after about 2 or 3 months. And it is a very simple procedure where you just do a tympanotomy, elevate the flaps, and just keep a cartilage and close the flaps again. So that is what we advise.
We replace the incus again in the same position at the same time. Same position. In the sense, we are not manipulating this incudostapedial joint on the incudostapedial joint, incudomalleolar joint. At the incudomalleolar joint, you can put gel form above and below to stabilize your malleus. And at the incudostapedial joint, if you think fraction of millimeter, your head of the stapes and lenticular process is not approximately exactly, just put a bit of perichondrium on top of it, a periosteum on top of it, just very little. This periosteum should not be big to go and touch on the promontory, just covering that gap only. Okay. So we do on the same sitting.
So we like to take few questions from online. Dr. Nageshwar wanted to understand what is the role of stapedial reflex in Bell's palsy.
So that is a topodiagnostic test just to find out the level of the lesion. So if your stapedial reflex is present, you can see the stapedial muscle here, and the nerve to stapedius comes somewhere near the second genu. So if the stapedial reflex is present, it means the nerve to stapedius is functioning, which means that the lesion should be below that level or distal to the level of the second genu, which means that it will be at the vertical segment.
Thank you. And what
in this case, again, it was present, which meant that the lesion was in the vertical segment. Now I disarticulated the incudostapedial joint. I'll slowly remove the incus here. And while disarticulating the incudostapedial joint, it is always important to work parallel to the stapedial tendon, because that provides a little bit of counter pressure, and it gives more stability when you're trying to disarticulate it. There was a little bit of ankylosis of the incudostapedial joint in this case, so it didn't come off that easily. 45-degree pick. I'm just again making sure that it is completely disarticulated, because I don't want to accidentally pull the stapes along with the incus when I try to remove it. Yeah, but now you can see it is clearly passing between the incus and the stapes. But still, while removing it, make sure that the long process doesn't go and hit the stapes and push it inside. So always keep an eye out on the long process of the incus, even when you're trying to remove the incus here.
Vijendran?
Yes, sir.
Vijendran, are you
Yes,
there?
sir.
Peter?
Huh? Yeah, I'm here.
Vijendran, what
sir.
I suggested, what I do for this incus, I reposition in the same anatomical position.
Okay, sir. Yeah.
I'm sure you can do as well or better than me. Try
Yes,
in
sir.
this case.
Yeah. So good suggestion, sir. We'll try to do that.
So lot many experts are wondering about the golden color of the burr. So they are inquiring what this golden burr is about. So can
Golden?
you add your
Yeah.
side?
This is the diamond coarse burr tape. So this is available with that Swambros Jyoti. So she exclusively imports this from Germany. These are very nice burr tips, and this has got a coarse and fine. These coarse burr tips are as good as a diamond burr. This is cutting burr only. So this will be very useful to drill fast, and also it is safer than the cutting burr tip.
So now this was the area of the incus buttress. I've removed the incus. Now I can drill out a little bit of this bone, because the facial nerve is inferior to this level. So you have to get a clear visualization of the second genu area. So carefully drill here. Keep an eye out on the level of the lateral semicircular canal, which is here, and just drill above that level.
You're from junior audience.
Thin out the posterobony meatal wall also at the same time.
Junior audience point of view, use the biggest burr point in given area. The
Yeah,
biggest
that is
burr
a-
point can be 7 millimeter and maybe 0.6 millimeter. So always use the biggest burr point in given area. What he's using is this level is a perfect size of burr point he had before. He may use a smaller size to get the bulge out.
Slightly smaller, I just took, sir.
Slightly smaller. But you'll be able to manage with this one also.
Yes, sir.
And one more request, sir. You have already shown the landmarks, but can you just please once more explain about the landmark for the facial nerve decompression again?
Both curve pick. Yeah, just 1 minute. So first I began by opening the facial recess cell. The facial recess cell is bounded superiorly by the fossa incudis, laterally by the chorda tympani, and medially by the facial nerve. Here you can already see the medial border, which is the facial nerve. So I've just retained a thin layer of bone, but you can see the shadow of the facial nerve running along the vertical segment here. So I've gone up to the stylomastoid foramen. So this was the digastric ridge. So this is another useful landmark. So if you come from distal to proximal, you can follow the digastric ridge. And here you can see the beginning of the vertical segment. This is the digastric ridge, follow the digastric ridge. And here you can see the facial nerve. So I've retained a thin layer of bone, which I'll remove at the end of the procedure. Now I'm coming towards the second genu. So to remove the second genu, I'm removing the excess bone over the lateral semicircular canal. And also I have to drill this bone here, which is inferior to the lateral semicircular canal in order to visualize the facial nerve. So you can see the horizontal segment of the facial nerve here.
We are
This is the
getting the
horizontal
picture
segment.
slightly out of focus. Is it possible
Okay,
to
okay.
sharpen the focus?
Yes, yes, sir. I'll go to a higher magnification. That might be better. Is it seen, sir?
Yeah, now it's very clearly seen. But
Yeah, you can see the blood vessels of the facial nerve, and you can
on
also
the horizontal portion, yes.
this is the horizontal segment, and I
Yes.
think it is dehiscent because it is completely bulged out here as well.
Yeah, it seems
There
to
is
be
no
there.
bone over the horizontal segment. So you should be very careful because in almost 30% of the cases, you can see dehiscent facial nerve. And also you can see the blanching when I press the nerve here. You can see the blanching of the blood vessels. That also is a very clear indication that there is dehiscent facial nerve. So you should be very careful while working here. Can you see the blanching, sir?
Yes, very clearly.
Yeah.
So there are 3 to 4 questions. So I
Yes.
think I will take this opportunity to ask how to approach an iatrogenic facial palsy.
Yeah, in iatrogenic facial palsy, again, it depends on the extent of the damage. If you can get away with the decompression, then you can do a facial nerve decompression. However, if the majority of the fibers are cut, then you'll have to do a facial nerve grafting. And when we do a grafting, you need to have a wide exposure and a clear visualization of both the cut ends. So in such cases, it is better to do a canal wall down procedure. So if you're doing a grafting, always go for a canal wall down procedure because it gives you a good area to work with. And also it is easier to approximate the cut ends of the nerve with the cable graft which you're going to place.
Occasionally, you don't have to do canal wall down. Last workshop I did in Calcutta, this boy, of course, junior resident, he done a lateral semicircular canal, he ruled out, and the facial nerve was damaged there from a simple mastectomy. Even this doctor patient, which I said I did recently, it was intake canal wall technique done by first surgeon. Why I did surgery, Kirtane, this patient had a CT scan pre-op, CT scan post-op. Post-op showing erosion on the vertical pores, which was not the pre-op, so it's not erosion. So it's exposure by incidental exposure by the surgeon. Now, when you're exposing the nerve, you do
We've
not
lost the signal.
One minute, sir.
You are no signal at all. Okay.
Yeah,
back.
now, sir. Yeah.
Okay.
So
it's
this is
possible.
Yeah, this is the importance of removing the incus buttress. Unless you remove the incus buttress here, you will not be able to visualize the second genu. You can see the nerve is going like this. Now I'll just drill inferior to the lateral semicircular canal. And this is a very critical area because on one side, you have the lateral semicircular canal and you have to keep an eye out on it and make sure that you don't accidentally blue line the lateral semicircular canal. And also you have to keep an eye out on the stapes as well. If you use a very large burr tip, the other end might accidentally hit the stapes, and also if your burr tip slips, you should make sure you don't go and hit the stapes. And the third thing is you should keep an eye out on the level of the facial nerve as well. You should not accidentally drill too much of the nerve. So this is a very critical area which I'm working in, and you have to take your own time and slowly try to delineate this segment of the nerve. Without removing the buttress, you cannot decompress this area of the nerve.
What is delayed facial nerve decompression and how we select the patient according to that?
Sorry?
I can say it again.
What is delayed facial nerve decompression and how we select patient according to that?
I didn't get the question. What is?
Delayed facial nerve decompression and patient selection accordingly. So
I think perhaps what you're talking about is in a post-injury traumatic facial.
Iatrogenic or
Yeah.
iatrogenic, whatever.
If it is not of immediate onset.
No.
then you might want to wait if it came in later, or if it was partial, you might want to wait. And if it doesn't recover according to anticipated time level, then you would go in. So you may not go in immediately if there are indications that there could be spontaneous recovery. And when the spontaneous recovery does not occur, then you decide to go in. I think that is probably what.
Now, I'll give a very good example of this. Kirtane, Mario Sana got so-called delayed facial palsy. Delayed by how many hours? 3 hours only. He went to Hugo. Hugo did not do decompression. To me, 3 hours is not delayed palsy at all. These are bone speculas there, which is penetrating and giving an edema and gradual development. And Mario Sana is left with grade 2. He thinks it's a grade 3 palsy. So delayed is also something you have to consider what is delayed. Number 2, as I said, even if they say after 24 hours, if you are excellent surgeon, I would, like, there's a student of mine, Rahul Agarwal. He has got largest series of facial nerve decompression, shortest period in India in last 10 years. You know what he used to do, Kirtane? His father was a dean at medical college. So any patient of head injury in medical college with facial nerve palsy, free of cost surgery. So he did 50, 60 cases like that. He's become so popular. Not forget about popular, his hand has become so stable, So he's willing to do grade 5 palsy also and delayed palsy also and give excellent. Like what they're doing today for Bell's palsy surgery. How many people would like to do Bell's palsy surgery? They're very limited people. So if your hand is good and you cannot give, you most probably won't give a damage, there's no harm in doing surgery.
Thank you, sir. And one more question. It is related to trauma. You have already explained about the trauma, both of you. So can forceps delivery cause the facial palsy and how to manage?
Can forceps delivery cause facial palsy? A forceps delivery of a baby and the baby gets born with facial palsy, I think you would have to just wait. You don't have to do anything because it's because of compression, pushing the brain down, stretching of the nerve. I don't think it traumatizes.
It's like a traumatic palsy. If the child is born after the forceps delivery, we presume it is because of forceps. We presume. It may be some congenital cause of facial nerve palsy. Some children are born with a facial nerve palsy with a cesarean also, for example. So with the trauma of the both, and as you said, any trauma you have to wait and see, assess how long it is,
Thank you, both of you.
So this is the most critical area here, because it's a very narrow area which I'm working with. So I've almost gone up to the level of the lateral semicircular canal here, and you can see the facial nerve appearing. And so I'm basically joining the vertical segment to the horizontal segment by decompressing or delineating the second genu area. And also I have to be careful about the stapes here. This is a very narrow area, and this is the most tricky area while decompressing the nerve here. And I think now you can see the shadow of the nerve near the second genu, and it is going up to the horizontal segment. This is thin layer of bone. I'll try to thin it out a little bit more so that it's easier for me to remove with the Plester side knife later.
So here I want to point it out to you that every case of facial nerve palsy, iatrogenic may not require canal wall down. Now look at your case now. You have been able to expose the vertical course, you have been able to expose the horizontal portion, and from this, if you want, you will be able to go to first genu also. So every case depends where the injury is. Now, people, one of the commonest side of injury is this area where he's working right now, People think they're gone into antrum and they go inside, it's not gone into antrum, So you can do a lot of cases without canal wall down. Look at this anatomy. He's showing himself. The whole anatomy of facial nerve you can see. So it depends on the location of the facial nerve palsy. And iatrogenic, why we do most often canal wall down? Like most of the iatrogenic cases are case of canal wall down cases sent to you. These are post-mastectomy cases. So as it is already canal wall down, so you do not mind doing canal wall down. But every case you don't have to do canal wall down.
Yes, sir. And even in our experience, most of the cases we've seen that it is the second genu which the surgeon tends to injure, because they'll go and look for the antrum here and they end up drilling the lateral semicircular canal as well as the second genu. And that is the most common site of iatrogenic facial nerve injury.
So one point here, that if you have a very well pneumatized mastoid like the one you opened just now, it's not likely that you'll have problems finding the antrum. But when it's a diseased mastoid, sclerotic, and it's contracted, that is the time you have difficulty. So when you have difficulty in locating the antrum, it is always better to delineate the dural plate first and go close to the dural plate so that you're as far away from the, follow the dural plate down into the antrum and they'll be staying away from the facial nerve. So delineating the dural plate becomes extremely important when you're in a contracted mastoid trying to look for the antrum.
Yes, sir. That's a very important landmark, especially in a very sclerotic mastoid. And now I'm going close to the stylomastoid foramen because in the CT we saw there is a widening here near the stylomastoid foramen. So I want to go as distally as possible to decompress the nerve completely.
For the experts in the hall, if you want to have any question or any query, please feel free to raise your hands. Khanna sir, please. Should I read? Okay. So Dr. Vikram Khanna wanted to understand, in an infected mastoid, we always remove the cholesteatoma before doing the facial nerve decompression. So plus we give pre-op and post-op antibiotics. So why not incise and open the facial nerve sheath after doing the decompression?
Sorry, can you repeat the...
In an infected mastoid, we always remove the cholesteatoma before doing the facial nerve decompression. Plus, we give pre-operative and post-operative antibiotics. So, why not incise and open the facial nerve sheath after doing the decompression?
Yeah, at our center, we usually incise the sheath in all cases, even in case of cholesteatoma. So now I've delineated the nerve here. Let
Signal
me just
is gone.
the anatomy.
We've lost your signal.
Yeah. We can hear you, but can't see the video right now. Yeah.
Okay, just a minute.
We can see it.
So I'll show you the anatomy from proximal to distal. So this is the malleus here. This is the processus cochleariformis. So the process cochleariformis gives a very good, it's a very good landmark. Just medial to that will be the geniculate ganglion area of the facial nerve. But in this case, we have to, we don't have to go up till the geniculate ganglion. You can see this is the horizontal segment here. And here, when I come distally, this is the second genu area. This is the second genu. You can see this is the pyramidalis process, the stapedial tendon. This is the lateral semicircular canal. You can see the nerve taking a turn at the second genu and continuing as the vertical segment of the facial nerve. Here, I can see some amount of ecchymosis here. I've retained the thin layer of bone throughout. So I'll be removing the extra layer of bone now and then seeing what the pathology is exactly. And here it is going almost up to the stylomastoid foramen. And this is the digastric ridge here. And these are the retrofacial cells where my suction is there. Double-end knife. Here there is some amount of ecchymosis. So this might be the area where the pathology is. So once we remove the thin layer of bone, you'll be able to see it better. But you can see the color change here. And this does not look like a healthy nerve sheath here. So very clearly you can make out the pathology and it will be even more clear once I remove all these bony spicules around the nerve here. So this is, it's always better to thin out the bone completely over the nerve and in the end use a Plester's knife to remove the remaining pieces of bone. So while drilling through and through, you might end up damaging the nerve. So always try to retain a thin eggshell layer of bone over the facial nerve till the end of the procedure. And in the end, you can remove the bony pieces like this. And try to open it as widely as possible. Try to get a good 180-degree visualization of the nerve. And you can see the bulge here. You can see here it is bulged out and here it is a little bit more narrow. Let me just clear out all this bone a little bit more and you'll be able to appreciate it better. And also the change in color also you can very clearly see. Some amount of ecchymosis is seen here. And this looks like the area which is involved. So this is how we can correlate our surgical findings with the preoperative CT findings as well.
What is the normal pathological changes you notice in the affected segment?
Adrenaline. Sorry, sir?
What is
Adrenaline
the
clotting.
pathological changes you notice in your affected segment in Bell's palsy cases usually, normally?
Yeah, the nerve sheath is usually will be very thick, sir. And in some cases, we see ecchymosis also. And also, when you send it for histopathology, the nerve sheath you have to send for histopathology, and it usually comes as dense fibrous tissue.
Fibrotic tissues.
Let me just point it out. Where he's working now, this area, he had this is with the intake sheet. This is area he had exposed before while drilling. This is area he had exposed before. But he has not done any damage to the nerve at all. Okay. So the important thing, as he pointed out to you, you make the bone eggshell. Don't make the bone, don't take out the bone from any part of the fallopian canal as far as possible. Sometimes incidentally we do expose the nerve the way he has exposed it. But as far as you're concerned, you're never going to expose the nerve. You're going to make the bone eggshell in complete course, whichever you want to decompress. And then as he's doing now, you keep on removing the bone. Okay. You can see the color difference in this fascial now and this fascial now here. And this fascial now here, which is being decompressed now.
Smaller double end.
So Dr. Shruti wanted to understand, why can't we do same time the tympanotomy and ossiculoplasty in the same setting instead of second stage?
Oh,
Yeah, you can do it, but
they're considering it. We have suggested them and they're considering it.
Adrenaline.
An ideal, Major Vaibhav wanted to understand, ideal time to explore the facial nerve palsy in an undisplaced transfer temporal bone fracture.
So even in those cases, we wait for 3 weeks or 21 days. So we try with steroids and physiotherapy. And if there is no eyelid closure at the end of 3 weeks, then we can take them up for surgery. So the earlier the surgery, the better.
So Dr. Faiz has one comment. Horizontal part of facial nerve can be decompressed till first genu. He just mentioned his comment here.
Yeah, we can decompress it. In fact, through this approach, we can go up to the labyrinthine segment also. But in this, preoperatively, the scan very clearly shows that the lesion is confined to the vertical segment. So I'll just go a little bit proximal to the affected part of the nerve. So, and I will stop at the horizontal segment. But it is very easy to go up to the labyrinthine segment through this approach.
Thank you. And Dr.
Sorry,
Yes, sir.
he's
Yes, sir.
decompressing now with the side knife. You can use a smaller instrument than that blunt right angle hook. Blunt hook, not the sharp hook. Well, that is much
Yes.
smaller, you know. And here you are taking out the big portion of facial now.
Smaller one.
This guy is good at his surgery. He's been doing surgery for too long. The junior boy, it will be much easier for him to use the hook.
Yes. And also we have different sizes of side knife. So appropriate size side knife you can use depending on the situation.
So Dr. Nageshwar Rao wanted to understand about Weber polling technique in decompression.
Adrenaline.
Weber polling technique in decompression.
Yeah. 1 minute. Barber polling. So sometimes the blood vessel here starts bleeding. So you can just control it with adrenaline. That's easy to control. But you can already see the nerve is bulging out here.
And
once
one thing
pole
about
is removed
adrenaline,
here.
see, like a lot of people like to use a cotton ball with adrenaline soaked. I like to use gel form soaked adrenaline. Why? If your suction cannula touches the cotton ball, everything will get sucked out. Gel form you touch, the gel form will come out. It won't get sucked out, adrenaline. So adrenaline stays there. So whenever you want to use adrenaline locally, use with a gel form. And if the bleeding is too much, then 2-3 pieces of gel form on top of it to give pressure, you can use a cotton ball.
Dr. Faiz wanted to understand about one case, facial
Adrenaline.
palsy, grade 5, following post-traumatic perforation of tympanic membrane due to key. Will require decompression post-conservation with no improvement. What is your opinion?
If there is no improvement with conservative management, then surgery is the only option.
I have seen 2 cases of facial palsy like this. Somebody is trying to clean the ear and somebody is going to hit him. You know what I mean? So I have seen 2 cases. One patient had an even dead ear. This patient, the cruras had fractured, the stapes had fractured, and he had a dead ear. And one patient had a facial palsy. One resident of mine was doing a syringing and the syringe dislodged and this patient got facial palsy. You know, very rarely the syringe can dislodge and got a facial palsy. So these are very rare thing, and any trauma can cause the facial palsy. And as how to look after the facial palsy will depend upon the grade of the facial palsy or the scans what the investigation advise you. If you're good at it, go and do surgery as early as possible. Bad at it, don't keep the patient with you. Pass on to somebody sensible, more senior. But today, medical legal problems are too many. If you can't do a surgery, it doesn't mean don't advise surgery. Put it on head of somebody senior. Let him take the responsibility of saying whether he requires surgery or not. Don't take yourself responsibility.
So whenever there is bleeding around the facial nerve, always wait. Don't be in a hurry. So I kept 2 adrenaline cotton balls and it took almost 5 minutes, but it stopped now. So always have a clear field of vision before continuing with your dissection.
What is the minimum age of a patient who should undergo a facial nerve decompression, and can it be done for a patient below 1 year age?
It can be done at any age. You know, now this is a very good example I'm giving you. Normally, acute otitis media in a neonate, when they get facial palsy, with antibiotic myringotomy, they will improve. Then never you see a patient, that child has not improved for 3 months, 6 months. I done only one case neonate, but this child did not improve for 9 months following the procedure. And moment I did a decompression, he improved. So I don't remember whether 12 months old or 16 months old, but this was neonate which I operated. There's only one case. And that's the era when I used to do hell of a lot of facial surgery, you know. So it must be out of thousands of cases, it's just a one rare case that you've done at this age, you know. So age is not a bar, as simple as that.
Sure. Thank you, sir. And
So here you can see I'm slowly thinning out this bone here. And again, here you should be careful about the stapes. If you use too much force and you go towards the stapes, you might end up dislodging the stapes. And here also I've come near the horizontal segment. There is a very thin layer of bone here, which again, I'm using a Plester's knife to separate. So this is the normal part of the nerve. So little bit of the normal part of the nerve also has to be decompressed in case of any facial nerve lesion. So that is the dictum of facial nerve surgery. So even here you can see a very thin eggshell layer of bone, which I'm slowly removing and exposing the nerve here. So this is almost close to the geniculate ganglion area. So this much of decompression is more than enough. And you can see the nerve is slowly bulging out. Once you remove the bone or the facial nerve and decompress it completely, you can see the nerve has slowly started to bulge out. So the pressure is also being relieved. Curate.
Thank you. With your permission, I will like to make 2 announcements, please. One is about the working lunch, because we will not like to have a break in the visual treat here. So I request all the participants or the experts from the hall, please feel free to have your working lunch during 1 to 3 o'clock. And second is for all the participants even joined online, for the credit points, they are queries to us. And in the invitation, there is one QR code. You can scan it and fill in the information, and 4 credit points will be allotted. Thank you so much.
So now I'm further trying to expose the nerve widely. So I'm using a curate because the bone here was quite thick and it was not coming out with a side knife. So I'm using a curate here to further expose the nerve widely. And you can see the nerve sheath also looks very thick. That you'll be able to appreciate once I start incising the sheath. So the nerve over the vertical segment is always very thick compared to the rest of the segments of the nerve. And in case of Bell's palsy, it becomes 3 to 4 times more thick than the normal vertical segment sheath. So that is what causes strangulation of the perineurium. So now you can very clearly see this may be the area of pathology, and also the sheath, you can see the color. It is looking very pearly white in color and it's quite thick. And once I start incising the sheath, you will see it completely bulging out.
I will like to take next question, please. Dr. Rambabu wanted to understand if a patient has developed facial palsy after 3 days of mastectomy without any injury to the nerve,
what could be the cause?
That should be treated as Bell's palsy only.
No, I don't treat it as a Bell's palsy. I said this patient has a micro dehiscence of facial nerve somewhere. And because of handling and mishandling and infection, this patient, so this patient, you just give them a heavy dose of steroids and good antibiotic, they're going to settle down. And even if you say Bell's palsy, what you're going to give? Steroids. So whether his theory is right, my theory is right, treatment is same. Okay? Steroids and antibiotic.
Yes, yes.
Murugan sir, what is your opinion about the facial nerve schwannoma?
Facial nerve?
Schwannoma.
Facial nerve schwannoma is a very funny thing. Let me explain to you. I've seen a facial nerve schwannoma, big one, without facial nerve paresis. And I've seen a small facial nerve schwannoma with grade 6 paresis. So either way, I'm sorry to say this, I call facial nerve sometimes as a woman. It doesn't react exactly to the injury. You know what I mean? Thoda gali diya, sar pe bad gayi, gali diya bahut kuch. So this is the, no, I'm very serious about little injury to the facial nerve can get you grade 6 palsy. And sometimes a great injury to facial nerve may get you grade 3 palsy. See, it has happened with me. Let's say I come out of the theater and told the patient's relation before the patient has come out of anesthesia, yeah, I handle the facial nerve, and this patient will wake up with grade 3, grade 4 palsy, paresis. And patient wakes up with grade 6 palsy. You know? So you get worried, but in this situation, the important thing is if you have a recording, please do a recording if you're doing facial nerve surgery, then you can cross-check on your thing. While doing surgery, you think, मैंने तो surgery पे injury नहीं किया, but go back and check. Once Deepak Dalmia made me check, I used to work with Deepak Dalmia a long time back. Deepak Dalmia is one of the brilliant ENT surgeons of India. He is an ENT surgeon who does good head and neck, who does good rhinoplasty, who does good otology, good rhinology. He is overall good ENT surgeon and tremendously working in a municipal or government hospital. The way he looks after his patient, cares for the patient, very few people look after the patient so well. We had done one child of 14 years old. This patient had a facial nerve palsy, congenitally. She got a facial nerve palsy. And we saw her movie at least 10 times. I had injured the sheet at vertical course for very small area, injured the sheet, not the nerve. And I was so sure it's going to be all right. But he made me see again and again, sir, 14 baras ki bachi hai, uska kya hoega? Anyway, she recovered completely. And funny thing, we did the other year, she had the same congenital anomaly, which was on this side. So remember this, if there's a patient of whatever hearing loss you're doing, congenital conjunctive loss, for example, this patient had, if his facial nerve is in the wrong course on this side, then opposite side also you're going to find most probably the same anatomical course. This is one thing which you must remember.
Yeah.
Vijendra is there?
Yes, sir.
Boss.
So now I'll just show the entire course of the nerve and then incise the sheath. So again, this is the process cochleariform is here, close to the geniculate ganglion. This is the horizontal segment of the facial nerve. Let me just zoom in a little bit more. This is the horizontal segment of the facial nerve. This is the lateral semicircular canal here. And here you can see the stapes very clearly and the stapedial tendon, the pyramidalis process. The nerve is taking a turn here at the second genu. And this is where the pathology begins. You can see the diameter of the facial nerve here and the thick sheath. So from the level of the second genu till the mid vertical segment is where the pathology lies. And here at the distal end of the vertical segment, again, it looks quite normal. So now I'll incise the sheath and you'll be able to appreciate the thickness of the epineurium and how it is strangulating the underlying perineurium.
There's one question for you. Patient, somebody has sent a question to me directly. Hello?
Yes, sir. Yes, sir.
You said you had done a Schimmer's test and you done a stapedial test.
Yes, yes.
And you found out the damage is proximal to the stapedial tendon. So
Yes,
that's why you are going to do vertical course decompression, right?
Yes, yes.
And then you went ahead and did a complete decompression.
I always decompress.
Also, and you did a horizontal portion also. So this person wants to know if he thought before with these two tests, the damage was in vertical course. This is not my question. This question has been sent to me on mobile, But some lot of people, Dr. Morwani's number all over India. So they send me the question, why has he decompressed the horizontal portion and the genu?
Yes, we always decompress the little bit of the normal nerve, distal and proximal to the affected segment. To get good results, you always have to decompress a little bit of the normal nerve segment. And
I would
that is
agree
why,
with him. I would agree. And how much normal nerve we decompress? Suppose
so I removed the incus here and I could get a full visualization of the horizontal segment. just a few millimeters of the normal nerve is enough. But after removing the incus, the whole facial nerve course has come into view. So I've not done anything to this part of the nerve, but it is visible very clearly here. So I'll only incise the sheath up to this level, and that will be more than enough, because just a few millimeters distal and proximal to the affected part of the nerve has to be decompressed.
Yeah. So now I tell you what we think about. Let's say you are doing post-traumatic facial nerve palsy, 3 millimeter or 4 millimeter facial nerve is exposed, whatever level damage is there, and it is edematous. It's swollen. You keep on decompressing 2 millimeter on either side. Edema will disappear gradually. It will keep on flattening till that freshly decompressed now and the originally exposed now, that thickness becomes same. That is good enough decompression. Whereas 2 millimeter, 3 millimeter, 4 millimeter, that decides on how the edema disappears. It spreads out.
Yes, yes, sir.
Did you agree with me, son?
Yes, yes, sir. So now I'll just incise the sheath. This is the tenotome which I use. It has a beveled edge here, and you can see the posterior end is quite blunt. So even if it is sitting on the nerve, it doesn't cause damage to the normal nerve fibers.
And again,
so incising the sheath again, it requires a lot of practice, because you need to get the correct cleavage between the epineurium and the perineurium, and just incise it gently. And the sheath over the vertical segment is usually very thick, and it requires a lot of effort to
It's thicker near
incise.
the stylomastoid foramen. As it comes vertically, it becomes thinner and thinner.
Yes.
Worse at the stylomastoid foramen.
So here you have to be very careful not to injure the normal perineurium. You should only incise the epineurium. Old tenotome, could you?
Anybody in auditorium has any question? Please ask. Keep everybody busy mentally. सोने के लिए नहीं आए वो. Anybody?
Still, you can see multiple layers here. Even though I incised the epineurium, there's still another layer here. I've still not got the perineurium.
Dr. Vinay.
Yes, sir.
Question from Dr. Praveen from Pune. That which nerve graft is better and why? Your experience, please.
We always use the greater auricular nerve. It is almost the same diameter as the facial nerve. And also we can get it at the same site. We don't have to go to the leg and try to get the sural nerve.
I agree with
Are
you.
they Cody?
Totally.
Previous
On the
one?
other hand, I'll tell you the more part of it. Mario Sana insists the sural is better graft. Mario, and he has much more experience than all of us, Especially, see, Mario does a lot of glomus, where the facial nerve is compromised quite often, So he insists that facial nerve, you should use a sural nerve graft.
Yeah, now you can see this is the perineurium here. Now I've got the cleavage of the perineurium.
We do not mind using sural. And sural is a very good graft if you're doing a surgery in the parotid area. You can sural now करना तुम 3, 4, 5 branch कर सकते हो. Sural now is so thick, you can make 1, 2, or 3 or 4 branches as required. So when there's an injury in the parotid area, then obviously sural now is better. If you require bifurcation में डालने का, कि 3 branch में डालने का, then this is thicker to be split into 3 and use a sural now over there for definitely.
Hello, you please watch now. See, he's got the perineurium. How is he incising? That is important step. Please, all of you watch.
You can see the color now. Color is coming out of the nerve. That because you see under the microscope, you can make out what is the color of the nerve and what is the nerve sheath of the nerve, color of the sheath. You give them an idea how to. Vijendra, तुम बताओ उनको.
So he's doing it.
So you can see the perineurium bulging out here. This is the epineurium and this is the perineurium. Going between the epineurium and the perineurium, and I'm incising the epineurium here. And you can see the bulging of the perineurium once I do that. And you can see how thick the epineurium was. So it involved multiple layers of slicing of the epineurium before I got the perineurium. And here you can see it is still more thick. You can see how thick this is. And the whole nerve is getting lifted up, but it is not cutting. So here it is better to use iris scissors to cut it. Otherwise the whole nerve gets lifted up.
Iris scissors are tremendously better than the regular micro scissors which we get.
Yes, sir. Only thing is we have to make sure that the blades are in between the epineurium and perineurium and slowly cut it. You can see this is dense fibrous tissue here. You can see the fibrosis and you can see how thick it is. And I'm slowly trying to incise the sheet further. So this is the main area of pathology here.
Now, what is this area? Geniculate ganglia.
No,
second
sir.
Genu. Second
genu. Beginning of the second genu.
And where was the
proximal
pathology we
second genu.
expecting? Lower down.
No, same, sir. Tenotome. So now there's still a few additions here, which I'll use a tenotome once again. You can see this is the perineurium. This is the perineurium. Here there's a thin band of epineurium, which I'll try to incise. So all this will relieve the strangulations. Suction block.
One question is not asked by people, and this I want to ask. How late you can do surgery for facial nerve decompression? I'll give one example. I had done one patient of mastoid surgery who had a facial nerve palsy for 7 years. So obviously we told the patient we are doing a revision surgery for colostoma, for discharging, for improve your hearing, and nothing to do with the facial nerve surgery. We cannot do anything. And when I did the surgery, in vertical course, I saw a damage 3 to 4 millimeter facial nerve missing. There was no ischemia, there was no fibrosis, there was no endoneuroma, and I did a facial nerve grafting. I went out of the theater and tell the relative I'm doing for academic reason. 7 years down the line, you are doing facial nerve grafting. There's something wrong with you mentally. Okay, so you have to be, you have to be idiot to think.
Adrenaline.
You know what I mean? You cannot be a normal human being. Sorry, let me finish with this. And this patient, when she's come to me, I used to hardly look at a facial nerve injury. I said, तो बेवकूफी तूने किया, तू क्या समझता है, खुद को हीरो समझता है साले, दुनिया में कोई अच्छा नहीं कर सकता. Can you believe? After 7 months, she started improving, and I shown hundreds of times in various talks. She has improved so well. After that, I had done cases, facial hypoglossal anastomosis also 3.5, 4 years after acoustic neuroma surgery, various surgery. So the important thing is when patient is grade 6 palsy, तुम डैमेज क्या करोगे भैया? ग्रेड 6 तो हो चुका है ना, तूने ग्राफ डाला, सूचन किया, अच्छा हुआ कि नहीं, क्या फर्क पड़ता है? So you have to have a different way of thinking altogether. This was incidents for me. It was lucky that this patient came to me, and I did. A lot of people would have not bothered to put a graft, but I could put a graft and see. I'm not a magician. What I did, what anyone could have done. Medical course. And I did not have suturing material. I did not have graft and where I was operating. I just put the graft over there. Important thing is when you're putting a graft, if the defect is 3 millimeter, graft should be 5-6 millimeter. You should not have any strain on the graft. That's the important thing. So you can attempt the surgery with a guarded prognosis, even 2, 3, 4 years down the line, if patient really. And once Anand from Polachi, he had discussed with me that he had done a patient who had a facial nerve palsy 20 years before. And discharging mastoid. And he did a surgery. He said it improved so much you can't believe it. It did not become normal. Okay. So this grafting also when you get a grafting, you don't get normal. You get grade anyway.
I'll continue now to incise the sheath over the second genu. Tenotome kudi. So it's important to find the right plane. Iris scissor. Lift up the nerve, lift up the epineurium, and then gently try to cut it. And you can see even here it is quite thick. Whereas in a normal nerve, over this segment it becomes quite thin and it is very easy to incise. But here it is still a little thick. And whenever there is bleeding, I would always prefer to stop the bleeding.
Somebody sent me a question. Why would he like to incise the normal nerve?
Adrenaline.
Why would he like to incise the sheet in normal nerve? He's trying to say the normal nerve, the sheet is not so thick. He's right. But somebody put a question, why would he like to incise the sheet of the patient, which is normal patient now?
See, each one
And
has
he's right
got
what he's
his
saying. He's not
own
saying
way of
wrong.
this thing.
See, when you say normal, when we are doing dissection, see the number of dissection this boy done, a lot of us have done, are so many. So this is normal for us, okay?
Tinotom.
So we are not gone on a patient to say it's normal. In a dissection, you know what is thickness of your nerve. You are right, sir.
I think the pathology.
So here I'm again going distally also, so that the normal nerve segment is decompressed. So whenever there is edema in one part of the nerve, and when you incise the sheath, it completely bulges out. So a little bit of the normal nerve segment also has to be incised, so that the strangulation is relieved. And also to know exactly where the lesion ends, you have to go to the normal segment. Otherwise, it is difficult to find out till where the lesion extends. So if you see a little bit of the normal nerve fibers, then you know that you have adequately decompressed the nerve.
Vinay?
Yes, sir.
I think when you are decompressing, not only in the pathological area, proximal and distal to the proximal pathological area, you have to decompress. Am I right?
Yes, yes, sir. Yes, sir. That's what.
Only you'll be comfortable. Yes.
Yes, yes, sir. That's what I'm doing now. Distally, I decompressed it a little bit more. Here, I'm just waiting for the bleeding to stop, and then I'll go towards the horizontal segment also. So the main pathology was in this region, that is the beginning of the vertical segment. So this is where the sheath was very thick, and you could see multiple layers of the epineurium which I had to incise. And even here, if you see, this is the thick sheath here. We'll also send this for histopathology, and most of the time the report comes as dense fibrous tissue. So all this is a very clear indication that it is the vertical segment which is involved in facial Bell's
It
palsy.
goes to the second genome, right?
Yes, yes, sir.
Vinay,
yes, sir.
Somebody wants to know what are the tenotomes you have and which type tenotome is best for this. Can you show them what tenotomes you have?
Yeah, yeah. It's just one thing, sir. It's the same tenotome which we use. Kodi ಇನ್ನೊಂದು tenotome kodi. Both are from Kalelkar. It's almost similar.
Sickle knife only. It's a sickle knife. Okay?
Something different from.
Sickle knife is a little sharp on this end. Sickle knife kodi. Sickle knife.
So the
I
answer
don't know.
is,
This is what sickle knife I have. It's sharp on one side, other side is blunt. This is what it is. He thinks it's more flatter. That is different, you know. But
the one on the right is the sickle knife.
Only you get smaller size and bigger size, you know. If you see he has got two, the size is different. That's all about
this
it.
tenotome is something different, sir. Designed by Vijendra. So
So the one on the right is the sickle knife, and the one on the left is
No.
the,
According to this gentleman who tried to give information, he said the tenotomes are a bit more straighter instrument than the sickle knife, you know. Anyway, but whatever you are using instrument, what is name? What is important name? So far you are getting a result. That's important. It is, you know.
yeah, result.
And all of us use different instrument. Like using a flag knife to decompress. Where I said you can use a right angle. No, there's nothing wrong. Either way, you're right. You know? What you're used to, that's important.
Dr. Vinay, someone want to know about the role of topical steroid during decompression. Topical steroid.
Vinay?
Yes, sir.
The second geno area, there are some fibrosis, no? Will you use steroid? Will you use topical steroid? What is the role?
No, we usually cover it with gel foam soaked with steroid at the end of the procedure.
What is the role of steroid? It's a fibrinolytic, am I right?
So Vinay, you've been able to decompress the whole facial now with
Yes, sir.
intercanal wall technique.
Yes, yes, sir. We can go to the labyrinthine segment also.
You can
But
go
in
to
this
labyrinth
case, since
segment.
it is
You
not
have to just
involved,
take away the cells in front of the canals. If you take away these cells in front of lateral and superior canals, you will get the labyrinthine portion there.
there's still a few fibrous bands here, which I'm still trying to release.
Now about these fibrous bands. I done fair amount of surgery for post-traumatic facial palsy. Sometimes fibrous bands are so fibrous, you are scared to damage the nerve. So I have given up. He is going on, there's nothing wrong, and he's not damaging the nerve. So if you are scared that you are going to damage the nerve, 20%, 30%, 40% fibrous band निकाला ठीक है. कुछ तो decompress किया ना बेटा. You done a decompression. So don't insist or persist on something which you think may damage the nerve.
Very nice. So now you can see I'm completely separating the perineurium from the epineurium here, and whatever adhesions are there is being separated now. I'm just using a ball probe. So as long as the perineurium fibers are intact, you don't have to worry about any facial nerve palsy.
I think it is 180 degree.
Yes, sir. Yes, sir.
We say 180, it may be 150, 160, 140, doesn't make a difference. You've done an adequate decompression and you've done an adequate incision of sheet also.
So here you can see a little bit of strangulation. So I would like to further extend this a little bit. So this nerve has bulged out after I incised it, but here there is an abrupt strangulation. So that also may cause some amount of facial weakness post-operatively. That's why I try to incise the normal sheet here so that this nerve settles down and there'll be a uniform widening of the nerve. So there should not be strangulation at one place like I showed now. So now I incise the sheath here, and eventually you'll see that the entire nerve will be the same diameter without any strangulation at a single point. So that is the importance of decompressing the normal nerve fibers also. I hope it's clear. Any questions?
Yes, excellent. Can we give a clap to the... Only if, would you attempt to put the incus back in normal position? Would you try?
I'll try, sir. There's no harm in trying.
You will be
if
able
it
to
doesn't work, then we can always open after 3 months and do an ossiculoplasty.
You can try now. It doesn't work. You can open up after 3 months. No problem.
Yes, yes, yes.
Give a try. You'll be able to do it. Your hand is very steady.
Sure, sir. I'll try it. Thank you. So now you can see the completely decompressed nerve. You can see how it is looking now and how it was looking earlier. The diameter is completely, it is equal in all the places, and it is not uneven like it was before. This is the vertical segment, and this was where the main pathology was. This is the distal vertical segment. This is the second genu area. And here you can see the nerve decompressed all the way to the horizontal segment. And here I think it's just a small strangulation, which again I'll try to release. Yes, sir.
So that is, are you doing under general anesthesia or local anesthesia?
Local, sir, local. The patient is snoring nicely, sir.
Local. Sir, can we check up the eyes now?
Yeah. At the end, sir, once we finish the...
Oh, during the procedure, can we?
Participants are requesting you to try and do ossiculoplasty in the same sitting.
Sure, sir. Yes.
Just I promoted them unnecessarily. Sorry. But this
Yes,
is
sir.
every case. Every case I do it again. And it is possible. What I can do, you can do. I always did what Daryl can do, what Hugo can do, what Mario can do, what I can do. What I can do, all of us can do. We are not superior human beings. We just put extra effort. We learn extra. We have work hard on the cadavers. That's all about it.
So here, actually, if you see, there's still a thin layer of sheath here. So I'm not completely
And somebody
satisfied.
had the suggestion, if you cannot do this ossiculoplasty from this area, you can still raise the temporometer flap and do ossiculoplasty now only.
Yeah.
What you're
So
going to do
here-
after 3 months, raising the temporometer flap, raise it now and do the ossiculoplasty, which you want to do. I'm saying put the incus back. If you think that's not feasible or not good enough in your hand, no problem. Do exploratory temporotomy now and do ossiculoplasty now.
Yes, sir. So now here you can see there's still a thin layer of epineurium here. So I'm not completely happy with the decompression here because you can see a bit of strangulation at this junction exactly. And if you actually look closely, there is still a thin layer of facial nerve sheath, which I have to incise to get optimal results. So that is what I'm doing now. I hope the demarcation is clear between the epineurium
Only
and
it is
the perineurium layer. So now
excellent
this also
demonstration.
bulged out and this also became even. Now the strangulation is shifted here. So there also there is a thin layer of epineurium. Again, I'm incising the sheath. And now you can see again, it is completely bulged out and it became even now. So that is
One more
the
round for clapping, young man.
advantages. Sorry,
Well
sir.
done.
Thank you, sir. So now you can see the complete nerve smiling and very healthy and completely decompressed. So this is how we can do a complete facial nerve decompression to decompress
With
the nerve
intact
in
canal
case
wall
of Bell's
technique.
palsy with intact canal wall technique. Yes, sir. Ball probe. So once again, I'll just show the anatomy before we finish. So this is the geniculate ganglion area. This is the process cochleariformis. Just medial to that will be the geniculate ganglion, which I'm palpating here. This is the horizontal segment of the facial nerve. You can see it is completely decompressed. This is the second genu, which is close to the stapedial tendon here, and the pyramidalis process. This is the the lateral semicircular canal, and this was the main area of pathology, which was around the proximal part of the vertical segment, close to the second genu. And now it's completely decompressed, and you can see it is looking quite healthy, and it is nicely bulged out, and it's looking same diameter as the rest of the nerve. And this is the proximal distal part of the vertical segment. Again, I have decompressed the normal healthy nerve fibers as well. So this is how you can do a facial nerve decompression in case of Bell's palsy. And if you want to reach the labyrinthine segment, you have to drill out this part of the bone here. These are the supralabyrinthine cells. And if you drill out that part of the supralabyrinthine cells, you can see the nerve taking a turn and continuing as the labyrinthine segment. The first genu will be somewhere here. The nerve will take a turn and continue as the labyrinthine segment. So when needed, you can also go to the labyrinthine segment from this approach. But in this case, since the lesion was confined to the vertical segment, this amount of decompression is more than enough.
Vinay, what is the size of the bar?
Iris scissor.
Use the labyrinthine segment decompression.
Iris scissor. Yes, sir. Scissor.
If you are,
Sorry, sir, I didn't hear.
you are planning for labyrinthine segment decompression, what is the
Yes,
size
sir.
of the bar you will use?
As much as possible, I would try to use a curette, sir, because the labyrinthine segment, there is no sheath and it is very tricky there, because you might accidentally end up drilling the labyrinthine segment. So as much as possible, try to use a curette. And if not possible, then use a 0.6 millimeter burr tip to drill the nerve around the labyrinthine segment.
Vinay, Dr. Kirtane, first of all, compliments to you on a fabulous demonstration. Thank you very much. One question, you've done so many of these. What is the time frame now that you expect the recovery to take place?
Thank you, sir. Thank you very much for your kind words.
Absolutely
And,
fascinating. We were all mesmerized by the surgery. Lovely.
thank you, sir. Thank you, sir. Now what I'm doing is I'm just taking the sheath here. This is the
biopsy.
affected part of the nerve. We give it for biopsy.
Okay.
Sir, usually the eyelid closure, many times we see it on the table. So I'll check now if there is eyelid closure on the table. Most of the time we get eyelid closure on the table. The rest of the muscles to act, that takes 3 to 6 months for complete recovery, sir. It also depends on how
You
early
follow
we
them
take
with electromyography to
Yes,
see
yes. We continue physiotherapy after the surgery.
because
Sorry?
electromyography would pick up recovery much earlier than the clinical recovery.
Alligator. We rely more on clinical assessment, sir. We've not tried post-operative electrophysiography, sir.
You just have to do EMG, which would be fairly simple to do, and you would get about 3 to 4 weeks earlier. You would know that the recovery is setting in with the recovery potentials coming. So it would be something worth doing.
Yes, sir. Yes, sir. That's a good suggestion. We can try to incorporate it, sir. Thank you, sir. Thank you very much. Alligator. Scissors, Cody. Biopsy.
What is the next case you're going to show?
Sir, next is not ours, sir. I think We'll go to a different center.
We have a case of cholestoma lined up. I don't think I have time. Our time is up to 3 o'clock they're given. So I think we have to wind it up, okay?
So I think there is not enough time for the next case, Dr. Vijendra is saying. So my suggestion to you is to have your lunch and come back so that I'll ask the next case, which is supposed to be at 3 o'clock,
Yeah.
to see if they can prepone it a little bit. Okay, so just have lunch and come back then.
So now if you have any doubts, it demonstrated very clearly the whole patient.
Master is now available. Vijendra is there on the mic. Any questions you have, any doubts you have in
Sir,
this case, or if you have doubts in any aspect of otology, now is the time to ask him.
Hello.
As we had time, why don't you do osteoplasty?
Yes, sir.
This patient, as we had time.
Yes, yes.
Vinay.
Yes, sir.
The great auricular now is giving two branches, no?
Yes, sir.
It's the bill of the ear and straight. So will you cut before giving the branch or not? When you are taking the great auricular nerve graft.
Yes, sir. We try to take it before the branching, sir. The main trunk of the great
You
auricular
are
nerve.
giving importance to the lobule, the sensation.
Sorry, sir.
Lobule of the ear, sensation now. The great auricular branch is giving a branch there, no?
I'm not able to hear you clearly, sir. Can you repeat?
See, when you are going for a nerve graft, no?
Yes, sir.
Selecting great auricular nerve, which is
Yes, sir.
giving two branches. That is one to the anterior and posterior branches, no?
Yes, sir.
So you will spare the posterior branch, am I right?
Yes, yes, sir. So here I'm trying to place it back into the original position.
Be able to do it. Just
like
be relaxed.
Morani,
Be
sir.
totally relaxed. See, you almost done it. You almost done it. Just be totally relaxed, sir.
Yes, sir. So I have to try to keep the lenticular process back onto the head of the stapes there.
And if you think the head of the stapes and head of the incus is not meeting beautifully, you can put it's meeting so beautifully. Look at it. Look at both the joints. People are clapping.
Thank you. Thank you for your suggestion, sir, and your guidance.
So osteoplasty charges which you're going to charge next time, send it to me.
Yes, sir.
Chalo.
Maroni sir is
Well done. And you can put little bit of, you don't need to put anything. It looks so stable. You think you have to put anything? Vinay?
We'll just keep on,
Air form you can put around the incus and incudomellular complex.
we'll put
And
a
if you
little
want to
bit
put
of
perichondrium.
thin layer of temporalis fascia around the
Yeah, you
inclustopidial
people are fond
joint.
of temporal fascia. I would put periosteum or perichondrium and includostepidial joint, but
Yes,
it doesn't
yes,
make a difference. So far you're putting a cover.
Yes, sir.
So
And
there is a
also,
question from
I'll
the-
put some
from the audience.
temporalis fascia here near the facial recess cell, just to cover this area as well.
So there is a question from the audience. I request sir to please ask the question. That is not working.
Marwani sir. Marwani sir.
Yeah.
Sir, keeping the ossicle just over the head of the step, is it enough?
Yes,
Or-
you can see it's
Yes,
not only
yes.
head of the stapes. There's a good lenticular process of
Yes,
the
Vinay.
anatomy.
Okay.
Yes, sir.
Sir, I have a question for you. Basically, I have
There's
seen
no
you
need of
countless
fibrin glue,
times
but
doing
there's
that
no
transcanal
fibrin glue because you use
decompression of the fascial nerve, particularly
say
for the
fibrin
injury
glue. Why not?
cases.
Use it.
So my question is, what is the rationale actually? I mean, even if you are not doing the osteoplasty in the same sitting as sir has suggested, your plan was to do it, say, 3 months later. So in that case also, you have to open the middle ear 3 months later. So this case, this is not an infected case. It's a Bell's palsy case. It's not a cholesteatoma or any infected case.
Includostepidial joint is okay,
So
sir.
why can't we go for the transcanal as well? Because in that case, the ossicular reconstruction becomes much easier if it is done transcanal than the transmastoid.
But no, transcanal decompression.
months we are going to do transcanal.
He's asking why don't we do transcanal for Bell's palsy?
Transcanal for Bell's palsy. See, in transcanal for Bell's palsy, actually this vertical segment is the one which has to be exposed. So you will not get this much of exposure when you do transcanal. Mostly up to the stylum as from the digastric ridge, you have to do it. So here the exposure will be good and it is easier. So when you do transcanal, then you have to reconstruct the posterior meatal wall, everything. So like that, you have to think bit Malila.
Sir, Indra sir.
Yes, sir.
The transcanal approach indication of our facial nerve decompression and the entire canal wall and the canal wall down. The facial nerve decompression surgeries. In which are the instances you will prefer, sir? Transcanal?
Yeah, Vinay very clearly told. See, transcanal facial nerve decompression we do only in cases of longitudinal fracture or traumatic facial nerve palsy.
Yes, sir.
So the advantage of this transcanal facial nerve palsy is once if you open the masseter cortex, you can very clearly see in all cases of longitudinal fracture, the fracture line will be crossing or across the posterior bony meatal wall and going towards the perigeniculate ganglion. So one advantage is you can trace the fracture line and go to the site of the lesion. And it is very easily you can reach the lesion, site of lesion through transcanal approach. That is the reason we go. So whereas in case of this Bell's palsy, the whole facial nerve has to be decompressed. When you go through transmasted, you'll get a good access to the whole vertical segment, which is the main pathology will be there. So that is why we do this procedure, transmasted procedure for this. And when you are doing a sedentary facial nerve palsy, iatrogenic facial nerve palsy grafting, always it is better to do canal wall down so that you can decompress the proximal and distal normal nerve, and then you can do a cut the diseased end, and then you can do a grafting. So like that, and with my experience, this is how on the table before surgery we decide which procedure, which route to go, approach to go.
Yeah, yes.
And this is a sheer experience. It is not one or two cases. I got a largest series of iatrogenic facial nerve palsy. As on now, we got more than 300 cases I operated. And mine is a referral center. Most of my dear friends, they refer. In an average, in my center, every month we do 2 cases of iatrogenic facial nerve, an average. Yeah, day before yesterday, we did a case of longitudinal fracture. These cases we get very often. Even this case was referred by one of my students, Shantala. So yesterday, suddenly he came. So it was a good thing we wanted to show. That's why centering place, we have selected this case. So the amount of case and amount of experience, the amount of post-operative results I have, probably the largest series in the world I have. So all these patients, they come for 1 year. And if we have got hundreds and hundreds of cases of pre and post-operative photos we have.
So in many cases, we are observing the eye improvements.
Yeah.
Particularly this ocular improvement we are able to see.
Yes.
But, as you told,
watch this. This is very important. Hello. Can you watch this? How is stabilizing the inguinal stapedial joint? This is a very nice technique.
Yes, sir.
So this will calm fibrosis and it will not allow the inguinostapedial joint to fall down. See, very nicely he has done that. Thank you very much, Morwani sir, for your guidance. It is a very nice thing. Henceforth, we will do it like this. See, and also he is stabilizing the inguinal joint by keeping a piece of temporal fascia. What it will do, it will form adhesions and it will fix the inguinal joint. Okay.
I asked about the fibrin glue, he accepted, sir. He is also fibrin glue.
Fibrin glue, we can use fibrin glue only to the inguinal joint, not to the inguinostapedial joint. Because the fibrin glue, if it falls down to the stapes may get fixed and the vibration.
Okay.
So that's why. So simple things always you try to do. This is a very simple thing. Everything is present. Only thing, presence of mind and experience. This is so nicely he did it. This is the first time he is doing it.
Yeah.
So thanks to Moroni sir for his guidance and encouragement. So he did it. Okay.
Gel foam.
Thank you very much, sir.
Steroid gel foam. Now I'll just place some steroid gel foam on the exposed part of the nerve.
So this is a dexamethasone. So we take gel foam and just keep it over the whole exposed part of the patient now. So it acts as a local steroid effect. And also this patient already has taken 2 courses of steroids. Here I'm not going to give steroids for this patient. So only we'll give the anti-inflammatory tablets like trypsin, tablet. So for about 15 days, and we give some vitamin tablets. And also we'll give a physiotherapy for this patient for a month. And most of these patients, they do very well. The first thing they recover is the eyeball closure. So this fascial palsy decompression, when you do this here, I'm 100% sure after 3 months, I'll show this photo of this patient. I'll put it in the group. So I'm very confident 100% is going to recover completely. Whereas in cases of iatrogenic fascial palsy, when you do grafting, patient will not recover 100%. They may come to grade 2. If you get a grade 2, that is an excellent result. And whatever you do, the frontalis will never improve when you do iatrogenic fascial palsy grafting. I have seen it, my experience, it will never improve. So this is the experience I have. And these patients, 100% they'll recover at maximum at the end of 3 months. So these photos I'll be posting to in the group. So I'm very sure, I'm 100% sure the way in which he has done completely, they will recover very fast.
So the temporal fascia, we have to cover the edematous.
Just to prevent any retraction pocket in future, that's all.
This is the facial recess cell which I opened and the incus buttress which I've removed.
So he's stabilizing the incus buttress also with this.
There is a protocol, post-operative protocol. You don't use steroid.
No, here I'm not going to give steroids. Not necessary. This local steroid is enough. As I told, already he has received 2 courses of steroids and it is 3 months old. So this surgical procedure is more than enough. I'm sure that he will recover. Only will give some anti-inflammatory tablets for some time. And for wound healing, we'll give a small antibiotic. Not a very strong antibiotic is necessary.
Yes, sir. Fantastic, sir.
Fantastic.
We'll just see the result, whether we can appreciate.
So, Dr. Vinay, there are a couple of questions.
Yes, sir.
Dr. Sanchita from Guwahati would like to understand what is more tricky in this approach, dislocating IS joint or disarticulating IM joint in normal hearing individual?
Sorry, 1 minute, sir. We'll just show the result.
We are seeing
Hello?
Yeah.
improvement in the eye.
Now you see that.
Yes, sir. Yes, sir.
As I told, the eye closure will be the first thing to be done.
Yes.
Open karo, aankhein ko band karo, 4-5 bar karo. Can you see? Hello?
This is the
Yes,
one-
sir, wonderful.
Yes, sir. What? Yes, sir. Yes, sir.
This is the, compared to the pre-operative, this eye closure is almost complete. Can you see that? This is the thing which we see on the table
On the
when you
table.
do like this. And I'm 100% sure this fellow will recover 100%. Okay?
Right, sir.
Thank you.
Thank you, sir.
Thank you, sir. Thank you very much.
And this is the advantage of local anesthesia. See, so comfortably we did under local anesthesia. So this is how I've been trained by my beloved teacher, Dr. Mahadevia sir, is to do everything under local anesthesia. We are very comfortable in doing this. And the patient also will be very comfortable. And so many things we can test on the table. Even transcanal fascial decompression, then fascial grafting, everything we do under local anesthesia very comfortably like this.
Close, madam. Close.
Any questions to Vinay? Vinay?
Sir, here you are reminding about Mahadevia, sir, the legend. So many of us are student of Mahadevia.
Yeah, correct.
Yes, sir.
So with this, just we are going to pack the master and going to suture. So I think
Full cover, master.
we have shown everything. Vinay has shown very clearly the whole complete fascial decompression, and nobody should go with any doubts, and also there should not be any controversy. So here I would like to tell, see, because some people are told that labyrinthine segment is involved, don't blindly believe it. So actually, I have gone through the world, all over the world. I have seen 3 international facial nerve symposium I attended. There are people who speak about the labyrinthine segment, but I haven't seen anybody showing pathology in the labyrinthine segment. Just that speak, but nobody can show the pathology like what we shown. So when you keep presenting, they keep asking so many questions. For everything I have answered today. You see the articles before 1970, everyone they were doing vertical segment. Just because somebody started doing the labyrinthine segment and they said that is the one which is involved. But practically in reality, if you show the Schwimmer's test, these things, the topographic test is very, very important. It very clearly shows the lesion will be distal to that. Second thing, when we started do radiological tests, so people started asking me about the contrast. So when you do MRI contrast, so in this case, very clearly we have shown that how the vertical segment was take up was brighter compared to the opposite side where there was no take up at all in the vertical segment. Then we started doing the measurement, the 3D reconstruction my radiologist will do, and he will measure each segment, vertical segment at different sites, and the diameter will be wider compared to the normal now. That is another proof to say. Then with my experience, when I incise the sheath, I can make out immediately how easily I can incise the sheath in a normal vertical segment and how difficult here to incise the sheath, because you have to take multiple incisions to reach the perineurium. That is another important point to say, that this vertical segment of the facial nerve is thick fibrous tissue. And again, what we have done, we have taken all the cases, the fibrous tissue, that sheath, and we have subjected histopathology. And also we have taken a normal nerve sheath from the horizontal segment, the normal nerve sheath. We have done a comparative study of that and this, then it shows dense fibrous tissue. And also we have shown how easy we can insert the sheath of the vertical segment in unaffected case and affected case. So like this, I got authentic proofs to say that the vertical segment is the only thing which is involved, not the labyrinthine segment. And we are doing, and plus I have done, this is probably about 146 or 148 seventh case we are doing. We have got record of all the cases, and believe it or not, honestly, I'm telling, at least 95 to 96% of the patients, they have 100% they have record when you have done this procedure in a proper time. Proper time is before 3 months. If you do it, they'll 100% there. 3 to 6 months or beyond that, when you do, they recover, they maybe grade 2, they will have done. So contrastly, some people say, even without doing, they'll recover. That is very wrong. I got a series of patients. If in my presentation I show where a young elderly lady in the almost 30 years total palsy she has got. One of my close friends' mother, she had a facial nerve palsy for more than 30 years. So she lived like this, and she was so hesitant to go out of the house. For 30 years, she lived only inside the house. My very close friend's mother. Even now, she has got the total palsy is there. One of our chief minister, ex-chief minister, he had a total Bell's palsy. You must be knowing that. So total Bell's palsy he had for lifetime. So these are the group of patients. When you don't interfere, they will have lifetime facial palsy. Even if you can see that Ramdev Baba has also got facial palsy, still he has got facial weakness of grade 3 facial palsy. That's a Bell's palsy. Like that. So if you should know when to operate, when not to operate, and how to operate, and what this thing to do, without any doubt, this is the segment has to be decompressed. And all of you, I'll show you this patient 3 months completely. I'm so confident that this patient is going to recover 100%. That is because of my experience. Thank you very much.
Sir,
and there should not be any controversy in this facial now. For Bell's palsy, if you do like this, that is very important. If you do surgery like this.
Hello, sir.
Yes.
What is the advantage of putting in gel foam in the mastoid cavity? Do you regularly give it, or what is the idea, sir?
No, that is all soaked in steroid. So that is only the local steroidal effect of the facial nerve exposed.
Okay. And sir, then what should be our dictum? That not that in every case of Bell's palsy, like Vinay said, that almost 75 to 80% recovers, then that rest 10-20% we are going to operate. So what will be our dictum after 3 weeks, or maybe we'll wait for some more time? With
No. Yeah,
steroids
correct.
and physiotherapy.
Yeah,
What-
not 20%. I can say about 10 to 12% we have. So the dictum is, if the patient has Bell's phenomena at the 21 days, in spite of giving steroids, physiotherapy, still if he has got Bell's phenomena, you take it from me, these patients will not recover completely. The other way around, if the patient is able to close the eyelid at the end of 21 days, even with a small gap, even if they have a deviation mouth, everything, frontalis is not recovered. These patients, they will recover. They may take up to 3 months time, give physiotherapy, and they don't operate them. Only if they have a grade 6 facial palsy, that is Bell's phenomena positive, these are the patients who will not recover. Even if at all, if they recover, they'll have a residual grade 3 to grade facial palsy.
Okay, okay. So Bell's phenomenon is the criteria that we should take over.
Yes.
For getting into surgery.
Correct.
Right, sir. Right, right. Thank you so very much. It was again a wonderful demonstration.
Thank you so much, sir. May I know who is speaking?
Sir, I am Dr. Dhruvajyoti Mukhopadhyay. I am from Kolkata. I work.
Thank you.
Thank you,
See, I got a passion for this facial palsy from 30 years. The amount of cases I have seen, and I have done probably one of the largest series in the world. With my experience, when the patient comes and sits in front of me, I can very clearly tell whether this patient is going to recover or not. That is the experience I have. The moment I see so many people all over India, they would have done iatrogenic facial palsy, they will send it. But if by seeing the patient, I can say this patient doesn't require surgery. Many a times I have sent back the patients. So that is the experience I have.
Thank you. Thank you very much, sir.
Thank you.
sir.
I once again thank the organizers, particularly Janaki Ram, for giving me this opportunity, and also the great legends, Dr. Kirtane and Dr. Morwani sir, as the moderators. It was a real boon for my son who operated in front of you, sir. This is a great honor for us. And also, I sincerely thank the Sun Pharma, who has done a company who have organized this live surgical workshop, 2 days workshop. Tomorrow is a real challenging cases Janaki Ram has got. It will be a real feast. I don't know how he is going to show all the 5 cases. Each and every case is important. And luckily, I got this case yesterday, and we could demonstrate this. I sincerely thank Royal Pearl Hospital and Bombay West AOA branch, Dr. Janaki Ram, Kirtane sir, Morwani sir, all of you for actively participating. And once again, my sincere thank to Sun Pharma, and also I thank my anesthetist Vinay, our staff sister, and Nilesh, and all our staff members who are coordinated very well from last 2 days. They have been working. Thank you very much. Thank you, one and all.
Thank you, sir. Dr. Vijendra sir and Dr. Vinay sir. It's our honor and pleasure to have you on the screen and seen you operating here. Thank you so much, and thanks.
Yeah, once again, we are going to show that now after removing the bandage and all, look at this eye closure is really very good. You tell Nilesh. Look at this patient we are doing at local anesthesia. Light off, glare ಆಗ್ತಾ ಇದೆಯಾ? Light.
The full sir.
Great.
Yeah.
Close your eyes. Close completely. Tight. Open. Close. Do that 4-5 times. Open wide and then close.
Can you see the difference? Definitely there is a good difference is there when you see the pre-operative photo. Okay. This is the result, and as I told, I'll keep posting the improvement of this patient. Thank you very much. And one announcement I want to give. So we, in our Vijay ENT Care Center, we run a 1-year fellowship, otology fellowship for post-MS candidates. So it is 1 year affiliated with the BLD University. So it's a 1-year fellowship course. So it is a unique course. This is our 14th year we are doing it. So we select candidates 4 candidates, 2 from abroad and 2 from Indians. So those who are interested can apply for that. So as early as possible. So 6 months they'll be working with Vijay ENT Care Center, and 6 months they will work in university, BLD university, and they have to do 30 dissections at the end of 1 year, and they have to publish 4 papers. And at the end of the 1 year, there'll be a 2 theory paper examination will be there, and a practical examination will be there. And the university will give a degree certificate as fellowship in otology. Whoever is interested, juniors, they can apply to my center at the earliest. Thank you very much.
Thank you, sir. Thank you so much. And we request, since there will be half an hour break during this session and the next session, we'll request all the audience to please have your lunch.
Sir, thank you so much, and so kind of you to share the fellowship announcement here on the platform. It will help so many budding ENTs to have to excel in this area and to learn under you. Thank you so much, sir. Thank you so much for the wonderful surgery, and thanks to your whole team along with you.
Thank you, ma.
Thank you so much.
I request all the panelists, they were here till now, and we thank you so much, all the 3 experts here, and some of you have not even gone for the lunch break, so we announce a half an hour break, and after half an hour we will again connect here. Whoever the experts who have joined online, we will take a break at least till 2:50, 2:55. So please feel free to have your lunch and join back. And about the credit points, as I have mentioned prior, in the invite, there is a QR code. And if you will scan it, fill in the information. But then please remember, you have to be online. And accordingly, the credit points will be credited to your account. The credit points are 4. Thank you so much.
Hello. Hello.
It's on only.
Hello, I can't hear you.
Can you hear us, sir?
Yeah, now I can hear you. Actually, the first 2 sessions went on very well. I was watching it, and Professor Mohan Kameshwaran sir and Professor Vijendra and Dr. Vinay Vijendra did a fantastic job. We are having 2 more sessions today. The next will be by Professor Padma Shri Milinvi Kirtane sir, and after that will be Dr. Deepak Haldipur from Bangalore. So we will be having 2 sessions after this. I think we are having a half an hour break. After that, we will start.
Sure, sir. Thank you so much, sir. See you at 3 o'clock, sir. I know you have a lot of energy. You can go continuously. But thank you so much. Even your health is not though. Still, consistently, your energy and your passion, it is throughout, we can see. Thanks a lot, sir. So sweet of you. Thanks.
Thank you so much. May I know who is on the dais? May I know the name?
I'm Dr. Archana.
Who is talking to me?
Dr. Archana from Sun Pharma Medical Affairs, sir.
Okay. Thank you.
Whenever you are there, I don't leave this opportunity to have this dais and chat with you.
Thank you so much. Thank you, Dr.
Actually, I was waiting to meet you here, but then I understood that you're not well.
I was not well. I'm actually even now I'm not well. I'm just watching the program alone. I'm saving my energy for tomorrow. Tomorrow we have a very big list.
Very true, sir. Very true. Take care, sir. See you at 3
Thank
o'clock.
you.
Thanks a lot. Bye.
Bye.
Hello, Hinduja, can you hear me? Is there anybody in the OT?
Hello. So they're not taking a mic.
Yeah,
They're giving
we can hear you, but everybody's out. I'll just call them in. It's Anjali.
Oh,
So can you hear me?
there.
Hello.
Okay.
कुठे आहे आवाज? कुठे आवाज नाही येते. हां.
हेलो दिनेश सर हेलो हेलो दिनेश सर हेलो
एक कॉफी लाई होगा
हेलो हेलो हेलो
The surgeons are not here yet. क्या किधर से बात करना है? त्याची काय गरज आहे? नुसती माईक कोणता? हॅलो
हॅलो चेक
हो येतोय. तुम्हाला येतोय का?
हॅलो चेक चेक ठीक आहे ना
तर we are about to induce. The surgeons are outside. I'll let them know once they come in. Okay. This is Dr. Anjali.
Can we get rid of this?
Yeah.
Hello.
Yes.
That was yours, no?
Someone handed it over to me that you eat something, so it was in my hand.
No, check 1 2 3 है चेक चेक check, check, check.
मी टाकलं पण तरी पण नाही आलं तेव्हा.
लो हो गया.
Hello. हेलो दिनेश सर, आवाज आ रही है? हेलो 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 हेलो
He check one hole. Check.
Sir.
He check.
Hello.
He check. Hole. Check. Check. He. Hello. Hello. Test.
Check.
Mic testing,
Hello.
testing.
Check 1 2
5.
3.
Hey, mic check.
Check. हेलो चेक. सही है ना? आ रहा है आवाज. इतना लंबा है. हेलो चेक. हेलो चेक 1 2 3. है चेक. हेलो चेक 1 2 3. है चेक. हेलो माइक टेस्टिंग. हेलो चेक. हेलो चेक. बराबर है ना? हेलो चेक 1 2 3. है चेक. हेलो 1 2 3 4 5 6. है चेक. हेलो चेक. हेलो माइक टेस्टिंग. हेलो चेक. हेलो चेक 1 2 3. है चेक. देखना ये रिटर्न ही आ रहा है. थोड़ा लाउड करने पे आवाज ऐसा रिटर्न जैसा मेरे को लग रहा है. चलो ठीक है, थोड़ा काट के देखो इसको. है 1 2 3. है चेक. हेलो माइक टेस्टिंग. हेलो चेक 1 2 3 4 5 6. है चेक. हेलो माइक टेस्टिंग. हेलो चेक. हेलो चेक. हेलो चेक 1 2 3. है चेक. ठीक है, बराबर है. इसको काटो बस, जो ये सब आ रहा है बस।
नहीं है सर, नहीं है वो नहीं है।
चेक चेक, हेलो, चेक चेक, 1 2 3 है, चेक चेक, हेलो हेलो माई टेस्टिंग, हेलो चेक चेक, 1 2 3 है, और चेक चेक, हेलो माई टेस्टिंग, हेलो चेक, 1 2 3 है, चेक, हेलो माई टेस्टिंग, हेलो चेक चेक, हेलो, देख आ रहा है, और फिर ये देख,
हेलो हेलो,
हेलो
1 2 3 1 2 3,
1 2 3
हेलो
है,
हेलो
चेक
हेलो हेलो
चेक, हेलो
हेलो हेलो
चेक,
हेलो
अभी सही दिख रहा है, हाँ अभी सही है।
हेलो, 1 2 3,
वन
चेक द
टू
माइक, हेलो हेलो
चेक, हेलो
हेलो
माई टेस्टिंग, हेलो
हेलो हेलो
चेक चेक, वन
हेलो
टू
हेलो
थ्री है,
हेलो
चेक चेक
हेलो
चेक, हेलो टेस्टिंग माइक, हेलो चेक चेक चेक, हेलो चेक, 1 2 3 है, चेक, हेलो माई टेस्टिंग, हेलो चेक चेक, 1 2 3 है, देख रिटर्न आना चालू हो गया, हेलो चेक चेक, वन
हेलो
टू
हेलो
थ्री है, चेक चेक, हेलो माई टेस्टिंग, हेलो चेक चेक, हेलो चेक चेक, 1 2 3 है, चेक माई, हेलो टेस्टिंग, हेलो चेक चेक, हेलो चेक, हेलो चेक चेक, 1 2 3 है, हेलो
लगी है
माई
ना?
टेस्टिंग, हेलो चेक चेक, हेलो चेक है, चेक, हेलो चेक,
मैंने भी आपको सेट करना था। एक ही बात करनी
ठीक है।
है। आपको कंफर्टेबल है ना?
हाँ, गिरना नहीं चाहिए।
इसमें इसको ना
क्योंकि इसलिए बाल का ही है बाहर ना।
एक मिनट।
कहीं गिर रहा है ये नहीं ग्लूज है।
नहीं लूज नहीं है।
हाँ चल,
लूज है।
1 2 3 है, चेक चेक, हेलो हेलो माई टेस्टिंग, हेलो चेक चेक, हेलो है, चेक चेक, हेलो
नहीं
वन
लूज
टू
कर
थ्री
नहीं लूज नहीं
है,
लूज है।
चेक चेक है, चेक 1 2 3 है, चेक, हेलो चेक, 1 2 3 है, चेक चेक, हेलो माइक टेस्टिंग, हेलो चेक चेक, हेलो चेक, 1 2 3 है, चेक चेक,
परफेक्ट। चलो
हेलो चेक चेक,
ऑन है।
हेलो चेक,
कैमरा लेके आओ।
1 2 3 है, चेक, हेलो
मुझे एक पेंसिल या कुछ इंस्ट्रूमेंट
हेलो
चाहिए।
चेक,
आर्टरी
1
और
2 3
समथिंग आर्टरी ऑफ
है, चेक चेक, 1 2 3 है, चेक चेक, हेलो चेक, अरे भाई चेक चेक करते करते गला सूख जाएगा।
व्हाट इज द हिस्ट्री क्या है थोड़ा पेशेंट का।
हेलो
एंड व्हाट इज
चेक चेक, हेलो चेक चेक, ठीक है, ओके है ना अभी, चलो।
He, check one, check. He, check. Hey, hey. Check. Hey, check. Check. He. Check. He, check. He, check one, hold, check. He, check.
या पूछो उनको चालू करना है and when I'm talking now, see that the mic is on, so all remain quiet. असून नहीं नहीं
नहीं उधर भी टेस्टिंग चल रहा है
ये अपने हॉल में नहीं है ये अपना है ओटी है ये अपना ही ओटी दिख रहा है they are in
ये आपका है
the Taj Lands End.
Hello. Yeah, hi, ma'am. Hello.
Hello.
Yeah, hello, ma'am. Can you hear us?
Hello.
Hello. Can you hear us?
Can you hear me?
Yes, I can hear you, ma'am. Can you hear us?
Yeah. Can we start discussing about the scans?
Yes, ma'am.
Okay.
One second.
Ma'am, can we take this opportunity to just introduce the panelists and request? It will take around 2 minutes. Kirtanesh sir is taking over.
Sangeeta,
Yes, sir.
Dr. Abhinit Lal and Dr. Adib Shetty will be the moderators for your session. I'll be there, of course.
Yes.
Right now, they're just finishing lunch and coming inside. 5 minutes, and can you do one thing? Yeah, you've got the CT scan focus, right?
Yes, sir.
So we can start with that in exactly 5 minutes. So people
Please don't come in front of the camera.
Okay, okay. बराबर है? Hello, hello, hello. Hello. Yes, yes. Hey, barabar. Yeah. Yeah. OT, can you hear us clearly? Hello. 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 Test, 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 test. Hello, hello. 1, 2, 1, 2. Test, 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 test. Testing, testing. 1, 2, 3, 4. 1, 2, 4. Testing, testing, testing. Testing, testing. Hello, hello. Test, 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 test. Test, 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 test.
नेटवर्क नहीं है तो बोला अभी मेरा क्लियर था ना वीडियो
त्यांच्याकडून चालू करो सांगितलं
मैंने बोलेंगे तभी करते नहीं
सिस्टर हे इथे कॅमेरा आहे ना इथून समोरून जाऊ नका
हो सॉरी
म्हणजे अजून चालू नाही झालंय हा टिल फॉर 5 मिनिट्स हा बघ तो कॅमेरा इथे येतोय हे बघा इथे कळलं हे बघा तुमचं सगळं येतोय चेहरा
I was there in both fire.
काय झालं
उनको बोलता हूँ स्टाफ this case, I heard Dr. Supriya ने एक case induce किया, so I can do
Hello, hello.
तुला ना तू कॅमेऱ्याच्या मध्ये येते 5 मिनिटं फक्त
There's an announcement for the panelist expert, Dr. Abhineet Pal, Dr. Abhineet Lal, Dr. Abhineet Lal and Dr. Adip Shetty, please come towards the dais. Dr. Abhineet Lal and Dr. Adip Shetty, so please come towards the dais. So please, we're waiting for you. See you now. See you. So we'd like to take this opportunity to just in brief welcome sir, a living legend in the field of ENT, Padma Shri and Dr. B.C. Roy awardee, Professor Dr. Milind Kirtane sir. He always say no for introductions, but it is my duty to introduce him. So please take it over ahead.
Okay, Sangeeta, can you hear us?
yes sir, we can hear you.
So, brief history of the patient.
Okay, so this patient is a 3-year-old girl, has inability to hear and speak since birth. She's using a hearing aid. She had an hearing aid trial and therapy, but it was of there was no response with the hearing aid trial. The patient's birth history is 8 months LSCS with a delayed milestone, and a CT scan. Now you can see this is we are going to do a right cochlear implant. So this is an actual CT scan. So if you can see, this is, we are going from the top to bottom. If you can see, this is the superior semicircular canal. This is a nice pneumatized mastoid. This is the superior canal. Okay, then we come here. You can just see the internal auditory meatus coming into the view. Okay. In the next picture, you can see one facial nerve turning here, and you can see a part of the cochlea anteriorly, and this is the lateral canal, so semicircular canal posteriorly. And you can see now in the next picture, there is an enlargement here of the vestibular aqueduct. Okay, and you can see you can see a nice base cochlea here, but the middle turn and the apical turn of the cochlea is fused. So we can say this is an IP2 cochlear anomaly.
What you call a Mondini's deformity.
Yeah, Mondini's deformity.
Is the vestibule also dilated? Yes.
Yeah, the vestibule also is dilated. Okay, the modulus is little attenuated. You can't see a perfect modulus here. The lateral semicircular canal also is showing dysplastic changes here. Okay, and if you see the facial nerve, you can see the facial nerve turning here. This is the greater superficial petrosal nerve, and from here the horizontal portion of the facial nerve. You can trace the facial nerve here. And in this picture, you can see now the facial nerve at this area. And here you can nicely see the basal turn, but the middle and the apical turn are fused to form a cystic cavity, small. Okay. There is also a little high riding jugular bulb here. The middle
But it's quite away from the round window area.
Yes, but it is like away from the round window. Okay.
Can you show can you see the stapes?
Yeah, we can show the stapes here. You can see in this picture, see this is a foot plate, and you can see a small stapes here. Okay. This is your facial nerve, and you can also see a pyramid here.
You can see the incipitocapitular joint in that particular, just ahead of that.
Yeah.
Head of the stapes and the long process of intercystin there.
Yeah, yeah.
That's right.
Yeah.
So the thing to note over here is you've got a good pneumatized mastoid, but you have a type, IP type 2, incomplete partition type 2, which is Mondini deformity, which has 3 characteristics: enlarged vestibular aqueduct, apical and middle turn fused, and a dilated vestibule. Mercifully, the facial nerve course doesn't seem to be affected. The lateral semicircular canal is otherwise quite well formed. So we will get, on opening the round window, some amount of CSF coming out, but it will not be a gusher. It will be a ooze, but it will still need to be peeled off. Okay.
Okay. Okay. On the MRI scans, we can see all the, this is the parasagittal cut where you can see on the right side, we can see all the 4 nerves, the facial superior, inferior, and the cochlear nerve. Very well seen.
The superior and inferior vestibular nerve appear fused together. So it's like a comma-shaped thing.
Yeah.
The facial nerve and the cochlear nerves are seen separately.
Yeah.
And usually the cochlear nerve should be a little bigger in diameter as compared to the facial nerve. In this case, they are more or less the same.
Okay. And this is the actual scans. You can very well see on the actual scan, you can very well see the on the right side, you can see a nice nerves entering inside the cochlea here. Okay.
And you can see a dilated endolymphatic.
Yes, you can see the dilated endolymphatic duct here. Okay. Okay, this is the very well seen dilated endolymphatic duct here. Okay, and you can see the middle and the apical turn are fused here.
But okay, you can see the entry of the cochlear nerve into the cochlea there. And if you can go back to the CT for a moment, can you just go back to the CT scan?
Yeah.
Yeah, I just wanted to show them what you mean by the cochlear aperture.
Okay, so this is the
So you can see a definite entry point into the cochlea. It's called the cochlear aperture of the cochlear canal, where you can see that the internal auditory meatus communicates with the cochlea. Usually in a normal cochlea, you would see a big, thick modulus there. In this, the modulus is attenuated. Whenever you have a doubt about the modulus, it is better to use a lateral wall electrode and not a pre-curled electrode. You would not use something that curls around the modulus if the modulus is not well formed, because the nerves may not be going through the modulus. They may be going along the periphery of the cochlea.
Okay.
Okay.
Okay, so we are using we are doing advanced bionic Slim J, which is a straight half band electrodes here.
Yeah, but it's a outer wall electrode.
Yes, outer wall electrode. So now I'll wash up and we'll start the case.
Yeah, so I'll introduce you as you go to wash up the case. Can you? And let me introduce you to. No case should be done by Varia technique. It's something which you need to throw out of the window. Dr. Sangeeta Vati is now a consultant ENT surgeon at the PD Hinduja Hospital. She was an associate professor earlier at the St. G.S. Medical College and KEM Hospital. She has a special interest in cochlear implant surgery. She's a general ENT surgeon, does every aspect of ENT. And she has performed more than 300 cochlear implants by herself now. She's also attached to the Aliyavar Jung National Institute for the Hearing Handicap as a consultant. And she's a clinical expert in the National Screening Committee for the ADIP, that is the Assistance to Disabled Individuals Program. And for the chair, we have Dr. Adip Shetty and Dr. Abhinit Lal. Dr. Adip Shetty is the director at the Apricity ENT Care Hospital at Bandra West. He's a consultant at the Leelavati Hospital. He also heads the Department of ENT at Rajawadi Hospital, which is a municipal hospital. He is a certified cochlear implant surgeon from Innsbruck, Austria. His special interest is endoscopic ear surgery and cochlear implants. He is the assistant editor of the International Journal of Head and Neck Surgery, and is currently the president of the Association of Otolaryngologists of India, Mumbai branch. Dr. Abhinit Lal, who goes back a long way. I mean, he was with us at KEM as a resident, so I know him from those days. He's a senior ENT consultant now at Paras Hospital in Patna. He was trained at the GS Medical College and KEM Hospital. He completed his advanced training under me, yes. He has been a fellow at the FISH International Microsurgery Foundation and has been involved as a tutor. This is something to be noted. He has been going there as a tutor in the fish otology course in Zurich and in Belgium. Okay. Right now, it is with Thomas Linder, right, Abhinit? Yeah. So that's a big plus that he gets invited as a faculty member for the course at FISH. Yeah. And at present, he's actively pursuing building up a cochlear implant program in one of the most populous and underserved regions of India. He comes from Patna. And believe me, there are other patients, people who ask me from different parts, how do I start a cochlear implant program? I just want you to know that I have either done or mentored about 4,000 cochlear implants now. But in 1996, when I started the program, I did one case in the whole year. In 97, I did one case. In 98, I didn't do any cases. In 99, then it started picking up. So today there are times when I can do maybe 3 or 4 or 5 cases in a day. When I go to Nagpur, we do about 20 cases in a weekend. But it didn't always start that way. It started very slow. So either you have state funding, which is very good, but if you don't, if you're in practice, all of you have good, rich patients, you can ask them to donate. That's how I started. The first donation we got was from Mahindra and Mahindra in 2003, where I made a presentation to them. All companies in your city have to donate 2% of their profits. It's called corporate social responsibility. They have to give it to some cause. So if you have a patient who works in one of the corporate companies, Go and make a presentation to them and they can give you a donation. They can donate you maybe 5 implants, but that's a start. But unless you keep on knocking on that brick wall, it's not going to break down. Plus, you don't have to do it in children. You have adult patients, like I mentioned earlier, who come not satisfied with their hearing aids. That's where you start. Now, once you have done a few cases, word gets around and then you start drawing. So don't give up. It's not easy. Where I have done so many, I started with 1 implant in a year. So don't give up. Those of you who ask me how to start a program, you have to make your own funding. You have to make your own efforts to get your pay. And CSR is compulsory for every company. They have to give it to somebody. Just talk to them and make them give it to you.
Okay.
Sangeeta, are you
Table
ready
done.
to start?
So we are starting now.
Okay, shift to.
Can you hear me?
Yeah, I can hear you nice and clear. You ahead. Go ahead
Okay,
and
sir.
start.
Okay. Table down, please.
Okay.
Rajesh, table down.
And I.
हे खाली कर स्टूल खाली बस हाँ सिटिंग okay no we can show. So we initially show the incision through the outside camera. So if this is the right ear.
If you start the mastoid, then you can take the
Yeah,
picture
okay,
is too
sir.
bright. We can't see anything. Just adjust the camera level. Yeah, that's much better.
Okay, so this is the right ear.
Mark it out with the pen.
Yeah. So this is the anterior, posterior, superior, and inferior. This is the mastoid tip ear. Okay. Our incision will be nearly a very small incision, like a post-oral incision. It will be nearly a straight incision this way, a little above the pinna. Okay.
Posterior to the pinna, you mean going slightly above the pinna.
Yeah, slightly above the pinna. Okay, so and we made take a little curve here posteriorly. Okay, so this is your incision taken. And we take some soft tissue or subcutaneous tissue and fat. This we will be using later on to plug the round window. Some 4 or 5 pieces.
You want some extra pieces because you're expecting a CSF leak. Because you'll get
This
the
should be on
CSF
30, no? Okay. So now we are going to undermine the edges of this incision.
If you can get your hand out of the way a little bit. Okay. Is somebody holding the camera? It's going round and round. Careful.
More.
What is the external camera that you're using?
What is the external camera?
You're using a phone or actual camera or what?
SCLR, na? Which camera are you using? Or external camera?
Yes, ma'am.
Okay. So you
Whoever is using the camera is moving about so much, it's getting a little difficult to follow what's happening.
एक stable रखो. Okay. So we have undermine anteriorly. This is your plane of your temporalis fascia. Now we will undermine it posteriorly.
You can only see your hand. There's a lag between the video.
हे नको हे नको take it.
You didn't tell me what camera he's using. Is he using a mobile
Sir,
phone?
he has not given me the.
It's a fixed camera.
It's a fixed camera. माझं हे
Fixed camera, fixed with the light on top?
So 1 minute.
It's behind now.
It's not on the top. It's on a. It's like on a tripod.
But which camera is it? It's
I don't know. He's not telling me which camera. Specification सांगा ना cameraचं.
no, is it a regular? Acha. Tell him to show it in such a way over your right shoulder so we can see what you're doing. Otherwise,
आणि
all
माझं
that
हे
we're seeing
पडतंय.
is your hand.
हे full पडतंय.
I think if the person who's holding the camera stands on a platform, it will be easier for him.
इथे पाठीमागे ना हे लाव मायक्रोपोर लाव.
राइट होता है.
ओके. Okay, so we have give me a
So
word.
we have just a black screen. We have nothing. Okay, fine.
Okay, so we have undermined anteriorly, we have undermined posteriorly also.
Yeah.
Okay, so now we will start taking the
Periosteal incision. So can you explain to them what is your periosteal flap like? Explain it before you take it.
flap.
Take a piece of gauze, triangle.
I
and
just
see
first
them-
mark for
If you can explain to them what flap you're taking.
inferior edge.
Sorry? The inferiorly based. Inferiorly based.
No, posterior superiorly based.
As I said, if you can show them with a gauze piece how you're going to raise the flap so they understand what you're doing.
Okay.
See, if you imagine.
So this.
Yeah. The picture is coming, breaking. I don't know what's happening.
So I took.
Yeah, okay, fine.
Can you see the triangle of the gauze piece?
Yeah.
Huh?
Yeah.
So I have taken the incision this way and the incision here. Okay. The sides of the triangle.
Yeah.
And this is the base.
Yeah.
So I'm going to lift this flap up like that. Okay.
Fine.
Okay.
So posterior
Yeah.
superiorly based flap.
So it is a posterior superiorly based flap.
Okay, fine.
Okay. Take a retractor here.
Yes, sir.
Okay, and again with
Very
the
good. Very clear. Go ahead.
okay, this is your. I'm just retracting this edge anteriorly. You can retract till you see the posterior canal wall. Posterior meatus here. Okay. Okay. That is your posterior. That is your canal.
I think all we can see is your hand. Don't
वरून
worry.
घ्या ना.
Once you take the microscope, we'll be better off. I mean, whoever is using the camera and his camera is very jerky in the sense, the picture is not smooth. The picture coming is, it's jerking all the time.
Can you see the triangle now?
Yeah.
Okay.
Okay, fine. Yeah, hold the camera where it is now. This is good. Yeah.
Okay.
I don't know what's happening to the picture. The picture suddenly stops in the middle.
Leader, you can contract.
The picture is frozen.
It's always present in
Okay, go ahead. Fine.
the mass.
No, go ahead. You go ahead with the discussion. We can see the posterior superior base flap being raised.
working.
Sometimes you'll come across the emissary vein there, no?
Yes.
So what do you do if you get the emissary vein?
So I just told them that if there is a mastoid emissary vein, you can cauterize it. If it cannot, if the bleeding doesn't stop, then you can use only a bone wax to stop the bleeder. So always should have a bone wax on your trolley. You can see this. Okay, that's how we cauterize the bleeder.
Are you able to see the screen yourself?
So my screen, I am having there's a obstruction in front of the screen.
Okay.
Barobar ata?
Anyway, you've got the nice triangle exercise, which is posterior.
Okay, so this is the triangle, if you can see.
Yes, it's very clear. Okay, go ahead.
Yeah. Okay, now take a periosteum elevator and very slowly just elevate make a small pocket here, not a large pocket, just enough for the
implant
silicone template to snugly fit inside. Okay, so this is your silicone template here, which just goes underneath and fixes it. You can see it going inside. Okay.
Yeah. Okay, fine.
Is it a good idea? Have you asked the skin and
Okay, I'll have a stitch, please.
where the template will be sitting?
We stopped doing that.
And no more the methylene blue. No.
Stitch, please. So you can use a mastoid retractor also, or you can take a stitch here to retract this anterior flap.
Yeah, put a little bit of gauze piece between the suture and
yes, sir. Take a gauze piece.
Before you tie, just put a gauze piece. Okay.
Yes. Fine. Yes, so now we have very secured the anterior edge. Okay, this cut. Okay.
Yeah, very clearly seen.
Yeah. Yeah, a little bit, you just take care of the triangular flap. Okay. Okay, now I think I should come to the microscope so that we can start drilling.
Yeah.
The mastoid. Okay, microscope, please.
Sangeeta, anybody from Biomed over there?
नहीं आता मी microscope घेते.
See that she has not elevated the posterior canal flap too much, just enough to identify where the posterior canal is.
You can see this here. Shift to the microscope, please. Microscope shift kara, please.
So, sir, the skin and the periosteal flap incision will be on the same line?
Beg your pardon?
The skin and the periosteal.
No, the skin was a straight incision. The periosteal anterior incision is much closer to the canal, and the posterior incision is way back. So what comes under the skin suture afterwards is the full flap of periosteal.
I think it's important to understand it's a double layer closure. It's a double layer closure.
Yeah. Yeah, thanks.
Recording on.
Okay.
I think go to the lowest magnification for now.
So this is lowest now.
Okay, fine.
Okay.
You can just. Oh God, this you can't see on the screen.
Okay, so we'll start. Before that, I will show you how we drill. Give me a cautery, please. Cautery, please.
Too fine. You can see the spine of Henley? Just about. Yeah, there.
Yeah, this one.
Yeah, that's right. So the important thing is you don't need to elevate the
Give me the
dome
pen.
of the sternum. Just enough for you to get the identification.
So now this is your zygomatic line here. Okay, this is a posterior canal wall here. And this is going to be your sinus
Triangle.
plate. So this is going to be your triangle this way. Okay. Okay. Rajesh?
So this incision is very similar to what they showed as a minimally invasive technique. The incision is the same size, but we will still a small depression for the receiver stimulator and take a stitch to fit it into place. But the stitch is something that we have devised.
Not working.
We will show you how the periostal stitch is taken, so that there is no chance of the device moving.
Rajesh na bolwa.
Flap is also posture pyramid. Yeah, so it's a very broad-based flap, good blood supply.
Okay. Okay. So we start drilling. We first do a cortical mastectomy. In young children, you have to be careful because you have a forward-lying sinus, low-lying dura.
And that you check already on the CT scan. So.
Yes. See that you drill from the side of your burr. Okay, another most important thing is this posterior canal wall should be bang vertical. You cannot have a beveling of this posterior canal, posterior wall here. It will go right up to the tip. Okay, you can see the dural plate here.
Yes, ma'am.
Okay, this is your sinus plate. You can see the sinus here. And this is your sinodural angle, right?
Yes, ma'am.
Okay, and I'll go to a little smaller burr. It's blocked suction. Just flush the camera. Okay, now we will look for the
So you drill towards the root of the zygoma.
Yeah, we look for the incus now.
In the antrum.
Okay, that's a lateral semicircular canal. You can see.
Yes, ma'am. Ma'am, is there a provision to a white balance of the microscope?
Okay.
Just do a white balance.
White balance.
It's appearing a little too pink.
Yeah, okay. I'll just arrange one. Can you call the biomed person here, please?
Ask one of the residents to mark yourself button the white balance. Might myself.
Can the image be cleared more?
Okay, we can just see the incus coming in the view.
Yeah. Abhinath, you were saying something, image not clear? White
balance kara, please. Take a gauze.
There is the flush pan marna.
White balance kara. Done? Better now?
Not really. But I think it's okay. Just flush it out one with warm saline.
Yeah, let it out.
Just flush कर जरा.
थोड़ा oozing जास्त कमी करता है क्या विचार आने से कुछ while thinning the ESP, ma'am, you're there?
Okay. Give me a small suction, please. This is too big.
Okay.
It's small, Dhyana sister. छोटा दे छोटा. Okay. Okay.
So you want to ask something, right?
It's better now, sir?
Okay, sir. Yeah. So in case you have a rent in the ESP, how do you normally manage it? Rent in the ESP while thinning it? Yeah, what I would do is I would collect some bone dust. I personally would prefer to take a small slice of cartilage, lift up the external canal skin, put the cartilage from there. So between the skin and the rent, I have a cartilage in front, and from the mastoid side, put a little bone dust and cover it with a piece of fascia. The sandwich thing. I would take front and back both.
You have a smaller burr than this?
Sangeeta, I think
Okay, now we'll start.
Well, थोड़ा pink है, त्यांना bleeding थोडं कमी करता आलं तर कांड होईल. बाकी doing very well.
थोड़ा सा पिंक यू आलाय म्हणजे जरा नॉर्मल असं पिंक दिसतंय सगळं. Just flush कर. Okay, so
yeah.
Okay, so give me your curved pick, please.
You can see the incus very well now.
Yeah. Give me a curved pick, please, sister. Okay, so now you can see this is your incus here. This is your lateral canal here. This is your posterior canal here. This is your tip. Okay. Yes, now we are going to now start doing a posterior tympanotomy. So now there are the landmarks we need to know about the facial now. Okay. So you know this is your short process of incus and this is your digastric ridge here. So your facial is going to lie here. Also, we need to know the facial is medial to the lateral canal. So if you see the distance from this of the incus, body of the incus, and from here, your facial is going to lie somewhere here. Okay, so we'll keep on drilling that area.
Approximate length of the body of the incus.
Yes.
In that plane, from the top towards the fossa incudis, if you extend an imaginary line, the length of the body of the incus, that's somewhere where she's drilling now, where you'll approximately look for the facial nerve. The digastric ridge, you don't usually use when you're doing a cochlear implant. You might use it when you're doing the facial decompression like we saw just now. Hello, we lost the video now. We lost the video.
Okay, now I'll take a diamond to start looking out for the facial.
What is happening? Suddenly it is changing.
Hello.
Now you carry on. Okay, much better. It's okay. We have lost the picture for a minute.
Okay. So now I'll start. There is important thing again to how to start your posterior tympanotomy. So if you give me a curved pick, I'll tell them. So the distance from the short process of incus till this lateral canal, this distance should be the same inside the anteriorly also. So this is 50% here and 50% inside. So we have to keep on thinning the canal to create the base of the...
What she's saying is that the base of the triangle is towards the fossa incudis. The fossa incudis should be in the center of this base. If you go too much towards anteriorly, you will make a hole in the posterior canal. If you come too much posteriorly, you're going too close to the lateral canal and to the facial nerve. So the base of the triangle should be such...
Turn the table opposite to me.
Fossa incudis falls somewhere in the center of the base.
Can you turn the table opposite to me?
50% behind.
Opposite to me. Towards that side.
Yeah, so
no, opposite please. Yeah, okay. Okay.
Yes, sir.
Okay.
If this is going to be your base of the triangle, fossa incudis, where it comes 50% in front, 50% at the back. So you're going neither too close to the facial nerve, neither too close to the external auditory canal.
Can you turn the patient towards me? You're taken too much towards that side. Towards me, yeah. Yeah, bus, enough.
Right, please centralize. Yeah. Yeah, that's much better focus now.
Yeah, okay. Okay, so I'm thinning the canal.
Now, contrary to what Dr. Kameshwaran has said, she's using a diamond burr all throughout. But if you're irrigating well, then there is no danger of using a diamond burr, because a diamond burr definitely creates more heat as compared to a cutting burr. So good irrigation is required. But the advantage of the diamond burr is that if you do accidentally go close to the facial nerve, you will not damage it.
Okay, so by doing this, you're making a very large area here. So it's like a funnel, then like a tunnel. Okay. See, slowly, I'm able to get the 50% inside.
Ma'am, are you using a nerve monitor right now?
No, we don't use a nerve monitor.
That would be an additional some 15,000 rupees. We are able to see the sentinel cell now. Yeah, so that cell there, the perifacial cell will lead you.
Yeah, these are the perifacial cells here.
But what is important is that you identify the facial. If you identify the facial, you cannot damage it. All the cases you identify. All cases. Look, I'm doing a lot of teaching and mentoring. So this is something I would say, do it, see it. It's like in thyroid, it's better to see the recurrent laryngeal nerve so that you don't damage it. Our general surgery colleagues say we never see it and we never see a vocal cord palsy. I tell them, you don't see the vocal cord palsy. they come to us in the ENT department. So always identify. The nerve has to be there. So you keep on, you've already seen it in the CT scan. And
So simultaneously also keep on thinning the canal.
yeah, but make sure that you don't. Will you see the Khada and facial?
Sir, is there a ballpark figure where you can, say that how much to thin the posterior canal wall? And then you can still see the shadow of the instrument.
See, usually it changes color. It changes color there. You can see that once all the cells are drilled out, and as Dr. Kameshwaran said, it should be like a ground glass kind of appearance. Especially because you've not lifted the skin off. Thinning it out is not a problem. It's not a free thing. It's got one complete blood supply intact on one side. Sometimes very superficially I thin it so much that I'm able to actually bend it forward. Yeah.
Can you use a periosteum elevator to bend it? Or?
No, with the drill. You saw Dr. Kameshwaran doing that.
Okay, so now if you want to see, give me your curved pic. This much is your body of the incus here, and you are going to get your facial here. Okay?
Yeah. But what you can see there is that it's a very broad-based approach that she's using. It's like a funnel. It's not like my friend would say, a friend from New York, Tom Rowland, make a funnel, not a tunnel. Why is the
If you see the bleeder, they may just, that's a cell, but don't try and enter inside. First, identify the facial.
Yes. And the depth of the facial can be variable. Sometimes it's very superficial. You start drilling and you hit it. And sometimes you drill and you drill and you drill. It's very, very deep. So just keep on deepening. You know that the facial is going to be there and keep on looking for it. I think we can just about.
Okay, I can see the chorda, but I'm not able to see the facial.
Yes, you can see the chorda. But just show them the chorda.
Yeah, I'll just show. Give me a curved pic.
Be able to see the chorda.
That's the chorda.
Yeah.
Give me a, this is not a good curved pic. Give me another curved pic, please. That's a chorda here.
That's a chorda, very clearly seen.
Yeah, and most probably this may be the facial, but I'll have to.
Yeah, just little more drilling and you should get it.
Yeah, so this is just a cell here. Okay, that's a facial here, most probably. Give me 18 number. 18. It's small, your to say 18 number 9. Yeah, so that's a facial here.
Little pink coming into view, so delineate it a little more if you can. Yeah, there it is.
Yeah, that's a facial here down. Okay, sir.
Which one?
Still need to delineate.
Delineate a little better. Yeah.
You can very well see the chorda now.
Yeah. But no, facial finely defined. There.
Yeah, I'll just show you. So you can see the facial here.
Yeah,
Yes,
but-
ma'am.
Yeah. Now this burr is little big in size. Just finish off this area and then I take a small burr now. Okay. Okay. So now I know where my chorda is. I know where my facial is. So keep on the thinning this bone.
Yeah, but you can go a little closer to the fossa impetus because that's where you'll have a broader space, no?
Yes.
As you can see the bluish thing coming, which means you're about to enter the ear. That bluish hue tells you that you're just about to enter the middle ear from there. So to the left
Okay.
of that, where your suction is, that
Give me a curve pick. Yeah. So you can see this is a pink hue here. That's a facial ear.
Yeah.
Yes, ma'am.
Yeah. And that's a chorda ear.
Yeah.
Okay. This is your.
you can
I'm going to
this
remove all this
backbone.
bone from you.
Remove a bit of that buttress so you'll have
Yeah,
a
yeah, I'll do
light
it.
going inside there. But see the advantage of defining the two, you can have a much bigger opening knowing exactly where your facial is and where your chorda is.
This is the facial where I'm on it. Okay.
Yeah, remove
Yes.
that bone to the left here. Okay.
Okay. Now if I turn microscope, you'll be able to see the stapedius tendon. Okay.
Yes, ma'am. We can see the impedostapedial joint. I think.
Yes. And even you can see the stapedius
Can
tendon
you clutch
also.
inside a little bit and you can enlarge the cavity a little more. We can just
Give me another.
saw the round window keeping
Yeah.
it.
And give me. Please give me a gel foam, adrenaline gel foam, please.
Put a
Little
little
bit.
line there and see if you can see the.
Yeah, I'll just 1 minute.
You can
A little bit I'll drill inferiorly.
Yeah. Because she sees where the chorda is, she can confidently drill there now.
Yeah, the chorda is here.
Now she's drilling the bone which is medial to the facial.
Okay.
You can just
we can
start to see the round window.
You can just see the round window coming there. Okay. Now I'm going below the facial. Okay. My facial is here. I'm drilling below.
You're meaning medial to the facial. Medial.
Yeah, medial to the facial.
In case we are unable to see the round window, what are
Okay,
the
now-
ways how you can approach towards the round window? One is to sort of thin it out the posterior canal wall so much that you get a little more angle to look inside. So thin out the posterior canal wall, go right up to the chorda, go right up to the facial. You can go up to the chorda facial angle, and you can tilt your microscope so that instead of looking at the window from behind, you're trying to look at it from the inferior aspect. Sometimes we even go and remove the incus buttress and try to look at it from
And you keep the table straight.
If there is no hearing,
Neutral.
you can even take out the incus. So you get a big gap. So then you go superiorly and look from superiorly.
Yeah.
Otherwise,
Yeah.
Otherwise, you can decompress the chorda and push it forward, take it out from the canal. You can use a 30-degree 2.7 millimeter endoscope. You can just put a little saline refraction and see where the window is, so you know where you can do your
So we
cochlea.
can see now where the round window is.
आतमध्ये जरा लाईट पाहिजे थोडा.
A light पाहिजे ना. थोडंसं turn the table little away from me. Little.
You can thin out the posterior canal wall.
Yeah. No, away from me little. Yeah. Okay.
Superiorly, and along with the skin, push the whole canal forward. Yeah. Do your work and then push it back like a canal wall reconstruction. Worst comes to worst, decompress the facial nerve, retract it back and drill the bone over there under the facial nerve. Or if the cochlea is really rotated and the round window is facing backwards, then you go deep to the facial nerve and enter the posterior tympanic recess deep to the facial nerve. These are all the various things that you can do. See how thin she's making the bone, yeah?
So when you're thinning, you should see that you are seeing the whole. Use a big burr, diamond burr to thin out the canal.
Okay. Okay. Good. Lovely. You can go. You have much more. I think you can drill a little bit of the bone inferior.
No. Yeah, and cordofacial angle.
Or towards cordofacial angle and deep to the chorda also. So you'll get more light going in. I mean, worst comes to first, you can sacrifice the chorda. But if you're going to be doing bilateral, you don't want to do that. I think you still got some bone over the facial.
Yeah.
You know what I say here? Remove the bone superficial to the facial, molecule by molecule, little at a time. Don't try to hurry up there. And you can amazingly get so much bone removed till you reach the facial teeth. Little bit at a time, yeah. Yeah, even that bone to the left of your burr, yeah. See how much bone there was still over the facial. And medial to the facial also. What khali bone is it? Nothing medially to the facial. Beg your pardon? Medial to the facial. Medial to the facial, yes. And now if she sort of tilts her microscope from little inferiorly, you'll see the whole thing. There, see that? Yeah, some more bone can be removed, but she's got a good view of the window now. So this is dark inside, but we'll see.
This way? Yeah.
Yeah. आतमध्ये फोकस ने थोड़ा बोन अजून काढतो त्याला. Yeah. Okay.
Better now?
Yeah, yeah.
Okay.
Able to see the superior niche, anterior, inferior, not in the posterior. Yeah, very good. Yes.
Okay, sir?
Yeah. Yes, ma'am. You can remove that little, that.
Yeah, this bone, na?
Yeah. Kitne, sir? Yeah, just around the around window. Yeah, in this area there is a congestion, no? So can you keep adrenaline? Can you keep a mucosal flap elevation, sir? Will it help or no? If you mucosal flap elevation. Yeah,
Okay.
where you want to drill the operculum, you remove this case. Yeah, you remove.
Okay, so now, sir, we will go in for doing the
Can you
little
just do
trough
one
for
thing,
the
Sangeeta?
yeah.
Just one suggestion here has come. Why don't you remove the mucosa, scrape off just where operculum you are going to drill?
Huh?
Just scrape that mucosa and put the adrenaline gel foam there.
Okay. Give me a cord pick, please.
That's what you were saying, right, Doc? Yes. Yeah. That's a very good suggestion so that when you go to drill the operculum, you don't have bleeding mucosa there. That's right. Excellent. Yeah. Move it upward. Yeah. Yeah. Now you can put a little adrenaline gel foam there.
Adrenaline gel foam, please.
So you can see the facial beautifully delineated there. You see the chorda. Now you've got both things under vision, so the chances of damage are much greater.
Okay, hydrocord, please. Okay, so now we will go and drill the trough because this is an AB device. I'll again show you the landmarks how to be drill the trough.
External camera now again or with the microscope only?
No, with the I'll try and see if I can do with the microscope.
Okay, then magnification to be reduced. Yeah.
लागत नहीं आती है. Okay.
Sir, there is a question.
I'm just making a little.
We wanted to understand your experience of bilateral cochlear implant in same sitting. If indicated and if the implant or the economics permitted. Just
so this is your sinodural angle here. Okay.
Yeah.
Give the silicone template.
Just yesterday I've done a bilateral incomplete partition 3. Bilateral. I have done bilaterals in even 8 and 9 month old children. So that's where the parents wanted a bilateral, they could afford it. And
see that?
So if both cochlea are suitable for implant, there is no reason why. Only thing is we tell them that in a child, if for some reason I got more bleeding while doing one side, say emissary vein or something, and I felt the blood loss was too much, I would stop and if I don't want to take a risk. If there is no blood loss, I would easily go ahead with the other side. So yesterday was horrible because both sides I had TSF gushers. It comes at you like a waterfall, coming.
Okay,
they were very keen on it. They had the money. So thank you, sir. So that's the dummy, and she will mark out. Remember, Dr. Kameshwaran had marked out with the drill itself.
Okay, so give me the. So this is the retractor which we are using. This is designed by Dr. Kirtane, by sir. If you can see, I'll just show you.
We are eliminating the posterior superior flap. This retractor will help. Huh? Yeah, but can you mark out with your pen or whatever the?
Okay, so we'll mark out with the pen.
It's right angle.
So the I'm just
angle retractor with a cavity, and it's got those
retractor
sort of hold on to the bone. But with
so you can see the template inside, And this is going to be your for the channel.
You can mark it with the cautery if you want.
Gauze.
Sinusoidal angle is the entry point. Somewhere there, 45 degree. You are dictated to by the presence of the two suture lines there. I think the
Audio more? No. It's okay. Yeah, I'm okay.
That's right.
Okay. Artery. So we have marked the area for making the trough. So we use this retractor to go underneath this flap and pull it up like that.
You can pull it like this. So you're actually, with that small an incision, you're having enough space to drill the bone. See that?
Yes, I did.
And in this case, because the implant is flat, you just need to make a small 1 or 2 millimeter depression.
Come and press on the head. No.
You can see the drill marks on the retractor, but it doesn't allow the subcutaneous tissues to get damaged. So the difference in this.
Okay. Can you see now, sir?
Can you see the amount of retraction you're getting with this? No, they were showing it with another camera. That was much better.
Not the microscopic camera?
No, there was some other camera which the picture was.
Yeah, okay. So we'll have that other camera. Microscope bazula kar. External camera.
Yes.
Sister, तुम्ही हे इथे सोडा. Somebody should have washed up with you today.
Get one of them to wash up.
नहीं माइक्रोस्कोप का दिखा उधर
माइक्रोस्कोप नहीं दिखा रहे माइक्रोस्कोप का कैमरा नहीं चाहिए आपका कैमरा
ये डायरेक्टली दिख रहा है
ये जा रहा है ये बाजूला कर.
Now we've got the external camera.
Okay, sir.
Get one more person to wash up with you.
Sorry.
थोडंसं डोकं बाजूला करायला लागेल.
No. No, I asked the sister, somebody should wash up with the sister. She's alone here. I can't see the light.
You want to do it with the microscope?
No, sir. Hey, microscope बाजूला कर.
Yeah, with these the visibility is very good. But see how much of a retraction you can get, and it's completely protecting the flap. So you don't get an accidental burr onto the flap. Yeah, this ultra thin J, no? So the thickness will be less and the dia will be more, no? Yeah, the receiver. Yeah, the dia will be more. The receiver it will be a little square. Square, yeah. So you don't have to go all the way in. Very thin. Actually, we had that old implant from Neuralec company where we didn't make a wedge. We just split it into 2 screws to be put. That was nice. I don't know why the other companies don't adopt that screw thing. So he's making a little channel there, and then she'll show you how to make a little hook. That hook is to hold the implant array without allowing it to bounce out. Electrode array. Retract a little better. Yeah, that's better.
So press the head, na? Nusto tap. Press.
So we are still doing the small incision. You saw the size of the incision was like what Dr. Raghu showed that way. Yeah. Minimal access. But because of the retractor, you are able to drill. And we like to fix. Now, the fixation suture that you're going to see something we have devised ourselves. And we have done it in over 200 patients now. And it seems to work very well. It doesn't allow the implant to move till such time that a capsule forms around. See, the movement of the implant will be till the capsule forms. Once the capsule forms, it's not going to move. And even with what Dr. Kameshwaran showed, where you fix it to the bone, in our revision cases, we found that the capsule forms between the bone and the implant. The implant doesn't sit on the bone, doesn't integrate with the bone. A capsule still forms between the implant and the bone. So you are going to get the implant surrounded by a capsule, whatever you do. So what she's done is she's made that little trough there into which the implant will fit. But we will still fix it with a periosteal stitch, and it's made our life so much easier that we don't have to have that big access to drill the bone.
So we have finished that, just making a hook now.
Sorry?
We are making the hook now, just 1 minute.
हुक करताना मायक्रोस्कोप ने दाखवलं तर बरं पडेल.
Okay, sir.
So the hook with the mic. First of all, in this depression that you made, can you put the dummy and show how it fits into the depression?
Okay, I'll show the dummy first. Okay. Okay, sir.
See that? Fits beautifully, so it is not going to allow it to move. Plus, we'll fix it.
Okay, now we take a special stitch to fix the receiver stimulator. So, give me a retractor.
So this is interesting. While she's showing you how it is done, we will now estimate where the center of the implant will be touched.
Ink, blue pen.
We will mark that spot.
Okay, so this is the spot. Okay.
The center of the thing, and that she will mark the area of contact onto the periosteum. And now, with the absorbable stitch, she's taking a stitch at that point. Okay? So what she's done is, this is the flap that was raised. On the under surface of the flap, she's taken a stitch at a point where it's going to touch the center of the implant. And this will be kept aside. We will fix the implant with this stitch, but we'll show you how it is done. Right now, what she's going to do is drill a hook.
Okay.
So that I'm asking her to do it with a microscope so you can see it clearly.
Top light off, please. Okay. Okay, this is the cat's paw. So this is the channel which we had made. Okay, now we'll make the hook here now. Give me a small one. Suction. Suction. When you're making a hook, you have to be careful that you don't, there's a sinus plate below. Okay, now I take a diamond burr and smoothen out all the edges. Okay, that's a hook underneath the electrode area is going to go. Okay. I'm not able to hear anything from there.
Yeah. Yes, ma'am. Yeah. We can see.
Yeah. Okay. Okay. Water. Okay. Okay, so that is done. Now we will again go on the other.
You want to fix the implant now first, right?
Yes. No.
So that also you show
So before the implant, I will just remove. I'll just the round window area. I'll just little bit drill, and the overhang, the operculum, I'll drill out and keep some.
Okay.
Wash, please. A nice wash, please. Wash again. Yeah. Okay.
You normally use warm saline for these washes.
Yeah, it's a warm saline.
Centralized.
Okay. So now here again we have to take a burr which is a small around smallest burr with a tapering edges. So this is what sir also meant. So that when you use this type of, can you see and show the one with a shoulder?
No shoulder there. Yeah. It's a 0.8, ma'am. Yeah, it's 0.8, but there's no shoulder there.
Yeah.
So you could also use.
I'll just see that there is one with a shoulder. Yeah, we have one with the shoulder which is like that, but this is not the one.
Right angle handpiece, no? No.
Okay. So this is a tapering burr. So try to use a tapering burr here. Okay. It's dark inside.
We can just about see, so you can go ahead, no problem. Yeah. You can try doing one thing, Sangeeta.
Yeah.
The size of the circle, can you reduce? There's a knob in front of the microscope which reduces the size of the light circle. Just see if that helps in any way.
Yeah, better now.
Not
ठीक
really.
है sir?
Yeah, increase your illumination now. Your right hand side little
Hello.
button there. Go to, yeah, you just need to focus. We got good light inside now. You need to focus. Yeah. Hey.
Better?
No, previous one light was better inside.
Better?
Yeah, yeah, okay, good, good, good. good.
He can just hold it like that, okay? Yeah. Not much, though, not so much.
So you don't have to really take out too much of the operculum. If you do an extended round window, you don't need to take out the operculum. It's quite
No, it's not coming. The light is not coming.
now it's okay. Now it's fine.
Light increases nahi hote. So there's some problem with the microscope. Just hold on.
Is the biomed there or not?
Yeah, he's there. You are able to see?
We are very clearly now. Nothing.
Okay, sir. I'll just go ahead.
Don't change anything now.
No, okay.
Is the size of the bar? This is 0.8, 0.8 or?
Give me a 20 number section. 20 or 22.
Or this would look more like a 1 millimeter.
I'll be able to see, but the light is not getting. It's
no, we are seeing it quite.
Yeah, yeah. So okay, okay. Microscope ला हात लावून नका नंतर करा please.
कोण आहे तिकडे microscope? Don't touch anything now. You are fine as it is.
Reduce the make the this RPM less. हाँ. Speed कम करो. Okay.
I think you've got a good exposure now. Lovely.
Okay.
Just wash with a little hydrocarbon.
Hydrocon, please.
You're planning to do round window?
Round window only, sir.
Okay.
Okay. So now we will fix the implant.
Flush on the implant. Leave a gauze piece.
नहीं हो रहा है, कुछ भी नहीं हो रहा है.
Sorry, not a gauze piece. Put a gel foam inside.
I'm changing the gloves.
Yeah. You could have left the gel foam in the posterior tympanotomy, so you
yes. Gel foam too.
So that space future can be used for all implants, different companies. Yeah, yeah. But actually slim fit on all implants.
Please take a forceps and use it.
See, for example, in that medal,
okay. Top light, please.
Notch.
Clean this area.
Just tight in the notch. You see how she is doing it now.
Wet. Dripping wet. Dripping wet.
So now,
okay.
Cleans that area of all bone dust is cleaned out. Okay. Now go to the lowest magnification, please.
है ना ये दिखा. Okay. So now I have changed my gloves and I'm taking the implant.
Now can you show the implant? Yeah, he'll take it out of the box.
Yeah. This is the way. Okay.
I've not seen what. Go zoom out now.
Okay, sir.
Yeah. Maybe. It's called the high res ultra.
Okay. Now we keep this implant on the patient's head. And we have this stitch which is taken. Hold the implant, please.
Somebody's finger should be on it. Somebody should on the outside part. Yeah, please.
Okay.
Ma'am, the camera.
Okay, now this stitch we are taking a stitch on the implant.
You had that stitch, right? So this is the rear end, not the needle end, the other end. You take it and tie it in the center.
Yeah, tighten.
You can't see what you're doing. Your hand is coming in the way. Okay. Laying over the magnet area. Okay. Make it really tight.
Okay, now slowly.
So what suture material is that? This is vicryl, right? Absorbable.
Okay.
Now this is the needle end. She starts pulling the implant.
This is the needle end.
Somebody just hold the implant. It shouldn't fall down. You pull it in. So the thigh will go towards the sideways or in the center.
Okay, sir.
Magnet area. No,
Retractor. Catch scope, please.
magnet is much further back.
So you can see this. Now a suture exactly is coming there. Now take a suture now. Tie the implant to the periosteum now.
Did you understand that? It's anchored to the undersurface of the periosteum. The idea is you're not going to allow it to move till such time that the capsule forms. After that, it doesn't matter. So that's why I'm using an absorbable material. So how long it takes for the formation of the capsule? I think, I'm sure within 6 weeks to 2 months, the capsule will form. One could also use proline, for example.
Okay. Caesar, please.
Bond use ethibond. Ethibond, sir. The one proline, in many cases, it is producing biofilm. Then the knot is outside. Yeah, but this is absorbable, so this will go away. Yeah, take the microscope view now. Okay.
Microscope view, please.
That's why I wanted you to leave a gel foam so all this blood, etc., can get absorbed. Go to lowest magnification. Like flush mark on. Very good. Now we can see it. Yeah.
Okay, you can see the pulsation also. A little bit of while drilling the little, not a rent you can say, but you can see.
You can see the pulsation.
Give me a hydrocot. Okay. Better now?
So we can see it, so you can go ahead. Don't worry.
Okay, sir. I'm not sucking near the, I'm just not sucking on the round window, okay?
And you're opening the round window with the same needle. Now we can see the round window open. Now you can see that. So it is
perfect.
Yeah. The inferior margin of the round window membrane is been separated from the wall. Yeah, okay, fine. Okay, with the pick you'll make it slightly bigger. As you can see, CSF is coming, but the CSF is oozing. It's not bursting it. It's not gushing it.
Okay, sir?
Yeah, excellent. Excellent.
Yeah. 22 number. Okay, now we'll
आता काय करते? Implant.
Okay.
Now she takes the implant.
This half banded one. See that the implants are, the band are towards the incus.
Yeah.
Okay, it has gone inside.
Yeah. So they used to give an inserting tool. No? Yeah, so she's using a faucet now. So this one doesn't have an insertion tool. You can see those electrodes are pointing towards the incus, right?
Yes,
Towards the modiolus. And can you go to lower magnification?
Yeah, I'm going, sir.
And go slowly, one electrode at a time. Go slowly.
Yeah. Can you see now? And there's a wing here.
Yeah, so the wing has to be inferior. Most importantly, electrodes are pointing correctly and the blue mark is up to where you have to go. If electrode array is having how many electrodes? Sir? This is 16 electrodes. 16. You may need to hold it closer to the.
So, sir, like in the morning we discussed 5 minutes, something like that.
Yeah, this is impossible for the human hand. That's why you need 4 minutes. 9 minutes, some people say. Who to believe? 2 minutes, 5 minutes, 9 minutes. I think if you can take it over the next 1 minute or so for insertion, that's good enough. So if there is a gush of CS7, okay? Yeah. Again. If there is a gusher, you wait for some time, let the fluid gush out, the pressure becomes less, and then you pack all around. But sometimes what we do is we take a periosteum piece, make a hole in it, and thread the array through the periosteum. If you thread it through the periosteum, and you go to the blue mark,
already
when you reach there, you have got the connective tissue on all sides of the implant, so you can push it in.
The city we have seen enlarged vestibular aqueduct.
So because there is a IP2, maybe it is not going so.
You may not have completed, but no, it's up to the blue mark already.
Yeah, a little bit inside I have to go.
Yeah. Yeah, but rather one electrode remains out than you push it too much. Because in a malformed cochlea, you may not have the entire length to.
Yeah, curved pick. Can I use a little curved pick to push in?
Sure. Sure.
Suction, please.
But your insertion was fantastic. Just shot and it went inside. Yes.
Yeah, it is just the blue mark is just at the round window. It is not gone inside, but
that's enough. I don't have to bother. Yeah?
Okay, sir.
I think I would leave it at that. Even if one electrode didn't function, I would not want to take a chance of damaging the electrode. So leave it be.
Because it's not going beyond this.
It's okay, fine, leave it. That's
okay. Little micro. Okay.
No, you can't allow it to do.
Yeah, it's going inside now.
What happens if the CSF oozes later? You can't.
Let's go on.
You have to seal it on the table to make sure that you've completely stopped it. You
okay.
You will take connective tissue and pack all around.
Sushil? Yeah. Okay. Okay. So now I'm packed the round window with a soft tissue which I had taken initially.
She will jam it inside so that there's no question of it. You think, see that? Yeah, as far as possible. Yeah. But I will still try.
And the one behind one.
Section में पूरे कर. You can push the implant ahead with the suction with your left hand. Implant, push it with the left hand with the suction and push the thing behind you.
Okay, sir.
Okay. If you want, you've got one more piece, you can put it onto the right of the implant.
Yeah. Give me a. Okay. No. So now we'll hook that underneath the hole here.
एक piece घाल ना आतमध्ये अजून. To the other side of the implant, you can put one more piece.
Yeah, I'll do it.
Now that little drum-like thing you see on the array is the ground electrode. Yeah, put it behind the implant there. That's right. That's right. Yeah. Okay. Show them the ground electrode. Focus on that.
Okay, now. That's the ground electrode.
See that drum-like thing? which is pushing under the bone. That's the ground electrode there. And that she will push. See how it's gone under the hook, so it will not allow it to bounce out. And this then she can just push inside.
Okay. Okay, sir.
Yep.
This soft
Now
tissue.
just take one perioperative stitch and we'll show them the neural response imaging.
Yes.
Is Sarvesh there?
Yeah, Sarvesh. No. Sushil is there.
Sushil is there. Okay.
Okay. Caesar, please.
Madam, this was like a robust minimally
Caesar.
Because
Suture cutting.
minimally invasive technique.
yeah, the incision is small, everything fixed in place. Even that little tunnel is not allowing the array to bounce out now. Yeah.
Suture.
Ask the Siam guy to come into the theater.
Yes, sir. So now this is your flap which you have taken, this flap. This is your periosteal flap.
Now the beauty of this is that the implant is nowhere near the incision. The incision line is not coming on the implant. And secondly, the entire implant is getting completely covered. No suture line is coming over the implant. You can see the mastoid cavity getting completely covered with the periosteal flap.
Yes, sir.
And the main body of the implant is under this flap. So when you close this flap like this, it's pressing the implant down, not allowing it to move. You can tell Dr. Haldi too. About something. So they say, young and one like 20 minutes after he can do it.
Step here, please.
We have to 5 o'clock, so most of the time. No?
Take one more, I'll take.
For 20 minutes now, we will not show the full closure, but we want to show the neural responses on the imaging. After that closure, they will do the 20 minutes. There is absolutely no tension on the suture line. The periosteum gets closed very easily.
Oops.
फॉर माय अंडरस्टँडिंग सर आपण ते नॉट जो बांधला होता तो बाजूला होता इथे आपण ते मध्येच ठेवलाय तर त्याने तसं काही जे आपण नॉट बांधला होता
दिस इज एन अब्सॉर्बेबल सूचर
ओके सो दिस विल गो so that will not have any issue.
कितने सर we are expecting this type of CS of leak. The metal is coming out with the form electrodes.
At the end where the implant is supposed to end going into the thing, the diameter increases like increasing wedge.
So you can see
that's
the
a beautiful
implant.
idea. We just go and block the window.
So you can see the implant here.
Form 19. Can you show the implant under the, see how the implant has got covered under the periosteum, completely covered, no suture line, nothing coming there. That's why this flap is so beautiful. No tension at all, and how the implant is completely under the flap. See that? Yes, sir. Yes, sir. Yeah. Okay. So now just put a gauze piece there.
Where
and
the gauze
show them
piece?
how we are doing the
Plastic.
go to the external camera, please.
External camera. Can you make the table neutral and raise the table?
So he just covered it with a piece of plastic. You could either cover the testing device in plastic or you cover the patient.
You will have to.
Now he's ready with the trolley there. Nati. Yeah. He's going to put he has to put it in the gloves. Yeah. So we now put plastic on the patient. Okay. And now can you focus the camera on his laptop, please? Zoom there.
Laptop.
So now he's going to measure the impedances. You've already measured the impedances?
No, sir.
It's what are those 3.3, 2.7, 2.7? वो किधर से आ गया?
And now this is the one which after putting implant inside.
So these are the impedances you can see. All are below 5.
He's done that already?
Sorry, below 4 you can say. All the impedances are below 4.
That was quick. Yeah. Can you do it again?
Okay, I'll do it again. So you need to click on this. Now it is showing that it is measuring out here.
There, that where his finger is there, the conditioning is going on there.
Priya.
And when that conditioning stops, you'll see the values appearing here. Okay, so absolutely fabulous values. They're all below 5.
Yeah,
this is excellent. I mean, below 15 you would say is okay, this is below 5. So
okay.
Now we do what is called the neural response imaging. So he will start with high current.
So he has selected 1, 3, 7, 11, 13, 15 and 16 electrode he has already selected.
And he's going from high to low.
Yeah.
Can you zoom out a little bit? Zoom out so you can see
zoom
the
out,
things
zoom.
also.
Okay,
fine. Go ahead, start now. So below you'll get the waveform, and in those circles that you see, that's a beautiful response plotted. That's the apical. That is the apical, that's right. So you start at high and then come to low. This is the next third electrode. Now again, very good responses. You get a negative and the positive peak, that green and yellow.
And the growth curve is good.
Is also good. Yeah, it's more or less linear.
Yeah.
Lovely. So he's taking four measurements per electrode. So far, so good. Yes, even on 15th electrode, very good response. We have to see what's happening on the 16th because we were worried whether it's completely inside. But on the 15th, you've got excellent responses.
Yes, sir.
And now, even on the 16th, you have responses. So your electrode is inside and it's giving you very robust, nice, big responses. So you're completely okay.
Okay, sir.
You deserve.
Now we'll do the C-arm.
Superb. Yeah. Now we're just going to show you that we always do.
No, let him come. Let him.
Yeah, you can take that out.
CM पर तिकडून तो focus, but he can focus from them.
So you can take out.
तुमचं तिकडे घेऊन जा.
You can take out the laptop focus now. Now go on to the C-arm focus.
Yeah. We are just arranging the C-arm, placing it.
As a matter of fact, we do C-arm and this together. You said this started. You get the C-arm in position. While the C-arm is being done, your neural response imaging is going on side by side. Not a problem. Yep.
तुम्ही पुढे जा. तिकडे जा पुढे. आप आगे जाइए.
सामने आपको दिखाना है. वो तो सामने का स्क्रीन है ना, आपको
आपको स्क्रीन दिखाना है. हाँ, बस उधर रख दिया तो भी चलेगा. हाँ.
Can you show how the
सियाम
Siam is positioned?
एक तुमचा कैमरा यहाँ टर्न करो और सियाम का ये पिक्चर दिखाना. हाँ.
This is a Indian make. This is Kiran, and I think it gives us better pictures than any of the imported ones.
हा पुढे जा जरा क्रॉस इथे जरा पुढे इथे क्रॉस आणि हे असं घे.
थोड़ा अँगल बदलायला सांगतो.
हा बस आणि टर्न थोडं त्या बाजूला झोपव बस. टर्न दॅट्स इट. हे बघ हे असं हे थोडं त्या बाजूला असं टिल्ट कर. हा कर अजून कर अजून कर अजून. हा बस आणि थोडस हे पुढे घे. क्रॉस इथे पाहिजे जरा. हा नाही थोडं मागे घे थोडं मागे. हा बस ओके. सो वी ऑल जस्ट गो आउट इन आउट ऑफ थिएटर. प्लीज ऑल लिव्ह द थिएटर. आपण पण थिएटर हे असंच ठेवा. आता तिकडे बघायचं. टर्न देअर स्क्रीनला.
Turn the camera to the screen, please.
Yeah, I'm positioning, madam.
Yeah, go ahead.
ह्याला स्क्रीनला ह्याला लावा. एक मिनिटच ह्यांना जाऊ दे मग आपण तिकडे फोकस करा. हे असं करा ना हे प्रॉपर. हा आपण बाहेर जा तुम्ही. हा हा तुम्ही फक्त फोकस करून बाहेर. हा ठीक आहे. हा या हा तुम्ही थोडं एक फॉर 2 मिनिटासाठी बाहेर जा.
Or they can wear a gown if they want. They can wear.
नो इट्स ओके. किंवा ह्याच्या मागे उभं राहा.
They can stand behind the guy with the gown.
या
Okay.
चलेल. हा शूट.
Oh, lovely.
ओके सर डन.
Can you zoom in on the array?
झूम कराय. हे झूम करा. एक सिंगल.
Can you see the implant position?
हे दिसतंय ना.
Beautiful, complete insertion, basal turn, middle. Bas.
बस मागे थोडं मागे घे. मागे
Position. And the clarity of this particular Siam is better than any I've used anywhere else. Absolutely top call. You can see a 3-dimensional picture of the array inside. Kangita,
yes sir.
Thank you very much. You can do the closure now.
Yes sir. Okay.
Okay. And there you can see the ground electrode, that little cylinder there. That's the ground.
That's a and you can see this from the round window. You can see the it's going inside from the round window.
Okay, so we are now going off the air for you so that we can get things ready for Dr. Haldipur. Once again, superb job. Congratulations.
Thank you, sir.
Thank you, sir. Thank you, ma'am, for wonderful session. And I thanks our panelists, Dr. Shetty and Dr. Lal, for being on stage and taking this. So thank you so much. And thanks, Kirtane sir, for taking the entire session lively. And since I was here, we had the minimum question because I was, making
Top light,
entirely during the entire session. That's why we had a very few queries and concerns during the session, sir. Since you were there to moderate the entire session, they could
low, please.
Actually see and understand me. Thank you so much, sir. Thank you so much. Thank you, ma'am. So we will be now we'll be switching over to Dr. Haldipur sir's case. So we'll be switching over shortly. Yes, sir.
Hello. Bangalore? Yes.
Yes. So
Just 1 second, sir.
Once again take an honor and would like to welcome Dr. Deepak Haldipur, sir.
who is internationally renowned ENT surgeon.
Sir.
Hello.
Yeah. Hello, sir. Can you hear us?
Yeah. Hello.
Yes, sir.
Am I audible?
Yes,
Yes, sir. You're audible. Dr.
Yeah, but
Deepak, you're audible.
Sir. But I think that CRM thing is over, Sarkar.
Yeah.
Yeah. So, sir, we are switching over to you only, sir.
Oh.
I take this opportunity to welcome you and your team.
Yeah.
And I would like to introduce you to the entire audience out here.
Yeah.
Sitting here as well as watching you over the telecast. So Dr. Haldipur sir has an immense experience spanning over 3 decades in the field of
Niranjan, lights were on, madam.
Past president of Association of Otolaryngologists of India, and performed live surgical demonstration as a guest faculty in academic events worldwide, and contributed various articles in a distinguished journal. So I welcome Dr. Haldipur sir and his entire team. So welcome, sir.
Yes.
Now I would like to invite our panelist, Dr. Kusum Patidar.
Is an adjustment. Okay.
Dr. Kusum Patidar.
Spice camera.
Welcome, ma'am. Please be on the stage, ma'am.
Dr.
Ritam Roy.
Yes. Sponge देना बेटा. Stilet लिया.
And Dr. Rajesh
का section check
Padi.
किया. Debrader का section check किया क्या?
Dr. Rajesh Padi. Sir, are you there? So I welcome our panelists for this case, and so the panelists are Dr. Kusum Patidar, who has graduated and post-graduation from Indore, gold medalist in her post-graduation, worked in MGM Medical College for a few years, serving aggressively to the rural community around Indore, and she had been instrumental in serving thousands of young patients who needed the cochlear implant, and her keen interest is in early detection and treatment of head and neck cancer patients. So welcome, Dr. Patidar. Dr. Ritam Roy, who is the MBBS gold medalist and currently the associate professor of Department of ENT, Bardhaman Medical College, West Bengal. Trained in middle ear surgery at Nanavati Hospital, Mumbai. The functional endoscopic sinus surgery at Hinduja Hospital and KM Hospital. Microlaryngeal surgeries and thyroplasty from Bombay Hospital. And has a multiple national and international journal to his credit. Dr. Roy, and as a panelist. So when Dr. Padi is here, we would welcome him. Okay, so Dr. Padi is the head and neck surgeon and alumnus of Tata Memorial Mumbai, an eminent and surgeon of Odisha in current year. He has an experience over 20 years, and he has operated almost 8,000 distinct head and neck cancer cases.
Local.
His special interest area comprises of laryngeal, hypolaryngeal, and skull-base surgery. So I welcome all our panelists for today's case. So over to you, Dr. Haldipur, sir.
Yeah. Hello.
Yes, sir.
Am I audible?
Yes, sir. Over to you, sir.
Who is on the other side? Any of the moderators there?
Here, Kusum. Good morning, sir.
Hi.
Here.
How did you make time?
Just because of you.
With your busy practice, we were supposed to do this tomorrow morning. So I thought Saturday evening you may be busy, Kusum.
No, sir. I just
No,
came.
Sponge? Yeah.
For you only. Just want to see. And, just want to interact. I'll get the time, sufficient time to interact with you.
Yes.
Okay.
Don't worry, I'll canvass for you in the next year.
For what?
Obviously, when is the assembly election?
November, December.
I'm
not going to contest.
Oh, really? Why is that?
No, sir.
You were supposed to, na? Sponge? Press karke dena beta. Actually, Dr. Kusum, I love to use the pieces of net cell.
Yeah.
For some reason, we are not getting net cell of late. You are getting it there. We are getting mirror cell, which is a lot more softer. Doesn't give us the necessary tamponade that, we would prefer.
Sir, one request. Can you simultaneously please brief about the history of the patient? And
Yeah, Akshay. Naveen, ಆಮೇಲೆ ಸೆಪ್ಟಮ್ ತೋರ್ಸು ಒಂದ್ ಕಡೆ ಬೇಕಾಗತ್ತ ವಾಶ್ ಮಾಡ್ಕೋ ಅಲ್ಲ ಇರಿಗೇಷನ್ಗೂ ಇದಕ್ಕೂ ಹೆಲ್ಪ್ ಆಗುತ್ತೆ ನನಗೂ ನೀ ಬಂದ್ರೆ ಲೋಕಲ್.
Dr. Deepak ji, can we have the endoscopic picture, please?
Yeah, I think they don't have the endoscopic picture, is it?
Now we're getting, sir.
अच्छा. अरे बेटा endoscopic picture दिखाना.
It's endoscopic picture is there.
It's there now?
Yeah, it's there.
But somebody is not getting it, no? Somebody.
No, just now we got it.
Okay.
So you are infiltrating with solution?
Sponge. Yeah. Madam, there are actually two viewpoints here. Now, a lot of people use undiluted adrenaline. Legends like Satish Jain, Janki Ram, nowadays just do the painting of the nasal mucosa with adrenaline, and they are showing, very good surgeries with very good hemostasis.
Yes.
Before this technique was being followed, we all used to inject a little, and I have still remained in that mode for whatever reason. So, except for once, in Hyderabad, the first Elite program, again organized by Janki, where, I could not get a good field. In that case, somehow I had a lot of oozing.
Yes.
Other than that, most of the demos I have had a relatively bloodless field, which is why I have not changed the technique. At the same time, I have not had many cardiac problems also by the selective injection in the axilla or whatever, local. So I still do a little bit of injection, madam, and I pack with 30 ml xylocaine, which has 5 ampules of adrenaline.
Okay.
I'll just read the CT scan for the delegates.
Yes, sir.
Shortly.
Brief history and radiological findings we want.
Absolutely. Akshay, a history ಹೇಳ್ಬಿಡ್ತೀಯಾ ಮೈಕ್ ತಗೊಂಡು ಕುಸುಮ್ ಪತಿದರ್ wanted to know. Sponge. नहीं तो छोटा रिबन गॉज भी दे सकता है बेटा. स्पंज ही दे दे, देखेंगे थोड़ा. थैंक यू. Patient also has a reasonable amount of high deviation and a deviated septum. So the left part is a little more narrow compared to the right. Okay?
Yes.
Now I am able to probably see the axilla of the middle turbinate with a little, maybe I'll give a small injection there.
Deepak sir?
Yes?
I am Dr. Palniappan.
Are, hello boss. How are you?
Fine, sir.
Congratulations. I saw so much of your good work on WhatsApp videos. Ironically, the first time we met was outside the country. I won't mention the name of the country. You know it, and I know it.
Okay.
We will keep it to ourselves.
The mirrors are gel form.
Yes.
Sir, if the mirrors are gel form. Sir, Handibu sir.
Yes.
The mirrors are gel form.
Yes, yes, yes. நீங்க சொல்றது correct தான்.
Miracell.
Sponge. I'm using the Miracell now. Soaked in the packing solution. I'll keep it there for a short while. One more. Yeah. This is a school teacher, Palniappan. I have been treating him for maybe around a decade or so.
Great, sir.
He used to come to me once a year with an exacerbation. I would give some, oral steroids. He would do well. This time he came and he said, I'm fed up, please do something. But as I'm demonstrating this,
They have put this.
I have a feeling.
Yes, sir.
External camera on the Adan Madama, light on Madam.
They have shown the slides, sir. 49 years old male.
Hello. Palniappan, Dr. Akshay will speak about the case.
Yes, sir. Yes, sir. Please, sir. PT also we want.
Yes. First, let Dr. Akshay speak. I'll read the CT for you.
Yes, sir.
Hello.
Good
evening, everyone. Here's a 49-year-old male patient who is a farmer by occupation. He presented to us with the complaints of bilateral nasal obstruction with frequent sneezing, more so about 2.5 to 3 years. So he came with the complaints that since 3 years on and off, he is having a bilateral nasal obstruction, which was insidious onset, and the obstruction is gradually progressive. And he also typically says that whenever there are episodes of cold, he could see grape mask kind of things coming out of his nose. And he also gave us the complaints of decreased smell sensation since past 3 years. Whenever the patient used to take oral medications or the nasal sprays, his symptoms used to reduce for a bit of time, and then the symptoms used to recur back. So there was no significant past history. And on our nose examination on the anterior rhinoscopy, at the time of presentation, we could see there were polypoidal masses occupying the nasal cavity, which were insensitive to touch, and there was no bleeding on probing. So posterior rhinoscopy was appeared clinically normal. The functional test showed that there was reduced smell sensation, and the cold spatula test showed there was reduced misting on both the sides. So this, as you've already seen, so this was the picture on the presentation. So there were, this is on the right side nasal cavity, and one more is on the left nasal cavity. So we can see there are whitish masses coming out of the nasal cavity. And his coina, once we can pass the scope below the polyps and see behind, the coina appeared to be free. So this is a case of bilateral nasal ethmoidal polyposis. I'm handing over mic to Dr. Deepak, sir. He'll be continuing with the CT scans.
Okay.
Okay. Hello.
Hello.
Yes, sir, we can hear you.
Are we back?
Yes, sir.
Yeah. Yeah, Kusum madam, oh, sound thoda TV se utna theek nahi aa raha hai. Anyway, are you getting the CT picture?
Yes, sir, we can see, but it will be better if you can zoom the CT.
Yeah, I'll read the CT. Are you getting the CT picture?
Yes, sir. Thank you so much.
Yeah. See, generally, I always look at a CT where we all get a single film like this. Many of the places you get a single film like this. Some of us can always procure a CD. If you can see the first cut, this is the right side, this is the left side. Can you appreciate the high DNS to the left?
Yes, sir.
And you can again appreciate it here.
Yes.
So the left frontal approach area is going to be narrow for me. Correct?
Yes, sir.
But just see above, there is a total agenesis of the right frontal sinus.
Yes, sir.
And there's a very small rudimentary left frontal sinus.
Yes.
You can appreciate a small interfrontal septal cell.
Yes, sir.
And the moment the maxillary sinus appears in the picture,
Yes.
you can forget the frontal sinus. Because what you will be seeing will be the anteriormost portion of the supraorbital cell.
Yes, sir.
Isn't it?
Yes, sir.
The moment you see maxillary sinus in the coronal CT,
Yes.
what you see here would always be looking at a supraorbital cell. You can see the frontal beak here, thick, already disappearing here. And you can see some neo-osteogenesis here.
Yes, sir.
As we go back, you can see the crista here, the W-shaped skull base, which is slowly going on and becoming a gentle U here.
Yes, sir.
So this cut is the posterior ethmoid.
Yes, sir.
All these cuts are the anterior ethmoid. In that, you can appreciate the Kennedy's nipple somewhere in this cut, appearing just there, where the anterior ethmoid artery may be running a little below the skull base.
Yes, sir.
On the right side, it is amalgamating with the skull base.
Yes, sir.
I always keep saying this concept, that there is a cellular mastoid and a sclerotic mastoid. Similarly, some sinuses are well aerated, well pneumatized, well developed, and some sinuses are sclerotic. This is one of those typical cases. He, being a farmer, becoming a teacher in his village, probably in his childhood he had some amount of anemia or whatever. So you can see that the pneumatization of frontals as well as other sinuses is relatively less.
Yes, sir.
The anterior ethmoids are reasonably okay. The posterior ethmoids are reasonably roomy. The maxillary is also reasonably okay. When you come down to the sphenoid, so again, frontal, I may with difficulty try to look at the left frontal. I'm going to encounter a high deviation of the septum. And even approaching that small rudimentary frontal, I have a problem with a small interfrontal septal cell, which means the drainage may be far lateral and difficult. And the anterior ethmoids, the anterior ethmoid artery is not hanging on a mesentery, basically because the supraorbital cell is not well pneumatized, because it's a contractile type of a sinus. And as I come into the posterior ethmoids and then the sphenoid, as I keep telling, once the W changes to a gentle U and you start seeing the superior turbinates and the orbits becoming smaller, the maxillary sinus is becoming oval, and the ground lamella turning and going laterally and attaching itself, this cut clearly indicates that we have come to the posterior ethmoid. As you pass from there and go back and back, this cut, you can see the upper border of the choana being well defined. The septum is bifurcating like a bird's wing into two arms. So these two cells clearly are the sphenoid. Here I can see a thin bony partition plus a bulge. So this could be maybe a mucosal polyp, but we will see that once we enter the sphenoid. You can see here there is no development or pneumatization of the lateral recess again. See the closeness of the Vidian canal and the impression of the trigeminal nerve or the V2. And posteriorly, anteriorly the two sinuses roughly look equal in the beginning. As we go posteriorly, the intersinus septum is going towards the right, and invariably the oblique sinus septums attach themselves to the carotid. So you can see this, that the right sphenoid is smaller, left is bigger, right?
Yes, sir.
So overall, if I have to summarize, the lamina papricia is intact. The anterior ethmoid artery is running along the skull base. There are no frontal sinus on the right side. I'm not going to go looking for it. Left, I will try to look for it. If I get a bit of an opening, I would consider myself lucky. Otherwise, I would like to open the anterior ethmoids, the posterior ethmoid, sphenoid, and obviously the maxillary sinus. Okay, madam?
Yes, sir.
Any comments? Any comments?
Wonderful explanation, sir. So
No, no. The voice, why is it metallic color? Kannadka kodtiya?
Dr. Hitam Roy, sir, you want to
Hello, sir.
Sir, can you hear us?
Yeah, hello.
Yes, sir.
Sir, how you prepare this case for surgery? What is your protocol of preparation?
1 minute, 1 minute. It's, your voice are not heard properly. Yeah, yeah. Just 1 minute. We are not hearing your voice properly. So
Sir,
waiting for that. Scan off, please.
So, our panelist, Dr. Ritam Roy, want to know what is the protocol for preparation for this patient? And
For this patient, just last week we started him on antibiotic, not injectable, oral antibiotic. I think we took a culture, it showed sensitivity to linezolid, I think. So I think we have given that and a bit of steroid. 1 week of deflazacort tablets. 30 mg OD for 4 days. 15 mg OD for next 4 days. Debrider beta. The other 2 blades are also ready.
8 days steroids, sir.
Okay.
Sir, will you plan
Yeah.
septoplasty here? Or either any you are planning for that?
Yeah.
Sir, how you decide?
I think they're getting your audio ready for us because I'm not able to hear you properly.
Sir, for your septal defect, whether you will plan for anything or after after that.
Shall we start?
Okay, sir. Technical team, please help.
Kusum, just bear with me. I'm unable to hear you people still.
Sure, sir.
What's happened?
Technical team with the OT, please help, sir, with the audio, please.
Okay. Just give me about 5 minutes. They are getting your audio okay.
Sure,
we are
sir.
not able to hear you people clearly. It is coming in a kind of metallic voice, you know.
Sure, sir. Sure.
Yeah. We can just about make out with what you said, sure, but it's not a...
So by the time the audio is getting corrected, can you please explain the steps what you are doing, because there are thousands of
Yeah. See, right now, my idea is to keep the debrider facing the polyp more than anything, because I don't want... So I'm just pulling out the polyp like that from the area under the inferior turbinate and taking it out.
Okay, so the blade should be under, vision. The direction of the blade should be under vision.
Dinesh Palak phone ಮಾಡು. ಏನಂತೆ ಇಲ್ಲಿ ಆ ಕಡೆ ಸರಿ ಇಲ್ವಾ ಅಲ್ಲಿ ಮೈಕಾ No, but they got to get it right now. I need to hear the moderators.
Hello, sir.
Hello, sir. Are you able to hear?
Can you hear us, sir, now? Deepak, sir, can you hear us? Can you please explain?
So basically trying to remove the polyp.
Sir, are you able to hear?
Without trying to traumatize the normal mucosa as much as possible. Suction.
Hello.
Dr. Kusum.
Yeah, sir.
Yeah, so far so good. I just about removed a bit of the polyp there. I'll take this for biopsy. No, gauze piece में लेना बेटा.
We are able to hear you. You getting our voice? Right, sir.
Irrigation tago Naveen.
I think the audio is...
Saline?
You can explain side by side, at least the virtual audience can hear you.
Hello, sir. Can you hear us, sir?
Debrider?
It is okay. You can, the online audience can hear you. Deepak sir, can you hear us?
Something you should do audio visual. See, the Kusum madam's voice I am unable to hear.
Sir, your voice is absolutely clear here.
TV volume ಕಡಿಮೆ ಮಾಡಿದಾರೆ ಎಲ್ಲೇನಾದ್ರು?
Technical team from the OP, can you please check the audio?
ಏನಂತೆ? ಹೌದಾ? But we are unable to hear them, no? Suction? Kudma, sorry. Sponge? Suction? So Kusum madam just giving a first line of irrigation. Just with regular saline, you can irrigate with ringer lactate or with warm saline. That also you can do. We use a normal regular saline to irrigate. Sponge. Sponge again. One more.
So we can hear you. Can you hear
Yeah.
us?
Yeah, you can speak. We'll try to figure out whatever we can. You're getting a good picture.
Yes, sir, we can see very clearly.
We can hear you a little better now. Go ahead and speak. No problem. We both were supposed to. Yeah.
Explain the steps, please, again, because there are...
Now we are hearing you better. Now we are hearing you far better. Hello? Ate hoytala. Debrider? ಈಗ ಸ್ವಲ್ಪ ಕ್ಲಿಯರ್ ಆಗಿತ್ತಲ್ವಾ?
Hello, sir. Can you hear us?
Yeah, now we can hear a little bit.
Sir, are you going to address the septum on the left side?
Am I going to?
High deviation in the septum. Are you going to correct it, sir?
Septum, 100%. I am my colleague, Dr. Naveen. He has been with me now for how many years, Naveen? We have been working together for the last 10 years. One of the most amazing surgeons I have seen. And his endoscopic septoplasty, in fact, he converted me into endoscopic septoplasty. I would, despite using the, endoscope, I was doing septoplasty with headlight only. And once he joined our team, that was 10 years back, we converted to endoscopic septoplasty. I feel in this case, on the right side, it would be worthwhile doing on the left side, sorry, Naveen is correcting me, he is right. To my right, but the actual left, doing a septoplasty would be worth it.
Okay, sir.
Straight grasper.
We will do it later on, sir.
We will do it. Generally, the dictum is septum on the roomier, fess on the roomier side. Then you do the septum. Then fess on the narrow side. Isn't it? That's what we learned from from our Guru P.J. Varmal. So, right now, just debriding the polyp.
So that we'll get the enough space.
So, as I keep harping, the most important thing is to stick to the polyp and debride the polyp well. I try not to injure the turbinate and normal healthy mucosa as much as possible. See here, I did touch the turbinate a little bit because I had to. Those are the polyps in the sphenoethmoidal recess. I've debrided it a little bit. The whole idea is to first get an idea of the anatomy. Probably this looks like the middle turbinate. This one, little medial to my debrider. But uh, 40-degree blade sponge de do beta. Yadamma?
Hello, sir.
What I am.
Before starting the case, you injected in the lateral wall of the nasal cavity. So, what is the advantage?
See, wait. I just injected a little to the polyps. I injected the axilla of the turbinate here, where the anterethmoidal artery twigs do come in. And if you inject a little bit here, the sphenopalatine part is taken care of. If you go posteriorly, inject here, the main sphenopalatine trunk where I'm touching now, that is also taken care of.
Okay, sir.
Yeah. The whole idea is to basically, make the vessels narrow. But now, of course, this almost is an obsolete concept because a lot of people are now just painting the whole thing with undiluted adrenaline. Sponge? 40-degree blade dalna beta. One more sponge.
Are you using any special needle while injecting or any regular?
26 1.5 inch. Some people, my guru again, Dharambir Sethi sir uses a dental syringe. I use a regular syringe with a 26 1.5 inch needle. Sponge.
So there is one question from the audience.
Yeah.
Dr. M. Shruti from Hyderabad.
Yes.
Wants to know what is the significance of the dictum, sir? Why not the septum first followed by the face?
Yes. Oh, what is the significance of the dictum, is it? Nothing much. The roomier side, it's easier to do first. You can pack that. Then once you do the septum, the other side becomes roomy because you remember in this case, it's the left frontal which is small, the small interfrontal cell. If you have to look at the frontal recess comfortably and instrument, better to correct the high deviation. Though me and Naveen were having, a debate because this deviation is kind of moderate, but I think it is better, isn't it?
Better to do.
First septum and then first on both the sides you can do.
No, that also you can do, but only thing is the way I am looking at Kusum madam is, see now this mucopedichondrium is nicely attached to the septum.
Yes.
If I do a septum, this becomes boggy and your debrider can catch the mucosa at times.
Okay.
You agree with me?
Yeah.
Kusum madam? Oh, again we lost her. Okay. Straight grasper? Ade, Papa. Okay. 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 Picture ಚೆನ್ನಾಗಿದೆ ಅಲ್ಲ ಅಲ್ಲೂ? Okay. Ball probe, Kusum madam? Ball probe?
Yes, sir. We are changing the mic.
Okay. Aram se. Well, this seems to be the bulla, maybe, which is destroyed partly by the polyps. This is the mobile structure in the lateral wall, and this should be the uncinate. So what I'll do is, probably I'll go here, somewhat this way, open it up. Yeah, that could be my maxillary sinus. And this is a bit of polypoid mucosa there. Debrider.
Wonderful demonstration, Dr. Deepak.
Who is it? That side?
Janakiram is watching.
Uh-huh.
Janakiram from Trichy.
Oh, boss.
Great demonstration.
Why do you make me?
Beautiful.
So I get my first landmark now among the sinuses, the maxillary, and just right now trying to take away the polypoidal mucosa. There seems to be a bit of uncinate here. Let me see. Suction. See, for the postgraduates, I would like to tell them, when you are doing FES, sometimes revision FES, if you can really locate the upper border of the choana properly, using that as a single standalone landmark, you can open up all the sinuses. That's one of the most stable landmarks you can get. Sponge.
So you are using 0 degree endoscope right now?
I do 90% of my FES with 0 degree.
Okay.
Because the anatomy distortion is less. See, the biggest advantage I've had in the last 10 years, whichever course I'm demonstrating, either Satish is showing or Janki is showing, or both of them are showing. So I don't need to address the high intensity surgeries, and I stick to basics like a DCR or endoscopic surgery, and I want to show it as simple as you can do. Because not all of us are talented. Ball probe. So this is the uncinate again.
Yes.
Remember, you can see this here. So when you are moving your probe or a J curette, stay parallel to the frontal process of the maxilla. Because here you don't want to reach go to the lamina papricia. And remember, this side, there is no frontal. Okay?
Yes, sir.
So don't try looking for a non-existent frontal and create a CSF leak. Debrider. So again, now I am removing the mucosa over the uncinate here. So probably this could be the recessus terminalis, isn't it? Majority of the time, the frontal recess and the drainage pathway would be medial to this uncinate. So this could be our agar nasi, and the peak of the agar nasi would be the recessus terminalis, where the uncinate attaches itself to the lateral wall. So I won't go very deep or very high here, because there's nothing to go there, really. So now, this uncinate, we will take it out. As Janki keeps saying, in FES nowadays, the straight Blakeslee is more of a scavenging forceps. Chota wala do beta, itna bada wala kyun rakhe ho beta? Ball probe. Janaki?
Yes, sir. Yes, sir. I'm watching you. Fantastic.
No, I'm really grateful to you for accommodating me for today on request. Because hello?
Yes, sir.
Can you hear me?
Yeah. Very well.
In fact, your mic is fantastic. Kusum madam and all, I don't know, they're not. No, their audio is Papa. Because she called me 2 days earlier. She said she wants to be there for the demonstration. I can hear kind of, but somehow and the sound muffled our.
Oh. Dinesh, can you do something about it?
No, they're doing.
Yes, sir. I'm doing something, sir. Wait.
They are doing. They're doing something.
Hello, Dr. Janki.
Now she's audible. Yeah.
Now you're better.
Janki.
Yes, sir.
Nee vanda ella perukku voice vandidu. Sponge, that's the entry wall of the bulla. Yeah, sponge. The felicitation and all is at 7 o'clock, I think, isn't it?
Yes, sir. Around that time.
Yeah. So my time is there till 6:30 anyways.
You take your time, sir.
Yes. You are in Trichy or in Bombay, Janki?
I'm in Trichy.
Okay.
I'm watching you from Trichy.
Okay, not from Sharjah. Next month, 19, 20, 21st, I think you are there, isn't it?
Yes, sir. 18, 19, 20, 21. 4 days.
Yes.
Brilliant field, sir. Superb field. We should actually thank the anesthetist. Anesthetist ko thoda.
Yeah.
You have to give a big hand of applause.
Yeah. 45 degree forceps. Ye dena 45 degree dena beta. And when is the Chennai center opening?
21st, sir. 21st.
Janki, that's the rudimentary frontal there.
Yeah. Very nicely seen.
The frontal recess.
Beautiful.
This is the recessus terminalis.
Yeah.
The left side or the remnant agar nasi.
Very nice.
Frontal. Yeah. Debrider. Ball probe or J curate. Any one of them you can give me. Yes, giraffe for 45 degrees. Anything you can
Fantastic field. Fantastic field.
Yes, boss. Yeah. Debrider. Janki.
Yes, sir.
Apart from you who shows that fantastic septoplasty with your special knife, we have Dr. Naveen here. Who is so good, you know.
Okay. Dr. Naveen.
Naveen Krishnamurthy.
Oh, wow.
He was with Kirtane sir for about 1 year. He was with Satish Jain boss for 1 year.
Wow.
Then he said it's not, enough if he works with only excellent people. But the medium people also he should work, and he came and joined me.
No. You are humble. No, sir.
No.
The three dons now. Now he's working with the three dons.
See, this is okay, na, Janki, for a small
Fantastic, sir. I think that's beautiful.
Yeah.
Hello.
Yeah.
Sir, for exploration of frontal recess, which
is better, sir, 0 degree or 70 degree?
See, ball probe. If you are using PJ Vermault's technique of creating an axillary flap like this and flap this and take away this bites of bone, then you can work with a 0 degree.
Okay.
Otherwise, it is 70 degree.
Okay, thank you, sir.
Only if you are doing the axillary flap technique and take away this triangular piece of bone, you can work with 0 degree. Okay?
Okay, sir.
Otherwise, see, now I am working with 70. I do limited work with 70, but see, the anterior wall of the bulla becomes the posterior boundary of the frontal recess. Okay. Ball probe. See, this is the frontal beak, which I am palpating. This is the anterior wall of the bulla.
Okay.
This is the medial aspect of the middle turbinate. Below here, if you go too close, you can enter the lateral lamella here.
Okay.
You can see the cribriform plate, cribriform area there superiorly.
Yes, sir.
And this is, of course, the remnant uncinate attaching itself to the lamina papricia. So beyond this would be the orbit. Straight Blakeslee. Kusum madam?
Yeah, I'm here, sir.
Now you are clearly audible. Clearly.
Oh, great.
And really thanks, day before yesterday you messaged me and then you said you would like to come on and be a part of this. And then again you called me yesterday when the timings got changed. I thought, you may find it inconvenient because Dr. Sanjay Agarwal keeps telling me you have a huge practice.
Oh.
In
his greatness actually.
No, but see, this is the maxillary. I've just opened it a little bit because it doesn't seem to be that involved as of now. But let me see. Debrider, ball probe.
So there are a couple of questions from the
please go ahead. Please go ahead.
Dr. Ruchir from Pune wants to understand: do you trace uncinate from the superior border or border of the inferior turbinate, or you palpate by using the ball probe?
Wherever the free border of the uncinate is clearly visible, I would like to go into the ethmoidal infundibulum, palpate with a ball probe, and then use a Nagashima backbiter. In cases like this, extensive polyposis whose anatomy is destroyed, I would like to hug the frontal process of maxilla, come back and look for the most mobile part in the lateral wall, and use a soft entry using the ball probe. Anyway, we have given up the sickle knife technique long back.
Yes, sir.
Right?
Sure. Thank you, sir.
Yeah. What is the other question? You said couple.
Yeah, and Dr. Ruchir also wants to know what instrument you will use to remove the uncinate.
Basically, you dissect the bone free. If it is, then, take it away with Blakeslee, or you can do a submucosal dissection with the ball probe as Professor Dharamveer Sethi taught us. We can do that as well. Sickle knife is out. And another wonderful instrument to take away the middle and the upper part of the uncinate is the J curate. 0 degree.
Sure. Thank you, sir.
Ultimately, loosen the bony fragment, don't pull. Loosen the bony fragment and then take it away with the Blakeslee 0 or 45, which act like a scavenging forceps. I am back to 0 degree now.
Okay,
because
sir.
I am going to open up the bulla and then go towards the posterior ethmoid and then finally the sphenoid. Right?
Yes.
We have 2 sinuses open. We have 2 more to go. Straight grasper. And I must thank my anesthetist for giving me a clean field, no? I think you appreciate that the field is very clean.
Yes, very well. Field is really good.
Yes. So maybe, this bony fragment, better to give it a twist and take it out. That could be the sphenopalatine artery area, deep here, little behind. So injecting there, when you're doing under local, as Dr. Ahila Swami does, that should also give you a good feel. Sponge, please. Saline, I'll irrigate once.
Sir,
Yes.
sir, what should be the adequate size of the maxillary enterostomy size?
See, in this case, if the polyps are not too many and you are not seeing signs of AFRS, allergic fungal sinusitis, the enterostomy which I have done should be quite okay.
Okay.
Wherever you find allergic fungal rhinosinusitis, if you're doing it for cystic fibrosis, it needs to be really, really wide. No?
Okay.
Yeah. Data section. Another maybe 20 minutes I should be done on this side. Then Dr. Naveen will show us the septum as well as a portion of the fess, probably the frontal area. I will again show you. Block हुआ बेटा. Sponge देना अभी. So now we'll go for the bulla. One more sponge. Ball probe. Now again, you can either enter the bulla by using the blunt end of the debrider inferiorly and medially at this point. I'm trying to see whether I can go back and break the whole thing forward, which I again learned from Alexander Philippou, Janki's favorite surgeon. So the whole bulla wall came off, 45-degree forceps. And if you're using manual forceps like this, give it a twist. That way you always get a clean cut. Isn't it, Kusum, madam?
Yes, sir.
During surgery, if anybody inadvertently damages the lamina papyracea, what to do, sir?
Just pack that area and work around it. Don't try to push the fat behind.
Okay.
Don't try to do anything. If you are not sure, abandon the case and take it up after a few days. Lamina papyracea breaching, no? He said. Dehiscent. If the lamina papyracea is only the bone is dehiscent and you can see the periorbita very cleanly, you still proceed. Only thing is be careful. Don't allow the debrider to face, the mouth of the debrider to face laterally.
Okay.
45-degree forceps. So the moment we open the bulla, yeah, we were looking at the ground lamella. Before that, let us remove the entire part of the bulla, whatever we can. Ball probe. So let me see these, these are the partitions which will come out now. Debrider. Yeah. Maybe even this bit we will debride and take it away. 45-degree forceps.
Then in this area, should I take any extra care for anterior artery?
Yeah, if you know your anterior wall of the bulla, see, you can see the anterior wall of the bulla there, which forms the posterior part of the frontal recess. Invariably, your anterior ethmoid artery is one cell behind. The posterior border of the supraorbital cell is the one which will protect you. This bulla's anterior wall will protect you from the anterior ethmoid artery. The anterior ethmoid artery would be somewhere where now I am taking away it is much posterior. Okay?
Yes.
And in this case, it is stuck to the skull base. So we need to worry a little less. So we have opened up the ethmoidomaxillary area, and this bone, you take it out. The scavenging technique is also an Indian technique, because using Blakeslee and removing the bone 45 degrees better will save your debrider blade for many more cases. Isn't it?
Yes, yes.
Okay.
Places like Singapore, where you use one blade for each case, you can go ahead and do everything with the shaver or the debrider. Debrider. Probably what we are looking at here now, where I am working, is a supraorbital cell area, also the middle fovea, isn't it? Bone punch. That is the anterior wall of bulla. Your frontal recess becomes really, really wide when you connect the supraorbital cell with the frontal sinus outflow pathway. What 45-degree forceps?
Sir, Dr. Nikhil from Jaipur would like to understand what caution should be kept in mind while opening the hypoplastic maxillary sinus.
I'll explain that to you now itself. That's a very important question, I think. It's a very relevant question because everybody thinks, maxillary is the simplest sinus. You get the maximum problems with that itself. In fact, to operate well on a pneumatized maxillary sinus, reaching every nook and corner is far more difficult. People do get worried about the sphenoid, but actually speaking, the difficult sinus is the maxillary. Yeah, here we need to be again careful. This would be the lateral lamella area. But you can see how the frontal outlet is opening up. 45-degree forceps. The anterethmoid would come somewhere there. Sponge. You will agree that our anesthetists have given us a very good field.
Yes, field is good.
Yeah, we should thank Dr. Kavana. Sponge. One more sponge there, beta. Yeah. One more. And look at the middle turbinate all along. Very stable, undisturbed. Now anyway, I'm keeping the pack here, giving a little irrigation. The question was about a small contractile maxillary sinus, sometimes a silent sinus syndrome as well. Isn't it?
Yes.
So the first thing is ball probe, please. The safest landmark to enter the maxillary sinus, hug the upper border of the inferior turbinate. Number two, even in the most narrow sinuses, the posterior fontanella would be always a little open.
Yes.
So in difficult narrow maxillary sinus, come from posterior to anterior. As Naveen is doing a pantomime here, keep the direction of your probe downwards like this at the angle of 45 degrees. Don't keep it this way. Look, I'm hitting the orbit here. Keep it downwards. Okay? So these are the 3 tricks. Hug the upper border of the inferior turbinate.
Yes.
Try to palpate posteriorly.
Yeah.
This way your NLD is also safe. You go posterior, make an entry, come anterior. Always keep your probe or 40-degree debrider blade turned downwards. Okay?
Yes.
जिंदगी में नीचे झुकोगे तो आगे रहोगे. Yes. Suction.
One question, sir.
Yeah, why not?
Do you combine Caldwell-Luck approach with phase for extensive maxillary sinus disease?
For extensive maxillary sinus disease, usually you can do endoscopic medial maxillectomy also. You can go, this lacrimal approach you can do now, which is a new approach. You can go through the canine fossa approach with the trocar, as Satish Jain showed us very clearly.
Mm-hmm.
And in rare cases, when you're working on extensive mucormycosis, huge inverted papillomas, and sometimes angiofibromas, if you're not as good at handling like Dr. Janaki and Satish, there's no harm in going through the Caldwell-Luck approach also. It's a wonderful approach. Sometimes in recurrent antroconal polyps which keep on recurring, I've found it's a lot easier to open that way. Can you see the frontal recess here now?
Yes.
70 degree. I will show you. Nicely mucosalized. We'll now go into the posterior ethmoids in a minute. And then the sphenoid. As far as the scans that we see now, there is no Onodi cell. See, Dr. Kusum.
Yes, sir.
How the whole frontal pathway gets widened
Yes.
once you connect the supraorbital cell. Ball probe, and invariably you will find the anterior ethmoid artery running along this posterior border, making an angle of 45 degrees. For me, this would be the anterior ethmoid artery location. Right?
Okay.
I don't want to dig deep into it, look for it, search, dig and make it bleed. Okay?
Yes.
Yeah. Kusum, do you agree?
Yes.
Or you feel the location is somewhere else? No?
I think it's
Yeah.
okay.
Yes. Now I'll go back to 0 and open up the
So
posterior.
can you give a good wash? So the
Yeah, why not? It's almost like Sanjay Agarwal is speaking through Kusum's voice. He always, when he meets me, he tells me, that Deepak bhai wash de do, beech mein aap wash nahi dete, acha dikhna chahiye. He's, keeps telling me that. And good, you told me his point. Suction. Looks reasonably good.
field is
Go for the posterior ethmoid without wasting much time. 0 degree. Again, the moment I need to go to the posterior ethmoid and sphenoid, I go back to 0.
okay.
I can open it with 70, but I still feel for 90% of the surgeons doing this surgery, 90% of the times, working with 0 would be the best. Because there's no distortion in the anatomical landmarks. Yeah, straight blade dena beta. Yes. Now, ball probe. Another favorite landmark of mine is the maxillary line.
That is the better.
See, this is the maxillary sinus.
Yes.
You can clearly see the junction of the roof and the medial wall.
Medial wall. Yes.
So you mark this point and mark this point, draw a horizontal line, open the posterior ethmoid and sphenoid in this point only or a little below. You'll always be safe.
Yes, sir.
You will not hit the skull base. Debrider. Yeah, Kusum madam, probably we have entered the posterior ethmoid. The moment we enter the posterior ethmoid, I feel we need to stay medial here. Don't get tempted to go laterally. Okay?
Yes, sir.
See, stay close to the septum. You know, in this line only, the maxillary line, a little below.
And in this stage, inadvertently, if anybody injures the orbital periosteum and medial rectus, so what to do, sir?
1 minute. Can you see that sinus there?
Yeah.
Yes, yes.
Sphenoids.
Obviously, that's the sphenoid. Okay?
Yes, sir.
So, now that I've seen the sphenoid, I can open the posterior ethmoid a little more confidently now.
Sir, hello,
Yes.
sir. If
Yes.
anybody injures orbital periosteum and medial rectus,
Orbital periosteum is okay. If you injure the medial rectus,
what to do,
then
sir?
you'll have to involve the oculoplastic surgeon.
Okay.
Because that is surely a disaster. Huh? Okay.
Okay, sir.
So I think they say, I think the oculoplastic surgeons, they do the work on that. It is not in our domain to do anything. Injure the orbital periosteum, that's okay. As me and Naveen mentioned, that is not a big problem. Debrider, 40-degree blade, or give me the straight blade first. Yes.
You can give a wash so that the field will be clear and you.
Yeah. 1 minute, 1 minute. I'll give a wash. I just thought I'll just open the posterior ethmoid a little bit. Can you see the glue there?
Yes, yes.
No, this is an AFRS. Early.
The fungal debris, no?
Yeah. Yeah. The sphenoid is more clearer. Yes. Sponge, yeah. Yeah, wash. And then give the sponge. So the best way is, doctor, keep looking for the orbital fat. The moment you have the slightest doubt, stop using the
Debrider.
yeah, and also look for the Stankiewicz sign, you know, where you palpate the eye. I'm palpating the eye.
Yes.
If you don't see any sign there, that should be good enough. Yeah. So, 3 structures, if you damage during FES, you are going to be in deep trouble. They're all located in the lateral wall, the carotid artery, the optic nerve, and the medial rectus. Right? And medial rectus, once you damage, I really doubt whether you can do anything much about it. Kusum madam, you have any idea what the oculoplastic surgeons do? Hello?
Hello? Yes, sir.
You have any idea what is to be done for medial rectus damage?
No, sir.
Because Satish once told me, you know, symmetrically weakening the opposite lateral rectus, but I don't know how accurately they can do. Sponge.
So there is one question from the audience.
Yes.
Can you please explain different approaches to sphenoid and which one you prefer?
Yeah. See, there are only 3 approaches to the sphenoid. One is where you go through the posterior ethmoid, posteriorly, which I think no longer anybody practices. The two commonest approaches are one which I showed you now, the intermediate approach, where you stay near the maxillary line, open the ground lamella, get into the posterior ethmoid, and then as Janki describes the toddler's walk, you just keep on debriding in a half C shape in that area like this, keep on swinging the Jula technique.
Yes, yes.
Keep on swinging here, go like that,
You will be in the
and go between the superior turbinate and the middle turbinate
yes.
and open up the sphenoid. That would be one of the safe techniques. The other safe technique is if your middle turbinate is already flappy due to the polyp.
Yes, sir.
Straight grasper. If your middle turbinate is already flappy due to the polyp, then you go medial here. SMR elevator, maybe you can give me that. I don't want to use a suction here. Yeah, just gently move the middle turbinate, go close to the septum, 1.25 centimeters above the posterior border of coina, remove these polyps, and you are there. Right?
Sir, Kirtane sir is with us.
Yes. Kirtane sir is there?
Yes, very much. Watching your beautiful surgery.
Sir, 1996 course in Hinduja.
What happened?
No, nothing. You gave me a J curate because I was the first one in the hall.
Oh, that way.
I showed that J curate to Naveen. I told him this J curate is sentimental. I have it with me even now.
Okay.
You would give a prize every session, no?
Yes,
for
people who are punctual.
With my academic abilities at that point of time, that's the only way I could have won a prize. So me and Satyaprakash Dubey were there. My name was called out. I got a J curate.
The thing that you said about that 1.25 centimeters
divider
above the corner.
Yes.
Just yesterday I was doing a case.
Yes.
Where the right sphenoid sinus was extending right across the midline.
Yes.
Completely blocking the left side, and the left sphenoid was about the size of my fingernail or smaller than that, very shallow.
Okay.
So you have to see that clearly before you do that, because if you then try to enter a very small sphenoid in that 1.25, you might actually land up.
Yes.
So I think the best way is what you're showing now.
Yes.
Identify the superior turbinate.
Yes.
Lower half.
Yes.
And identify the ostium. If you can identify the ostium, then you are totally self and assured that you're not going to go wrong. Yeah.
Yes, sir.
There. And very often that ostium is slit-like, so it's if you take your elevator, periosteum elevator, you're able to enter it there. Yeah.
And again, for the beginners, the cell in which the floor you cannot appreciate is going to be your sphenoid, and the cell in which you can see the floor very clearly is going to be the posterior ethmoid. Yeah. Yes. Naveen, come along. Sir, your other disciple, Naveen, is going to show us a fantastic endoscopic septoplasty, sir.
Okay.
Then we see the other side. Naveen was with sir for 1 year, and he is a gift to me from sir. Sponge.
Well, he is fortunate to be able to work with you.
Sir, no. It's the other way. Naveen, come in. Mike, beta mic shift karna Naveen ko. Sir, abhi hall mein hai. This is best moment. The biggest moment in his life as well. I can understand. Because last time I got sir for about 5-10 minutes in Hyderabad, that case was such a bloody mess. I felt very bad that sir was moderate. I mean, on the other side, and the whole field was oozing. But
Yeah, but that happens to all of us sometimes.
yes, sir.
To all of us.
Like,
and at that
sir, Naveen
your
is
patience
now-
is tested. You have to be very patient.
Yes.
Proceed slowly. Do one little bit on one side. Go to the other side. Pack one side. Go to the other side.
Yes.
Hi Naveen, how are you?
Sir, Naveen, we are just putting the mic now for him. Just a moment. Yeah.
Hello, sir. Good evening.
Good evening, Naveen. How are you?
Fine, sir. Thank you. How are you, sir?
I'm doing all right. Waiting for you to do your septoplasty. I want to see.
So it's my honor, and my hands are trembling.
I'm just going out for some time. Go ahead.
So I was fortunate to have worked with you, Dr. Satish Jain, and now I'm fortunate that I'm with Deepak sir, infiltration. So
both of you are matching in temperament. Both are very quiet fellows.
And sir,
soft spoken and quiet.
Hello.
Yeah.
Sir, can you hear me, sir?
Yeah.
If you go out of the hall now, another coconut may fall on your Mercedes-Benz glass.
Oh, you still remember that?
Yes, I remember. At this time, it was not a coconut. This mango season, I lost one glass because of a mango falling on my car.
Oh, my God.
So this is the third time my windshield has been smashed.
Oh.
And the other time, a small tiger had trespassed into his farmhouse.
So, going ahead, here we are doing a septoplasty basically for the approach because of the high DNS to continue with the FES on the left side. So here, while infiltrating, I would prefer to infiltrate from posterior to anterior and inferior and then superiorly, basically because to prevent any bloody field. So if you infiltrate inferior and then infiltrate superiorly, you can avoid a bloody field on the surface. Again, anteriorly we come little later for the same reason. And
what are you using to infiltrate?
So we are using a 26 gauge 1.5 inch needle, sir.
No, the solution.
2% with adrenaline, sir.
The patient is under general anesthesia, so you could also use saline adrenaline.
Yeah, saline as well. Yes, sir. Infiltration sponge. Sponge.
On the local.
So rather than calling a septoplasty, probably it would be ideal to call this a septal correction. So as we see here, probably the maxillary crest is not causing much of a problem here. Infiltration.
Yeah, it's mainly a high deviation to
To the left side. Yes, sir. Sponge. Inside packing forceps. So the amount of correction here is basically the bony correction what is required.
Yes, yes.
And sponge. Chota, small, you put very small. Okay. Okay. So now the incision as well, either just get me the Cotles elevator. So based on the kind of deviation we are addressing, if we have a very anterior deviation and the maxillary crest is causing a lot of issues for us, I prefer to put the incision on the skin itself so that we can address quite anterior issues here with the maxillary crest.
Okay.
But here, since the problem is basically with the high deviation, I would prefer to put the incision a little posteriorly, just around the mucocutaneous junction. 15 blade. And to number 2 section. Once I put the incision on the mucosa, the first thing for us is to get into the plane. So I use a number 2 suction, and gently with the suction, we just dissect out putting the pressure a little on the cartilage. So here we see we can appreciate the cartilage. So the perichondrium just gets elevated. Bottles. And this is a wonderful instrument, Cotles elevator. Unlike our Prier's elevator or SMR, this has got a gentle curve and a slightly pointed end, which you see here.
Sir, in this step, suction prayers or this cordless, which one should be the better instrument?
Sir, sorry?
Step. Suction prayers.
Suction elevator, sir.
Suction elevator.
Yeah, we can use a suction elevator as well for the suction elevator. But again, for me, so once we are in the plane, so either we can use a suction elevator but compared to a suction elevator, if there is a lot of bleeding, I definitely use. But here we are able to manage. So the Cotles elevator gives that fine dissection for us. So now I'm along the maxillary crest. So this fine dissection for this cartilage elevator is one of the best instruments. So this is the high deviation. Let me 15 blade. I'll just extend the incision. The more higher the incision we have taken here, it's easier to address the high deviation. (15 blade). And again, incision on the cartilage, see, based on the kind of deviation we are addressing. So here we can preserve much more cartilage. So even if you are able to preserve about 1 centimeter of the dorsal and the caudal strut, it's enough to stabilize the septum. So in this case, because there's not much of a anterior deviation, so we can preserve much more cartilage. 15 blade. So I would enter the opposite side. Making a small window in the cartilage, and making sure that I will not put a through and through incision on the cartilage. Just halfway through with the 15 blade, and I use my cartilage elevator to deepen the incision on the cartilage. So now I enter the opposite side. So here we see the mucoperichondrium and the flap getting elevated on the opposite side. So as I said, go higher up so that the dissection is much easier. Either you can use the suction elevator or you can use the cartilage elevator.
So if you are in a right plane, field is remains very clear, and you know you can see it's no bleeding at all.
No bleeding, yes, absolutely.
Field is absolutely clear. So Kirtane sir correctly said no, that you can use the saline here also just for the hydrodissection.
Yes,
right, sir?
yes, right, yes, yes, madam. I totally agree with that. Right. Sir. So now, just make a small here. I make a cut in the cartilage. Quarters. And with the Cottle's elevator, I am opening up the bony cartilaginous junction.
Separating the bony part with the cartilaginous part.
Yes, madam. Quarters. So now, if we have there is a small spur on the right side. So with this, we can just address that as well. So this is the spur which we see here.
Yeah.
Sir, I have one question. Sir, as we know that septoplasty is a conservative surgery, and here we are removing bone cartilage. So is it really a septoplasty or endoscopic SMR?
Sir, as I told earlier, rather than calling it as a septoplasty,
Septal correction.
septal correction.
Yeah, because when septoplasty concept came in, and they said that you remove only the bone and the cartilage has to be scored on the concave side. So it didn't work out always. So very often what I would do is, if I had a bad cartilage, I would take it out, remove whatever bone I wanted to, and then put this cartilage,
replace it back.
Replace the cartilage.
See, sir.
So that you have support. It prevents the two flaps from sticking together. What happens is, although you've left the dorsal strut intact, when the flaps stick together and contraction occurs, it pulls on the cartilage, so you tend to get a supratip deformity.
Yeah.
So if you interpose that cartilage in between, it prevents that contraction of the two flaps. So I think that is good enough. So it's sometimes that old concept of septoplasty didn't give us very good results, because we still had patients with cartilages bending and not being happy with the result. So most of us now resort to this: take it out and put it back as required.
Yes, sir.
So, we are using most of the times endoscopic septoplasty. So is it?
Sorry?
We are mostly calling it endoscopic septoplasty. So,
yeah, terminology, it's like when we call something a stapedectomy, is it stapedectomy or stapedotomy?
Stapedotomy. Yes, yes.
But people just use the general term stapedectomy, although they are just doing a small hole fenestra, which should ideally be called a stapedotomy. So I think the terminology, basically, you want to make sure that you give the patient the kind of septum that he requires to breathe normally. And to prevent too much of contracture, reposit the septum.
Reposit the cartilage back. Yes, sir.
Thank you, sir.
As sir said, on table we feel we have got a good septum after scoring, but over a period of time, again, we see the deviation is still persistent. So here again, going by the conservative way which we are speaking about, so just remove as much bone as required. So here we are able to see the axilla and even the cribriform area now. So just probably this small part of
part of that upper part of the
yes, sir.
Posterior end of that strut and
yes, sir.
bony portion there.
Yeah. So this part, if we just address it, Cottrus. Caesar.
So there is a question from Dr. Ruchir from Pune. I wanted to understand, before septoplasty under LA, not this case, but how much time ideally should we do nasal packing with ribbon gauze?
How much? Sorry, sir, I didn't get your point. How much time?
How much time ideally should we do nasal packing with ribbon gauze?
So that just gives us surface anesthesia when you are doing a local, under local. ultimately infiltration is the one which matters. The surface anesthesia,
I think is more for decongestion so that
That's
you're
it.
able to infiltrate better.
better.
Sure. Thank you, sir.
So now, so I agree, sir? Kirtane, sir?
Yeah. The initial packing that you do is more for decongestion.
Decongestion. So here just the part of the spur posteriorly, just address that. So here again, I use this Cottel's elevator to scrape out part of the soft tissue over the maxillary crest. It gives us and now I use this to elevate the lower part of the flap on the right side. Sponge. A small piece of sponge, I just Mirocell, I just keep it here. Bottles. So this gives us a wonderful field. So compared to a headlight, endoscope gives us such a wonderful visualization for a septoplasty. So now, gouge hammer. I just gouge this out and Cottles. We place this small piece of sponge here, which acts as a cushion. Gouge, which can prevent a tear. Slow. Okay.
So you always prefer to use the gouge or just a normal chisel?
Gouge, sir. Yeah.
During this step, if anybody lands up into damaging the palate and palatal perforation, what to do next, sir?
So, sorry, I couldn't.
During removing this maxillary crest,
yeah.
If anybody land up into damaging the palatal
No, I think
and
that
the
would be
palatal
a
perforation,
very rough and adventurous surgeon who would go through the hard palate. Be difficult to do.
Very difficult, sir. Yeah.
You have defined the extent of the spur. You know the level of the floor of the nose. I don't think unless you really bang hard, you're going to go through the hard palate. It's very unusual.
And if the mucosa is still intact, probably it shouldn't cause much a fistula unless and until we have gone through the mucosa as well.
Just give a wash, make the field clear.
Yes, madam.
You'll be able to see it properly.
Sponge. So here, I just keep a Mirocell to give a little tamponade.
So there is a question from Dr. Minesh from Ahmedabad. What should be the minimum age of a patient to septoplasty? For the septoplasty.
So usually we try to wait till about at least around 14 years. But in case if the pediatric septoplasty also is not something which we don't do unless and until we have not addressed, if the child has adenoids or allergy, and you have addressed all of that, and still the patient has issues with breathing, probably he may require either a septoplasty or a septorhinoplasty in that situation. So even we have done septum or septorhinoplasty even at ages 9 years or even 10. But we would prefer to wait at least till 14 years, if possible.
Sure. Thank you, sir.
Wash. Keep ballpoint cautery ready.
Naveen,
Sir.
There's a question. In this case, would it be better to go for a regular septoplasty, dislocating the bony cartilaginous junction, scoring the cartilage in a spot, and correcting the high deviation by removing the bone? So, what has been your experience about scoring the cartilage?
Sir, on table it looks good, but again,
it's a little unpredictable.
Unpredictable, yes, sir. So we have seen that it's really unpredictable. And as you said, so we prefer to keep back the cartilage if required. At times, there can be a tear on the flap, identical tears. So we prefer to either in that way, or if we feel it's very flabby, I would prefer to keep back the cartilage. Where's the foot pedal? Foot pedal.
Hello, Naveen. Big Boss Janki is also watching.
Fantastic. I've been watching for a long time.
Sir, Janaki Ram, sir. Oh, sir. I am shivering again now.
Janki
No, I've been watching you for a long time. Very, very nice.
He's watching in rapt attention with a mic in his hand.
You have lovely hands.
So I've been watching you from quite a long time, and inspiration for all of us. Bottles?
Huge, huge. His energy levels are infectious. And ultimately, it's all from that Gulzar, lookalike sitting there in the hall, in the front row. The voice remains the same. The big boss from Hinduja.
So this is the posterior part of the spur.
Very nice.
This is like Janki septoplasty. No tear anywhere. Only
Lovely,
the
lovely.
life is missing. Yeah, very good, Naveen.
Lovely, lovely.
Yeah.
Thank you, sir.
So now you have good access to the middle meatus there.
Yes, sir. Switch. Get cartridge.
Another 20 minutes will be done, Janki. But a
Perfect.
big thanks for
And,
accommodating us.
At times,
No, sir. It's a pleasure. Always a pleasure.
at times when there's a very anterior deviation of the cartilage, once we put a release incision here, you can see part of the cartilage starts overriding. In this case, it is not as expected because we saw the deviation was basically posterior. So in that case, I would just take out a sliver of cartilage here so that it sits snugly here.
No, he's already finished one side, no?
Bunny. So I would like to suture. There are two schools of thought. Few people say no need of any suturing, no need of packing after septoplasty, but we prefer to suture and even place a pack. It's better the patient has nasal obstruction for a day rather than we having sleepless nights. with even
Yes,
small amount of.
We call it a hypnotic pack. Hypnotic because it gives you better sleep.
Yes, sir.
For how many days you will keep this suture?
Madam, it's a vehicle which is a dissolvable suture, so we don't
You need
remove
not
the
to remove.
sutures. Yes.
Sir, though you mentioned that there are different schools of thoughts for this suturing, but
No, I mean to say, few
because
people say
there's a
no need of
question, is
suturing.
suturing mandatory after septoplasty?
So that's what I said. So we prefer suturing.
Okay.
So there's nothing like mandatory. So we prefer suturing. And especially if there has been some tear in the mucosal flaps, it's better we suture and keep the pack.
Right, sir.
Actually, can I add a point here?
Yes, sir. Please, sir.
Actually, if there is no tear,
Then
absolutely no tear, then I wouldn't suture.
Okay, sir.
The reason is there can be a septal hematoma formation.
Right.
If there is a tear, some people create a tear, a small tear, wantonly after the surgery because they don't want blood to collect. And if
Yes,
you
sir.
suture it like this, no, sometimes what happens is there is collection of blood. If you pack also, it doesn't go.
Right, sir.
If I pack, then that through the suture line, it comes out, the blood comes out.
Yes, sir. Yes, sir.
Very nice,
Absolutely
very
taken,
nice.
sir. Thank you, sir. At times, as you said, I tend to make a deliberate cut
Yeah.
posteriorly here and inferior.
Exactly.
Yeah.
Thank you, sir.
Deepak sir is ready.
That was a very good.
Very well done, Dr. Naveen. Excellent demonstration. I am feeling bad now. The reason is, you see, morning Dr. Mohanji gave to his assistant, and then Vijendra sir made Dr. Vinay, and Dr. Kirtane sir made Dr. Sangeeta, and you are doing now. Only person who is not giving it to my assistant is me.
Tomorrow you have the whole day now.
No, but I
Make
am not
comments.
planning to give it to my assistant. That is the problem. I am the odd man now.
No, those cases how you can give. கொடுக்க முடியாது. Debrider, 40-degree blade. You can't give now.
Janki.
Yes, sir.
That's because we are lazy. You like working. So.
Yeah.
No, that's because you've got fantastic, assistants. That is why I still have to make one.
You are being very, very humble now.
No. Wonderful demonstration by Dr. Sangeeta, sir. Excellent. I really enjoyed it. Last year also, she's the same person who did it, right? Last year also.
That's right. I can't keep on getting new assistants. And she's not an assistant. She's a consultant in her own right. So I say that it was an assistant, but she's a consultant in her own right. She was a associate professor at KEM for many years.
And in fact, Janki, I am just like you. I don't have any assistants. I have only colleagues.
Sir, we are proud to call ourselves assistants, sir.
Yeah.
If you ask Dr. Sangeeta or Dr. Ramin, they'll be proud to say I am assistant because, being an assistant of such a big person itself is a big thing.
Now they are no longer assistant, they're chaperone. When I'm operating, they make sure that I don't miss up.
Sir, I heard you have to leave at 7:30, no, sir?
I have, my cardiologist is having his 60th birthday, so he was
yeah.
attend. So it's not 7:30. I can wait a little longer. I was deciding to cancel that trip because I thought that Dr. Jankiram is coming here, but I had the privilege of meeting his son. Is
Thank
just
you, sir.
good. I don't know which of the two is more handsome.
Oh my God. Sir, actually,
Obviously, Janki is second.
Yeah, I prefer to be second.
Yes, in Sanskrit they say, no? Putrat ichet parabhavam.
Putrat ichet.
It is, always better to lose to your son.
Yes. Very, very, very true.
Yeah.
So there are.
And you, Dr. Deepak ji, you have a meeting after this, immediately after this, right? You have
Renuka Bradu madam has called me, na? Renuka Bradu madam has called me, so.
But I think that should have started at 6 o'clock, no?
7.
7 o'clock, okay.
Suction. Huh? Enuma? Enante? Oh.
So, sir, there is a question regarding what is the line of management for caudal dislocation of septum or the tips for correction of caudal dislocation?
I think we'll.
Naveen, can you take that question?
But endoscopically, one punch.
In case of caudal dislocation, what we do is we elevate like this, and then we create a reverse pocket. We start elevating backwards. And then we resect a small portion of the anterior buccal portion, or we score, and then we suture. There's a definite indication to suture.
I can't make third answer, madam. 40 degree blade, na? One node Vishwa. Debrider. Sponge. Keep it ready. I think another 10 minutes and we are through, sir.
Okay.
Sir?
Okay, sir.
Hello.
So there is one more question, Doctor.
Deepak will wait for 10 minutes. Otherwise, we have to go ahead with a little felicitation function here.
No. So go ahead, sir.
So we can keep the video playing and we can have on. Okay.
Yeah, sir. Please go ahead with the felicitation.
Okay.
Because we have shown on one side anyway.
Yeah.
I think please go ahead. I think you have been magnanimous staying along even with a function where you have to go. I can't ask for more.
Yeah, but I also like being with you guys. Know what to do.
Sir.
Janki is my favorite.
So nice, sir.
I'm waiting for the day I can have a badminton match with him.
Yeah. I've asked Dr. Sirish Gunn to come here this weekend, and we are playing a match.
Okay. Is he coming by flight or is he cycling down?
He may cycle down also.
70 degrees. Janki, I'll just take a look at the frontal recess.
Yeah.
And then I think we can put us on mute and go ahead with the felicitation, Janki. I think we should not hold sir back.
Yeah. Sun Pharma, are you planning to transmit the felicitation function or how is it? Dinesh?
Sorry, sir.
Are you going to transmit the felicitation function?
Transmit because it's on. This is on.
70 degrees.
Camera is on, so we can transmit.
Please transmit.
Oh.
Yeah.
And Janki, since you mentioned Dr. Shirish Gunn, I think in your next Elite ENT Club function, we should have him demonstrate.
Yes. We should have. Yeah.
He was telling me he's done now more than 500 cases. Yeah.
Oh, okay. Wow, wonderful.
Yeah, Janki?
Yeah, sir. Fantastic.
Absolutely. So, again, a small frontal.
Yeah.
Lateral drainage. I think you can go ahead with the function, Janki. Let's not.
Sir, thank you very much. It was a brilliant demonstration, sir. Brilliant demonstration.
Thank you. Thank you.
Am I here?
Give rider.
Yeah. So would like to have this last question. Christopher wanted to understand anyone using septal splint or the septoplasty splint after septoplasty.
My friend Harihara Murthy is using it. He's now, I think, I think he's gone on the world tour, I think, but we don't use. I think Dr. V. Anand uses it in Coimbatore.
Very well, sir. Thank you so much. Thank you so much, sir.
Yeah.
Thank you, Dr. Deepak Ji. Fantastic demonstration.
Thank you. Thank you very much.
We should give a big hand for him.
Thank you. Thank you. Thank you, Janki.
Excellent demonstration, sir.
I remain relevant as long as I'm in your event in some capacity or other.
You're always there, sir.
Yeah.
Janki sir, please stay here online. Our request is to. And
yeah, sure.
For those who are going out now, just wait a few minutes. Let's finish the felicitation function. Till then, they won't be opening the tea counter.
Mohan sir, you can make arrangements. Mohan sir.
Sir, right now, Mohan sir, I don't think he's around, even online.
No, he just called me.
So should I tell the
team? You can start.
Sure. So with your permission, I'll be taking this opportunity to invite our cluster head, Mr. Salil Pandey, to just give a brief about Sun Pharma perspective to the forum.
What is the name? Take it. Take it. Anyway, I will just. I think several. No. Okay. Good evening, everybody. Yeah, okay. People are not there. I take this opportunity to convey, on behalf of Sun Pharma, convey my sincere thanks to Royal Pal Institute. And on behalf of Royal Pal Institute, I convey my sincere thanks to all the dignitaries, and particularly the course director. I would like to say Kirtane sir is not there. Kirtane sir as well as Janki Raman sir. In the meantime, at the same time, we have the host of and the plethora of, I would say, all big dignitaries who have made it possible today for a very engaging and I would say very insightful live surgeries that we have seen today. And one more day to go.
one thing I would like to definitely put it on record here. It was my first experience being into this therapy area. And on behalf of Sun Pharma, I can say it was a enriching experience for me from my side. So I once again convey my sincere thanks to all the dignitaries, all the attendees who have made it possible and made this program. And not only today, as far as what we can see here in Bombay, I'm very delighted to share with all of you, as been briefed by my team, that close to 3,000 plus delegates who have been able to attend online in close to 60 plus centers across the country. So big round of thanks to everybody for making it possible. And this is all possible because of the kind of content. See, all depends. Today, I was just sharing with you of my first interaction that as far as the profile in terms of the lecture series is concerned, in terms of the content of the text is concerned, everybody, all the senior clinicians, you all know. But nothing can be better than what we see when it's a live surgery. And there is a lot of interaction and lot of insight which can draw out of this in our clinical practice. So that's a great experience for me as well, for being a beginner, for the first timer. But I must be saying that this is the second year from Sun Pharma initiative to bring to you, all of us, the platform, creating a platform, and all the top dignitaries across the country have come under one umbrella and have been able to get such an engaging program throughout the day, which is going to be there for tomorrow also. Now we'd like, before I take a little longer, I would like to call on stage I would request Dr. Archana to please felicitate and call on the dignitaries who will be a part of the felicitation program today, and then we'll carry on till tomorrow. Thank you so much.
Thank you so much. So I request Kirtane sir to just have a brief word about the program, and simultaneously I will be requesting the other experts to come on stage.
I think she made it very clear. Brief word. No, I think as I would echo the sentiments just now expressed, that it's been really fascinating watching the surgeries, and next to doing the surgery yourself, I think in a workshop, watching live surgery is the excitement, in the sense it's not just lectures, it's not recorded videos. You never know how things are going to go. So, and I think today what we saw was demonstration of excellence by all the people who operated today. It's absolutely fantastic. And believe me, tomorrow we're going to have the same, if not better. We have Dr. Nupur Nerurkar who will be operating tomorrow, and Dr. Jankiram. Anybody else? Only two of them. So you're in for a treat. I mean, if you think you enjoyed today, tomorrow would be even better. So do make it a point to come and attend tomorrow. Thank you. Okay.
Sir, thank you so much, sir. Please have a seat, please. I request Nupur madam to please join sir on the dais. I request Sangeeta madam, if she has arrived. I request Dr. Satyanarayanan sir, Janki sir, you will like to say a few words by the time the replica of yours will join the stage?
I first of all thank Sun Pharma for this endeavor, and this is the second program which we are doing, the Elite ENT Club. And as I told, it is not only the demonstrators who are elite, but also each member who actually attended this conference is an elite member. So I am really thankful to Sun Pharma for this wonderful academic treat. And they have done it so professionally and absolutely, unparalleled academics. We started off with Professor Mohan Kameshwaran, and then we had Dr. Vijendra sir, and then Professor Padma Shri Milind V. Kirtane sir, my teacher. Then we had Dr. Deepak Haldipur. All the four demonstrated varieties of cases. And I'm sure that every participant, every elite member who attended today would have been very happy, had a lot of experience and a lot of carry home points. I'm sure that this will be remembered for years to come. And I thank individually all centers. There are so many moderators who call me from Dr. Anthony from Chennai, Dr. Nageshwar Rao Garu from Visakhapatnam. So many people call me from various centers. There are around 80 centers, I think, I'm not sure. And also medical colleges. So many medical colleges, they're all sitting there and watching. I'm so happy that, today on the click of a button, we are able to learn. We used to go to conferences in person, not able to pay money for registration. Registrations are very costly now. Hotel accommodation is costly, but now on the click of a button, we sit back at home and we are able to see a Mondini dysplasia being operated, and we know what is the impedance and what is the final result of the implant with a C-arm. Absolutely incredible, believe me. This is how science has to progress. We by giving, we actually gain. God gives us when we give. I think the best way, even better than a doctor. I always say, if I would be like to be called someone, then I would be better called as a teacher than as a doctor. And I learned it from my professor, Professor Kirtane sir, who always believed in teaching. And thank you very much, sir, actually, for being there for us. You are the pillar of support for us. And without you, I think no program would be complete. Thank you very much. These are the few words which I wanted to say from my heart, actually. And my journey with him started from 1998, and it's still going strong. 2023, and we will have another 25, 30 years of interaction. Thank you, sir.
Thank you, sir. Thank you, sir. Now I request AOI President Dr. Amit Seth, please be on the dais. Welcome, sir. AOI Secretary Dr. Rahul Modi, please welcome. And AOI Trustee Dr. Makrand Damle. Dr. Makrand. Okay.
He is on the way.
Right.
Sorry.
Request to Dr. Satyanarayanan to please join the stage. At this tender age, he is already a faculty. It's really proud to see him here. So we'll take this opportunity to just have our token of appreciation for the experts and solvers here. So I request our BU head, Mr. Amit Shukla, to felicitate Kirtane sir, please. Sequencing.
Thank you. Now I request our BU head, Mr. Sundar Rajan, to felicitate Dr. Nupur.
I request our BU head, Mr. Ambrish Sahai, to felicitate Sangeeta Madam. For Janki sir, on behalf of Dr. Janki sir, Union for Shukla sir.
So on behalf of Dr. Janki sir, I request Amit Shukla to give the felicitation to Dr. Satyanarayan.
Janki sir, we are missing you here.
Sorry.
I request Mr. Sundarajan to felicitate for Dr. Mohan Kameshwaran sir. I request Dr. Panali Appan to accept the token of appreciation, please. And I request Mr. Ambrish Sahai to please felicitate Dr. Deepak. I request Dr. Kusum to please accept the token of appreciation for Deepak sir. I request Kitane sir to felicitate actually a token of appreciation for Dr. Amit Seth sir.
AOI President Dr. Amit Seth.
Thank you, AOI team. Without your support, it was not possible. Thank you, all of you, for the patient support and for this scientific program. Everyone has contributed so significantly, and at Sun Pharma, it's our honor to associate with AOI and all the experts and solvers here. Thank you, sir. Two more, sir. Two. So I request sir to felicitate AOI Secretary Dr. Rahul Modi. So request to felicitate Managing Trustee AOI, Dr. Makaran Damle, please. I hope sir has arrived. Still on the way. Okay, we can take him at the end. So there are 18 panelists, and it is always an honor to be in frame with you. So I will like to bother you and madam, all of you, to honor the 18 panelists today. Because I'm making you getting up. Thank you so much, sir. Thank you so much. I request Dr. Vijay to please take over the panelist felicitation. Please.
Yeah. So I request Dr. Debabrata Panigrahi to please be on a dais. And I request Kirtane sir to felicitate. Yeah. Dr. Ratnesh Kumar, are you there? Dr.
Modwani sir has, I think, left for today early. So Dr. Abhineet Lal. Dr. Abhineet Lal, please. Please come towards the dais. Dr. Adip Shetty, please. Dr. Kusum Patidar. Madam, please come forward. Dr. Ritam Roy, sir. Dr. Rajesh Padhi, sir.
I request, Nupur ma'am to please felicitate Dr. Kusum.
Sorry.
I request Sangeeta ma'am to please felicitate Dr. Ritim Roy. Dr. Rajesh Padi. I request Nupur ma'am to please felicitate Dr. Rajesh Padi. So we will be felicitating the panelist, the tomorrow's panelist as well. So I request Dr. Debabjyoti Mukhopadhyay will be there with us for tomorrow's session. So we'll be felicitating today only. So I request Nupur ma'am to felicitate Dr. Mukhopadhyay. Dr. Mukhopadhyay. Dr. Amit Bhandari. I request Dr. Amit Bhandari to please be on a dais. Dr. Rupak Kumar Goswami. Dr. Prashant Kumar Gure. Dr. Rahul Garg. Yeah. I request Sangeeta ma'am to please felicitate Dr. Garg. Dr. Prasad Kelkar. Dr. Amol Patil. Dr. Gaurav Bamba. I request Nupur ma'am to please felicitate. Ma'am. Yeah. And I request Dr. Vikram Khanna to please be on the dais. I request Kirtanesh sir to please felicitate Dr. Khanna. Dr. Khanna.
With this, I'm declaring we are closing for today. Just a minute. Just a minute. For Dr. Makarand Damle, I request any of the AY faculty here. Okay. Yes. I request Kirtanesh sir to please hand it over as a felicitation to for Dr. Damle. Thank you so much. Thank you so much, sir. Thank you, madam. And thank you all the experts and the delegates here. With this, I will like to close for today. And we will love to see you at around 8:55 tomorrow, because madam will be starting sharp at 9. Right, ma'am? Thank you so much. And your presence and your support was and will be very valuable to all of us. I request Kirtane sir to have few words, please.
No, tomorrow's breakfast starts at 7:30 but stops at 8:55.
I just want to add a few words.
Sure, sir.
Hello, are you hearing me?
Yes, sir, we can hear you.
Just want to know what Professor Nupur Kapoor madam is going to operate tomorrow, so that it'll be exciting to know what she's going to operate, so that they'll be ready exactly at 9 o'clock.
Hi, Janke. I hope you're feeling better.
Slightly, madam.
We're all
Still.
excited to see you in action tomorrow.
Thank you, ma'am.
I'll tell you what I'm doing tomorrow, but just wanted to mention that we are indeed fortunate that we belong to an era where Dr. Kirtane is a teacher.
Exactly.
I think we're really fortunate in ENT. And tomorrow my plan is to do a simple case, which is a vocal fold polyp with a contact lesion. I was given a feedback for last year that because the patient was already intubated and the scope had been put in position, many of the delegates felt that they would have very much preferred if it had been shown right from the beginning. So, description of the instruments, description of intubation, patient position, putting the scope in case of a challenging laryngeal exposure, what to do. So I plan to go very slow and from A to Z. So, and I hope to get lots of questions and keep it as interactive as possible.
So I think the reason why I asked Professor Nupur to talk about it, because I don't want anybody to miss out on the initial, discussion which Professor Nupur is going to make. So I request all the participants who are online, offline, and who are sitting in various centers to be there exactly at 9 o'clock. I think we're going to have a very interesting session with Dr. Nupur, madam.
Thank you.
And hope to see you tomorrow, ma'am.
Thank you.
Thank you so much. Thank you so much, sir. Thank you, ma'am. So with this, I declare officially for today, we are closing the treat, and we will be happy to open it again at 9 o'clock for the online participants and all the participants who are here. And for the experts who have joined us here at the venue, request to please move for the gala dinner, which is just next to the hall. Thank you so much. Have a wonderful time.